in the close vicinity. Now, when to plan for delivery, there are two schools of thought which actually says that what are the considerations when you look at. Before 39 weeks, definitely if somebody has got past history of IUD, you already have a macrosomia, maybe more than 4,000 grams. Somebody who cannot reach you close by, maybe a decreased movements felt or membrane rupture, all those things, if they are located 2 hours, 4 hours away from the hospitals, you would try and deliver them early rather than keep on waiting for 40 weeks. Obviously, for glycemic related, if there are uncontrolled diabetes, any other complications, you should consider delivering them early. Keep them good till about almost 40. If there is no obstetric complication, things are going smoothly, growth parameters are normal, well-controlled diabetes, even with the tablets or maybe a diet. Insulin-treated patients generally are not kept till the term. Okay. What do guidelines recommend about when to deliver? Can anybody read on this slide? So guidelines are also not clear. Nevertheless, the ACOG, it only tells that diet management up to 40 weeks you can wait. For somebody who is using drugs, 39 to 40, and you should definitely go for cesarean if your fetal weight is more than 4.5. Nice guidelines were actually nice. They just said deliver before 40 weeks. You don't have to bother about the diet, you don't have to bother about what sort of medication, but it is just giving a blanket statement that before 40. FIGO again looks at induction more than, if the estimated fetal weight is more than 3,800, and maybe with good control you can wait till 40. So by and large the consensus is you can wait till about 40 if everything is good, otherwise early. Key considerations in the labor, mostly the mothers are kept actually nilparvolar at that time. So it is important to look at their glucose, look at their insulin, what they have been used previously. Okay. Glucose turnover increases because the insulin levels comes down, or the activity, the muscular activity increases. So you are actually utilizing more glucose without the help of an insulin at that point of time. When to stop oral feed, when to continue oral feed, again some of the prolonged labor issues, or when you are converting an observant mother from labor, taking up for an emergency LSES, all those things are important. And insulin requirement drops drastically the moment you deliver the placenta. So again you look at, be vigilant about the hypos at that point of time. Most of the guidelines agree that you should keep a target of 70 to 120 throughout the labor period. If you are planning for a C-section, preferable for any diabetic mother to be first case of the day. You should omit the nighttime insulin in all GDM patients. Okay, reduce it by 50% in pre-gestational diabetes, because most of the gestational diabetes, you don't require that much support, especially beyond 36 weeks. And if you are taking up in the morning, you deliver early, so that longer acting insulin is going to further act almost to 24 hours. So it is always better to stop the previous night. Neutralizing drip in some, when you have a prolonged issue where you give some amount of insulin along with the 5% dextrose to control both glucose level as well as the insulin, especially mostly applicable in some type 2s. Type 1, we don't do this because we want them to be separate infusions. I'll come to that later. Avoid hyperglycemia, especially in that setting, because the moment you have hyperglycemia, more insulin is released, more glucose gets across to the neonate who releases more, and the moment the fetus is out, the neonate, there is higher insulin in that spectrum, you have more chances of neonatal hypos at that point of time. So preferable to stick to a range of 70 to 120, and beware of the long-acting insulin, which may cause hypos unexplained in the post-surgical period, where you are actually other things to handle, but glucose is neglected often at that point of time. If you have to induce the labor, again preferably first case in the morning, all diabetic mothers. The night dose by and large is taken normal. You have a early breakfast, you have a light breakfast, and you may have to give a 50% reduced dose of the prandial insulin of that particular day. And prolonged labor, if you are keeping them nilorally and glucose requirements are there, you parallelly start the glucose infusion. And if there is a hyperglycemia, you start insulin infusion if GRBS is more than 140. Now, when you give glucose, it is by and large 10% dextrose infusion. The boluses are given 50 ml per hour and continuous infusion, which is continuously given. Potassium is generally not added. Potassium is only added if you have a baseline hypokalemia or if the duration of action is beyond 10 hours. If you at any point of time during monitoring documented a low blood sugar, you have to give a bolus dosages of the same thing. Insulin infusion, again, you give mix 50 units of insulin, regular insulin with in a 50 ml infusion pump. 1 ml per hour will be the infusion rate, and different protocols exist. I'll show you one, but generally you have to check hourly glucose, and if it is less than 120, you may not have to give any insulin infusion, but more than between 120 to 140, 1 ml per hour, and beyond 140, 2 ml per hour is general recommendation. If the expected drop is more by 50%, you may have to down titrate the infusion. One of the protocol from the University of Northwestern Hospital, most of this is managed by the nurse practitioners who have a set pattern as to document the glucose, adjust the rate accordingly. So if you have a checklist sort of thing functioning, it is easy to handle. You can see how you are changing and what is the glucose values which you are managing at the other end. Okay. Some individual considerations depending on what type of diabetes you are dealing with. Gestational diabetes, by and large the targets remain same between gestational, pre-gestational diabetes. As I said, omit the basal insulin, and most of the times gestationals don't require insulin during labor. So don't give unless your sugars cross 140, 150, because they're more prone for hypos at that point of time. Type 2 who have been using metformin, you have to reduce your basal by 50%, and you have to give glucose insulin infusion separately if required. Monitoring can be a bit less because these are young type 2s, so their insulin reserves are fairly okay, so you may not have to have more close monitoring. Most problematic are the type 1s who are actually young and who don't have any insulin in their system. They are more prone for ketosis at that point of time. These are the people, it is mandatory to have a glucose infusion separate and a insulin infusion separate, so that you can adjust both parallelly, and don't stop the infusion forever in type 1 till they start their oral, till a subcutaneous insulin is on board, because they are obviously without insulin they will go into ketosis. So you require to continue the insulin infusion in all type 1s. How to look after the newborn. Glucose more than 48 is considered as normal. Immediate and 2 hourly checking is required, and preferable to feed within 30 minutes. Depending on the echo, depending on the assessment prior hand or the complications, you may have to look at magnesium, calcium and other things, and a echo if required, or if there is a suspected cardiac malformation. At least 24-hour observation for all gestational diabetics and their newborns before you discharge is mandatory. Don't be in a hurry to discharge even if it's a normal delivery. Post-delivery breastfeeding is mandatory, there is no doubt about it. Some of the ladies still have, may not be from this part of the world, but most of the patients do have the fear that they may transmit the diabetes to the baby. So educate, it is our job to educate them that they will actually prevent the risk of diabetes rather than transmit the diabetes. So it is important to educate. There are some studies to say that lactation improves the glycemic control as well as the benefits for the offspring also. Long-term risk education is important, and babies born to mothers with a GDM have a higher risk of metabolic disorders in future, important to understand. And any method of contraception, GDM, history of GDM is not a contraindication for a OCP. So whatever the patient is comfortable, educate about the contraception as well. How to follow up? Most of the guidelines say that you should do a OGTT at 6 weeks. OGTT doing at 6 weeks is actually a very difficult thing to do. So some of the NICE or other people have said fasting, or some have said even A1C. At least will give you some clue as to what you are likely to have. Obviously, the mothers have a higher risk of type 2 DM in future, almost 5% per year, and a recurrent gestational diabetes, again a higher risk. So you should educate about the lifestyle, weight, and possibly some of the guidelines now start accepting or giving metformin in this pre-diabetes phase for an expectant mother. So last slide. Mother with diabetes is ideally delivered before 40 weeks, there is no doubt about it. Differences between the only diet controlled and some medication related GDMs are important. Maybe 40 or 38 should be the ideal one. GDM per se is not an indication for cesarean. It is definitely an obstetric indication depending on whatever is the pregnancy. Just because somebody has diabetes, nobody is taken up for surgery. And beware of the physiological changes at that point of time. Be more dynamic. Frequent checking is the only way which will help you, and possibly having the two different infusions also will help you. And adequate preparation is important, and this is a time where the ladies are more receptive, so educate about the long-term risk and the implications of having a diabetes. I have finished here.
Thank you, Dr. Hari Kumar. That was indeed a very elaborate and detailed discussion on management of GDM and pre-GDM in labor and postpartum. We'll take the questions at the end of the session, Doctor. Our next speaker is Dr. Anish Ghosh, who is going to talk on CGM in pregnancy, evidence-based and practical usage. Dr. Hari Kumar is a consultant.
Hari Kumar is sitting there.
Dr. Anish Ghosh, yes. He is the head of endocrinology at Trivandrum, director and consultant, Center for Obesity, Diabetes and Endocrine Sciences, Trivandrum. And he's presented, slides please.
Slide. Where is the point?
Original work in annual conferences of IDF, International Diabetes Federation, American Thyroid Association, Endocrine Society, US Endo, and American Association of Clinical Endocrinologists. He's authored a book titled Living with Diabetes, A Complete Wellness Guide, having several publications to his credit. So over to you.
Thank you, ma'am, for the kind introduction, and my regards to Magna Code and the organizer, Dr. Anantharaman. Next 15 minutes, I would discuss relevant sections of the allotted topic. This is the overview of my discussion. If you look at the National Consensus Report 2018 on pregnancy in diabetes in pregnancy, it has thrown up some of the questions, because you look at the update, it says that over the last 5 years, nothing has changed. As far as dealing with the risk of pregnancy is concerned, we could not move an inch. So that is a huge task or a huge question. So in that background, I have framed a question, and through my talk, I would try and answer this question. That is, could CGM help bring about the change suggested in order to improve outcomes in pregnancy? I think all the time that I'm going to spend in the next 15 minutes or so, I'm going to try and sort out and try and get an answer for this question. But if you scourge through the literature, we have ample evidence that if you put in effort and bring sugar in the normal range in pregnancy, obviously it will be hugely rewarded, not only to the mother but also to the neonate. And often what we miss out completely in our dealings when we manage pregnancy is the glucose variability. If you, let me just introduce J index. Actually, it is a measure of glucose that incorporates mean and standard deviation of glucose. So, in fact, J index comprehensively capture every dynamics of glucose levels in a given lady. So, naturally, you look at the illustrations on your right hand side, you see that the upper graph, the J index is lesser, and in the lower graph, the J index is rather high. So, in the upper graph, the mean glucose levels are low, and in the lower graph, the mean glucose levels are high. So, does that make any sense? Yes, indeed, because higher the J index, higher would be the risk of large for gestational age babies, higher would be the risk of asymmetrical fetal growth. And also, if you analyze carefully, this HbA1c is not an accurate predictor of prevailing glucose levels. And HbA1c has its own fallacies when we apply it in pregnancy. I'm not going into the details, but we all know that. But there are calls from different quarters to replace or substitute HbA1c with different CGM metrics. Like, you have time in range, you can also calculate the mean glucose levels. Because it makes sense. Because the average or the mean glucose levels derived from CGM metrics is far more an accurate representation in a given case than the average glucose levels which you get from HbA1c. Also, if you take the time in range into consideration, time in range often can give you valuable inputs which helps you to minimize the risk of hyperglycemias, hypoglycemias, and glucose variability. So, essentially, if you use CGMS, it opens up a new vista and give you more inputs for better management of glycemia in pregnancy complicated by diabetes mellitus. This is international consensus recommendations, quite clear on the use and targets of CGM during pregnancy, and in fact, the consensus panel concluded that using the time in range as a metric in addition to HbA1c during pregnancy would give you more actionable input where you can take better actions in comparison to the situation where you are using only the standard of care. So what is the time in range in pregnancy? It is 64 to 140 milligrams. I think that is the glucose range that you should be targeting. And in type 1 diabetes mellitus, the time in range should be around 70%. In type 2 and GDM, you should try and keep the time in range more than 90%. And either case, you should try and keep the hypo or time below range less than 4%. I think this is the recommendation. So, to quantify whether it is in time in range, time outside range, time above range, below range, can you do it with SMPG and HbA1c? No. You need to have a mechanism wherein you can quantify the above range, below range, in range, etc. For that, I think we have right now only have CGM as tool, a useful tool to quantify these parameters. This is the compendium of data published where CGM is used in type 1 diabetes mellitus. Most of these cases or in these studies, CGM was used as an adjunct to the standard of care and put together this available data, in fact, press for a compelling reason for us to use CGM as an aid apart from standards of care because of the additional benefits that we are going to get. For example, if you look at Murphy and et al. Trial where 71 women were studied, most of them were having type 1 diabetes mellitus. And you see that with the usage of CGM, the mean HbA1c could be reduced significantly in the second half of the pregnancy. also there is significant risk reduction in terms of macrosomia. But many trials, the data as such is heterogeneous because some trials did not reproduce results in the same line. But the magnum opus trial in this segment is Concept 2017, which was a multi-centric randomized blinded trial, 12 months, examined the utility or explored the possibilities of CGM in maternal glucose control, obstetrics and neonatal outcomes. There were 325 women participated in this study. And what were the results? There was a significant, even though it was small, reduction in HbA1c, mean HbA1c to the tune of 0.2%. And the icing in the cake is, look at the improvement in time in range from 68% against 61%. That has taken place without increasing the time below range or without increasing the risk of severe hypoglycemic episodes. So the study concluded that every 5% increase in time in range, there is significant improvement in the composite of neonatal outcomes. So even 5% improvement in time in range does matter. There is also significant reduction in the risk of large for gestational age babies, significant risk reduction in neonatal hypoglycemias. There is 1 day lesser need for hospitalization post-delivery. There is reduction in risk of neonatal intensive care unit admissions. But what about economy? Because I think use of these gadgets will jack up the cost of management of pregnancy. But here again, there is a financial model proposed by the Concept Collegium, and it has predicted that indeed CGM usage can save cost because you look at the fraction of expenditure put under different heads. You see there is a huge difference in the column of the gray columns, because that gray column represents the need for NICU admission. So by using CGM, according to the financial model proposed by the collaborators, there is significant reduction in the need for NICU admissions. Henceforth, you can save money in that regard. That is the compendium of data of usage of CGM in gestational diabetes mellitus. Again, let me just give you some details of the Yu et al. Trial, which was conducted in 345 women with gestational diabetes. Again, here the CGM use was blinded, and the study came out with some wonderful results. There is maternal benefit, preeclampsia, fetal benefits ranging from reduction in small for gestational age babies, large for gestational age babies, reduction in obstetric trauma, reduction in small for gestational age babies, reduction in neonatal hypoglycemia, hyperbilirubinemia, etc., etc. So huge benefits. But here again, the data is heterogeneous. The Close-in-Heel Wei et al. Had published his data, which did not get results in the same line. In fact, it was ambiguous. So you can't make tall claims if you study through this available data, because data is quite kind of heterogeneous. This is Swedish data, again suggesting that with where women who have used CGM was pitted against women who received only standard of care, and they found that with increasing gestational age, there is a clear-cut improvement in glycemic control by all means, and also glycemic control in terms of mean glucose levels and time above range and time below range were closely associated with outcomes like large for gestational age babies or composite of neonatal outcomes. So indeed, glucose control is hugely rewarding if you can quantify these parameters and act accordingly. Now, this is additional data to suggest that use of CGM can bring down the mean HbA1c levels in the later half of pregnancy and also reduce the risk of macrosomia. Now, the second part of my talk, that is the practical usage, let me introduce you to this real life case I have managed 5 years ago. I was in the team. So this is a 29-year-old IT professional having type 1 diabetes for 11 years. She was managing all this while her diabetes with multiple injections, subcutaneous injections and home glucose readings. And she was reported at 12 weeks of gestation because she had poor obstetric history, because last 2 of her pregnancies ended up in abortions. So she was admitted for introduction of pump therapy and also to put her on real-time CGM and also to give her assistance and support. She was weighing 71 kilos and her HbA1c at the time of reporting was 7.1%. And this was her baseline CGM. Look at her baseline CGM. You see her sugar all over the place. You don't want to see this happening in a pregnant woman, isn't it? So you see, this is if you look at the J index, it is quite high because the glucose variability is quite high. The sugar levels are hopping all over the place. So we put our heads together, and she underwent counseling education. She was introduced to carbohydrate counting exchange, and in addition to SMPG, she was put on real-time glucose, continuous glucose monitoring, and the pump, of course, was introduced. She was proactively managed. As far as her basal insulin requirement is concerned, bolus was based on her carbohydrate counting. Correction bolus was given on as and when needed basis. She received psychosocial support. Her spouse and her parents received counseling. She was kept in for 3 weeks. So 3 weeks is the intervention that we have applied, but we did everything what is possible, and look at the results. So this is the pre-intervention CGMS, and that is the post-intervention CGMS. See how much, to what extent could you influence her glucose dynamics for the betterment of the mother and pregnancy. You know why? Because you have additional data at your disposal. You have more information, actionable information. That is what is more important. So the more actionable information you have, the more you act. So the better would be the outcome. So post-intervention, so she delivered at 38 weeks, birth weight was 3.6, no untoward neonatal incidences, and she was discharged day 4. So the highlights of this case is CGM enables actions to adjust for glucose in real, and improvement in neonatal outcome detects more maternal hypos and hyperglycemias and fluctuations, and the CGM identifies nocturnal hypoglycemia and postprandial hypoglycemias. To conclude, ladies and gentlemen, CGM provides a powerful new tool that promises to help us achieve goals of improved outcomes by various ways, because CGM, as I said, derived mean glucose levels may be more accurate than HbA1c, and time in range is hugely, I think the potentials are still to be explored. We need more mechanisms to utilize CGMs and its scope and take the treatment to altogether different planes, and improvement in patient and provider's experience, that is more important. CGM provides far more data and therefore more opportunities to improve glucose control. That is also there. Enhanced ability to deliver care remotely, because now most of the manufacturers have come out with their own software, so CGM can be put in remote places where access to healthcare is minimal, and the data can be retrieved and it can be sent to a central software processor where it is analyzed, and the report can be delivered back to the healthcare provider in no time. I think that is one area which I think we need to explore more, and more changes are needed to optimize outcomes. That is because even now 50% of pregnancies complicated by type 1 diabetes ended up in large for gestational age babies. So we need more work, we need more action. And prognostic tool is, of course, because CGM can risk stratify pregnancies by different mechanisms, and also can pinpoint pregnancies where intensive glucose control would be the most beneficial, like the case which I was referring to. Thank you so much.
Thank you, Dr. Anish sir, and it was a different perspective and nice deliberation. I invite next speaker, Dr. Shanmugasundaram, for self-blood glucose monitoring in GDM. Dr. Shanmugasundaram is a consultant endocrinologist at Chennai unit and is invited faculty for several national and international conferences, and had a MGR University Award for topping anatomy best going student award, and presented more than 800 scientific forums and published 20 articles in prestigious journals and contributed chapters. We welcome you, sir.
Thank you, sir. Thanks for the kind introduction. So the topic given to me is self-monitoring of blood glucose in GDM. So how to ensure quality and reliability. So I will divide my talk into two parts. One is the glucose monitoring in gestational diabetes mellitus or diabetes complicating pregnancy, why it's important, so what are the targets and how frequently we need to do. And second part of my talk is regarding the glucometers. So how accurate the glucometer value should be, so what is the essential parts of the glucometer or glucose strips, or what are the potential errors while doing the SMBG's values, I will be discussing. So why blood glucose testing is very important. It is a very, very essential tool for people with diabetes, particularly type 1 gestational diabetes patients and people who are taking insulin or people who are having a fluctuating blood glucose. It's very, very essential. For the patient, it helps in knowing whether the values are too high or too low or it's a normal, and it also helps in managing their lifestyle according to the fluctuation in the blood glucose after exercise or after food. For our healthcare professional, it's essential because based on the values, we can start the medication or change the medication, and also we know how effective medications we are giving, how they are responding. So from the both patient perspective and physician perspective, it's very important. So what are the targets in gestational diabetes? So the fasting and preprandial blood glucose should be less than 95, and 1 hour should be less than 140 mg per deciliter, and 2 hours less than 120 mg per deciliter. For diabetes complicating pregnancy, slightly different, so I'm not going to detail in that. So in that, the preprandial should be between 70 to 110, and the postprandial should be less than 2 hours should be less than 110 to 140, and 2 hours should be less than 120. So how frequently we need to test? So in gestational diabetic patients, initially on nutritional therapy or the people who are taking insulin, always better to do at least 4 points per day, that is before breakfast, and at 1 hour or 2 hours after the beginning of each meal. So 1 hour postprandial measurement is preferable because it closely mimics the insulin peak after giving the rapid acting analog, insulin analogs. So it's always better to measure 1 hour. And we should know that if it's 1 hour, then the target is 120. If it's a 2 hour postprandial, it's 140. Or if it's 1.5 hours, it's 130. And all the results should be recorded in the glucose log along with the dietary information. Why postprandial monitoring is preferred compared to the preprandial? Because most of the studies have shown that postprandial monitoring and control of postprandial glucose levels compared to preprandial monitoring leads to better glycemic management, HbA1c 6.5 versus 8.1, and lower incidence of large for gestational age newborns, 12 versus 42, so almost 1/4 reduction in the events, and lower rate of LSCS birth for cephalopelvic disproportion, 12% versus 36%. So controlling postprandial glucose is very, very important. That's why in GDM, postprandial monitoring is preferred. And coming to the testing in diabetes complicating pregnancy, that is already pre-existing diabetes, there we advise for usually 7 points, because in this kind of patient, there will be large fluctuation in the blood glucose. So fasting and before each meal, and 1 or 2 hours after the first bite of each meal, so 6 times plus bedtime. And additional testing is indicated in selected patients like suspected nocturnal hypoglycemia. So again, glucose assessment between 2 to 4 a.m. we need to do if we suspect nocturnal hypoglycemia. It's always better to document hypoglycemia before initiating intervention. So inform the patient if they have symptoms, do the SMBG and then take some food. And CGM may also help in identify the nocturnal hypoglycemia. Dr. Anish has already discussed about that. And coming to pre-breakfast hyperglycemia, if the glucose assessment we are doing between 3 to 5 a.m. before the pre-breakfast, if it is consistently high, then we need to evaluate why it's high. So it may be due to inadequate insulin management, or the patient may be taking excess carbohydrate snack at the bedtime, or we are giving too low dose of, very, very low dose of basal insulin. If the patient is taking pre-mix, and if you increase the dose, there can be midnight hypoglycemia, and if you decrease the dose, the fasting pre-breakfast hyperglycemia can be there. So again, we need to modify the insulin regimen, etc. And it could be the dawn phenomenon because of the increased release of counter-regulatory hormones in the early morning. There can be pre-breakfast. So again, we need to adjust the insulin dose. And hypoglycemia again can happen at pre-breakfast level. So then we need to reduce the insulin dose or increase the carbohydrate snacks at the bedtime. And third thing is settings of increased situational risk for glucose derangement. That is before starting exercise or After having hypoglycemia, whether we need to document whether the patient has normoglycemia, or during the steroids, steroid therapy, etc., we need to monitor more frequently. Whether the frequency of self-monitoring can be reduced, particularly in people on nutritional therapy. They are not taking insulin, they are on nutritional therapy, whether we need to ask them to do 4 points testing daily. So what data has shown is there is no strong evidences for people only on nutritional therapy in patients with GDM. So data has shown that if the GDM is very mild, that is the glucose elevation is only within 5 to 10 milligram from the target range, and there is no signs of fetal overgrowth or increased estimated fetal weight, a normal amniotic fluid volume, doing alternate days testing or reducing the frequency improves the quality of life of the patient. And there is studies also in patients on GDM or nutritional therapy, if the values are within the range, they compared with the people who are doing daily SMBG versus alternate day SMBG, their birth weight and frequency of macrosomia are almost similar. So the frequency of testing in patients of nutritional therapy can be reduced, but if the patient is on insulin, it's better to follow the protein regimen. So coming to second part of my talk about the blood glucose meters. So mostly we don't discuss about this topic. So we all know that glucometer measures capillary blood glucose. So now all these glucometers are modified such that it gives the plasma equivalent values rather than the whole blood glucose values. So mostly available glucose meter and the venous plasma glucose method in the laboratory should be comparable. I will come to that in the later. And they should meet the standards compared with those set by the IOST, the International Organization for Standardization, or US FDA. So what are the variables? Again, I will discuss in the future slides. And many current glucometers are reasonably accurate, plus or minus 10%, and require a very small drop of blood. So what are the criteria for selecting the blood glucose meter? So there are various criteria. So accuracy. So we have two types of accuracy, analytical and clinical accuracy I will be discussing, and blood glucose meter and strip technologies, and design and features. What are the additional features the glucometer, if we have, it will make the life easy for the patient, and how these glucometers avoid the potential interfering substances. So last thing is obvious, availability in the market. So it should be easily available for the patient, and the strips should be easily available for the patient at reasonable cost. Those things mandatory. So coming to accuracy, again, it's very, very important. Accurate blood glucose monitoring are very, very important because it is essential for monitoring, and we are going to make changes based on the blood glucose values. So for safety purpose also, it's very, very important. So for reliable monitoring or making informed therapeutic decision, accuracy is very, very important. So we have two types of accuracy. One is the analytical accuracy. Analytical accuracy means how closely a blood glucose reading matches the true value. So the true value may be the already established method of testing, like measuring venous plasma glucose by the routine biochemistry testing, and they do the comparison along with the blood glucose values. So they do this random error, which tells about precision, systematic error about the bias, and other interferences like altitude, hematocrit, and galactose. So this first is analytical error. Second is the clinical accuracy. So this is again plotted in the POX consensus error grid. So if we are going to make a decision based on the blood glucose values, this should be in the A or B. So A or B means if we make a clinical judgment based on the reading, there should be no effect on the clinical action. And B is little or no effect on the clinical action. And the variability is very much C or D, it could have more effect, the wrong effect in the treatment. So the patient, we may treat the patient wrongly, and if it E means it can have a dangerous consequences. So always this clinical accuracy of the glucometer has to be in the A and B. So these are all things which will be done while manufacturing itself. They will analyze with the standard method of testing, and they come out with this, what is the analytical error and what is the clinical accuracy, etc. Then only they proceed with the marketing. So there are again guidelines for this, how this method should match with the standard error. So to be make it simple, mostly this FDA and ISO values are similar. If the blood glucose values is less than 100, the difference between the blood glucose meter range and the standard value should be plus or minus 15 milligram per deciliter. And if the blood glucose value is more than 100, then the difference should be less than 15%. So the FDA has told if they are able to do this plus or minus 15 milligram per deciliter less than 100 or more than 100, 15%, then it's almost 95% accurate. And if this same thing is around 20 milligram per deciliter less than 100 or more than 20% more than 100, then almost 99% accurate. But what most of the standard glucometer company, they do before releasing these batches, they target for 10%. That is less than 100 milligram, 10% difference from the standard method, and more than 100 milligram per deciliter, 10%, and less than 100 milligram, 10 milligram per deciliter difference. So they target for more stringent criteria, then only they release this one. But while in the market, at least they should follow this 15 milligram less than 100 for blood glucose less than 100 and 15% more than 100. So we can expect a difference of 15% between the lab value and the glucometer value. Many of our patients ask, so that's a difference between the glucometer value and this one. So you can explain them. If the values are more than 100, the difference can be up to 15%, it's acceptable. And the values are less than 100, it is plus or minus 15 milligram per deciliter. It's acceptable range. And most of this glucometer varies in the hematocrit, and most of the, again, newer glucometers or advanced glucometers have the adjustment for hematocrit between 10 to 65%. And also they should have this, should take care of these interferences like bilirubin, other interfering medications, etc. They should be taken care of. So coming to glucose strips, again, before we used to have this batch to batch variation and require calibration, coding, etc. But now things has changed. Most of the glucometers, there is no need for coding. But again, we need to explain to the patient, if the glucometer has to be coded for every batch, then it has to be done religiously. Otherwise, they will be getting wrong report. That has to be told. And nowadays, many strips are packed in groups. But errors are leaving the lid off for a period of time with exposure to heat, moisture, and humidity that can affect the value of the testing. Use of expired strip, and mixing the lot of different strips in one can for convenience, again that can influence the reading. And coding, if the patient forgets to do the coding, again it can have different values. And more fortunately, most of the newer glucometers have taken care of this potential errors. So now it's very, very convenient for the patient. They have to just insert and do the testing. And method, GDH based method is better than the glucose oxidase method. I'm not going to detail. So coming to blood glucose device, so there should be no coding. It should be very simple, accurate, and extensive safety checks should be there before releasing the product. And nowadays, again, they can see the patient can see the previous 7, 14, 30, 90 days testing average. Now even they are giving this time in target also based on the previous 2-3 months reading. The glucometers automatically is giving a time in range values also. And it should be very sleek and modern design, easy to handle. And the strips also, the size should be big, where they are going to keep the sample. It should be user friendly, and they should take minimal amount of blood for the capillary blood for the testing. So again, these are the small things, but it matters because elderly patients, if they are having difficulty in doing the test, if it's very convenient for the patient, it's easy for them. There are a lot of interferences, as I told, humidity, if they are keeping open, the temperatures, air, all those things can influence us. And hemodialysis, and particularly if the patient is on peritoneal dialysis, the presence of maltose can falsely give higher values of blood glucose values, so we should keep in mind. And the patient is taking vitamin C, acetaminophen, again those can also influences the blood glucose values. Hyperbilirubinemia, many glucometers, again bilirubin value can influence the blood glucose values, particularly in the patient's neonatal hyperbilirubinemia, we have to think about that. So the bilirubin value can interfere with the glucometer values. So these are the potential errors to summarize. So failure of used test strips appropriate to the meters. Again, one different brand they give me a strip they may be using for the different glucometer. Dirty meters, improper storage of the test strip, poor skin preparation. Again, after eating, taking some food, if the food particles are there, if they are not wiping out properly, again that can also lead to false readings. So proper skin preparation, and to avoid, we have to avoid expired strips, and we should always remember some interferences can be there, like acetaminophen, ascorbic acid, and all. If the patient is in ICU, dopamine infusion again can interfere with the blood glucose values. Oh, sorry, this slide is not so. What can be done? So it's always better, we can ask the patient to bring the glucometers to the clinic. So if there is a doubt, we can always cross check with the blood glucose meter what we have in our clinic, or with the standard blood glucose measuring method. And if the values are way out of the thing, then we can do calibration. So we can ask the company fellows to do the calibration. They will have the testing liquid for doing the calibration, so they can do the calibration. If the glucometer is not calibrated for quite some time, we can do the calibration. And every time we can ask the patient how they are doing the test, whether the strip method is what they are using, how they are using is good. And also we need to see that their glucometer log, whether they are maintaining it properly, rather than just asking them what was the reading 1 week back, 2 weeks back. It's always better to see the log and also see the glucometer, whether they have set the time, hours, and if they have not setting the time, hours correctly, again we can have a different reading, which are readings which are not matching with the what time they are doing. For example, fasting if they are doing, but the time is not set, then when we are seeing the glucometer, we may get a wrong information. So all these things we need to check. So always better to ask the patient to bring the blood glucose meter and verify it. So the summary, blood glucose monitoring is very, very essential for the patient's perspective also, physician perspective also. And presently available blood glucose monitoring are very much advanced, has less interferences, no coding required, and the accuracy is very good. So they usually target for very stringent accuracy, almost plus or minus 10 milligram per deciliter if more than 100, and 10% if it's less than 100. And operational errors are very common. Again, we need to discuss with the patient what they are doing and try to avoid these operational errors. And patient education is very, very important. Thank you.
Thank you, Dr. Shanmugasundaram, and it was a very nice and practical session. I request other two speakers also to be on the dais so that anybody who wishes to ask questions pertaining to the first session of the three speakers, we can ask. Any questions anybody wishes to ask? You can raise your hand. Somebody can give a mic.
This is a question to Dr. Ashish Ghosh. Enjoyed your lecture, thank you. CGM, it's being more and more used in pregnancy, diabetics. What do you think is the range of error with CGM? And also, do sensors have to be calibrated on and off?
Now, regarding the accuracy, you look at SMPG, I mean the glucose stick capillary method, the variation, the variability, acceptable range of variability is 10 to 15%.
Yes.
And in CGM, by and large, there are no recommendations, but the norm is the accepted variability, because it is more than the accuracy, the lag which concerns us, because there is about 7 to 10 minutes lag between what you see here and what is actually happening, because you are measuring the interstitial fluid glucose rather than the venous or capillary glucose. So there is a 10 minutes lag. That is what more worrisome than the accuracy part. The accuracy, if I quote literature that I have gone through, it is 10% is the variation that is permitted, and that is, it is little less than the capillary glucose estimates. Now regarding the calibration, yes, indeed you need to calibrate, you need to put in the glucose sticks, capillary glucose values thrice a day. It is very important. Without calibration, the CGM, either the tracing will become more erroneous or the tracings will stop. Because here the sensor is picking up glucose values every 5 minutes and averaging it out and storing it. So for it to continuously work, you need to calibrate. So every 8 hours, you need to put in a reading, as long as the sensor is in.
Yeah, does real-time perform better than intermittent scanned?
Yes, sure, because there are 3 papers. One paper looked at the comparison between these two and said risk of preeclampsia is less. Another paper looked at the comparison between these two and says came up with a report saying that the average HbA1c in the second half of pregnancy is less. But as far as neonatal outcome is concerned, there is no difference.
Okay, thank you. Can
Doctor.
I ask or
Hari
somebody
Kumar.
else wants to ask, because I wanted to ask the first speaker, Harish Kumar.
Yes,
Pregnancy
please.
with type 2
Yeah.
diabetes who are on oral medication, do they require insulin during labor?
Can you please come again?
Hari Kumar.
Yes, sir, please come.
Pregnancy with type who are on oral medication, do they require insulin during labor?
Okay, pregnancy in type 2, do they require insulin, correct? Now, usually at what level of type 2 is the question mark? If somebody is controlled only with metformin, you are only monitoring. Insulin resistance does go up from the second and third trimester. Most of the times they do require, because you are not permitted to use even metformin, there is a question mark, but nevertheless most of us use. So you are likely to require insulin in most of the pre-gestational diabetes. There is no doubt about it. Even all type 2s will require.
And Dr. Shan Sundar, regarding usage of expiry strips, see they give usually 2 years expiry date. But once the cap is opened, you have to take it as 6 months. Correct?
Yes, sir.
Question to Dr. Hari Kumar.
Yes.
Do you monitor glucose levels during labor in GDMs, pure GDMs? And what is your practice in Fernandes?
One hourly monitoring, and then adjusting. You said glucose monitoring only.
Glucose monitoring in GDMs, per se. Yeah.
I mean non-labor setting.
No, in labor.
In labor setting.
They are not pre-existing. It's GDM.
GDMs hourly monitoring. GDMs hourly monitoring.
Hourly monitoring.
Hourly.
Because most of the time we don't require to monitor.
See,
because
depends,
most of the
as I
time-
said, that's why most of the times at what setting of GDM they have entered the labor. Whether they are only on diet control, whether they are only on OAD control, whether they required a single dose of insulin or a multiple dose of insulin. As I said, there is no specific guideline to it, but depending on what you anticipate, you increase the frequency. Some of us, we do actually do a half an hourly monitorings also, but some we may have to do a 2 hourly also is good enough. Depending on at what level of control and what are the pre-existing complications, what the patient was requiring before they entered labor.
Okay, yeah, because in our practice, we do measure blood sugar when they enter the labor, active phase of labor. And if it is normal, they're unlikely to put it up during labor. So that's how.
Yes,
we
absolutely
practice.
correct. Most of the times, that's why I said you don't require it. But sometimes if it's a prolonged labor because of stress, there can be some values which goes beyond 120s or 140s. At that time, a correctional dose may be required. And because of a longer acting insulin, you may have actually a hypos because of again exertion. Again, monitoring only will help because the focus is something else at that point of time. So just a simple measure will obviate a lot of other complications which could have been prevented.
I have a question for Dr. Hari Kumar. In gestational diabetes on insulin, is it still recommended when we give steroid prophylaxis to admit them to the hospital, or can we also manage them?
Admission is not required. Frequent monitoring, up titration of the glucose, more close monitoring. I mean, at least 4-point or 7-point profile for the next 3 to 4 days is what matters. Admission is generally not recommended for it. For glucose control, no.
Thanks.
Yeah, I think these are the metrics calculated using CGM. You have the software where you feed the CGM data, you get the J index, the time in range, time below range, time above range, and the mean glucose levels. That is what the point of contention, it is apparently the mean glucose levels derived from time in range is more an accurate representation of the prevailing glucose levels than the HbA1c's average glucose levels. And they have some data for that. So that is the point of contention. Now, we don't have to sit and use some algorithms, arithmetics to manage it. It is software derived. According to the international recommendations, irrespective of the type of pregnancy, be it type 1, type 2 or GDM, the time in range is calculated between a range of 64 to 140 milligrams. So in type 1 diabetes, it should be that in range should be more than 70% of the time patient should be in range. In GDM and type 2, they should be in range more than 90% of the time. Having said that, can we push the sugar levels well below 90 again in type 1? I think that depends on the kind of back-end support you have. How many diabetic nurses are trained, diabetic nurses are available at service, whether a registered medical practitioner is available round the clock, and what about the dietitian and other, and what are the kind of gadgets that you are using, and which setting the patient is being managed. Based on that, and the patient's level of cooperation and frame of mind also comes into play. So based on that, we need to have a workable or a working target or working range, which may not be the same as what has been internationally recommended. In type 1 diabetes mellitus, if you ask me, I would set a range of like ADA or WHO recommendation, a fasting sugar of around 95 to 100, even though the recommendation is 90 to 95, because it is at times it is difficult because they may experience overnight hypoglycemias, and a prandial glucose of say 130 to 140, even if it is hovering around 145, I don't mind. But in type 2, you can be more stringent. In gestational diabetes, obviously you can target as low as possible, because the hypoglycemia is not as severe as what you expect. You know why? Because the robustness of insulin, because if you look at the stakes of insulin, the body has the maximum stakes. You are giving minimum only. So the body can adjust its stake based on the prevailing glucose levels. Unlike in type 1. Type 1, the body is at the mercy of insulin which is being given. So body has no stakes in it. So you need to be practical.
Thank you all. I think we can continue the next session, and for the next tea, I think we can continue the question and answer session.
Sir, last question. Sir, what is your experience regarding patient compliance with CGM, sir?
Oh, patient's workload is minimal here. All the patient needs is to be focusing on the diet, which is being advised, and 3 inputs. The patient needs to give 3 inputs to the machine. Anyway, the patient is doing multiple capillary glucose estimations on a daily basis. Might as well just feed 3 readings into the system. That's all. The patients, I don't think patient needs to put in more effort here. So the compliance is good. Compliance is not a big question.
Thank you, sir.
Only thing is that the patient's overall approach will be revealed. Once you look at the CGM, you can know how well the patient is adherent to the diet and the other management strategies which are being impressed upon.
Thank you, sir. Thank you, speakers, for the wonderful session. Thank you.
This one? First one is, but what about this projection of slides? That is there. Introduction. Biodata. First topic is the. Okay. Good morning, everyone. Hope you enjoyed the first session. Now we'll move on to the second session of this Magna Endo update. And we have 2 interesting topics in this session. First one is approach to adolescents with PCOS, how it is different from adults, by Dr. Jayaprakash. And next topic is how endocrinologists will approach male subfertility, by Dr. Vimal Upreti. And to chair the session, we have 3 eminent faculties, Dr. Ashwini GB, and Dr. Prabha Nambiar ma'am and Dr. Sripada Vinekar. Please come onto the dais. One, yes. Yes, not able to read.
Shall we start?
Chairperson's slides. So, Dr. Ashwini is a consultant in reproductive medicine and scientific director, and she is working at Aspire Fertility Center, HSR layout. And she won the Padmini Memorial Award for the best outgoing student in 2006. She's very academic, and I think she's training future fertility professionals also. Next slide. Next slide, please. Dr. Prabha is my colleague at Chenmai Mission Hospital. She's a senior consultant in the Department of Obstetric and Gynecology at Chenmai Mission Hospital. She completed post-graduation from the BMC, and she's been working with CMH for the last 20 years. I would say that she's the prime mover for the CMH Department of Gynecology, and she's associated with the BSOG, and she does handle a lot of high-risk pregnancy cases. Next slide. Dr. Sripada Vinekar is my senior from college. She's from St. John's, and she's a consultant minimally invasive surgery in Apollo Hospital and Cloud9 Hospital, Bangalore. And her major achievements include the Hingorani Gold Medal by the Minister of Health. She's from AIIMS, New Delhi. And she has several presentations and papers to her credit, and has been involved in clinical research throughout her professional careers and enjoys teaching. So next slide, please.
Yes.
I think
Dr. Ashwini ma'am will introduce Dr. Jayaprakash, our first speaker, and over to the chairpersons.
Thank you, Dr. Anantharaman, for the wonderful introduction. It's my privilege and honor and pleasure to introduce Dr. Jayaprakash P., MD-DM, present designation Consultant Endocrinologist, Medical Trust Hospital, Kochi since 2009. Major achievement was state topper and won all 3 medals for MD in General Medicine. Has many publications and has been a regular speaker in many academic forums. Welcome, Dr. Jayaprakash. You can start from here.
Thank you, madam. Good morning, all, and it's my pleasure to be here in Bangalore with the hospitality by my good friend Dr. Anantharaman, and I thank Magna team for the topic. So I'll be talking on approach to adolescent PCOS. It differs from the adult. Adolescence, as defined by the WHO, is a period of age from 10 to 19 years of age, the so-called teenage, where major changes do happen in terms of the physiology, in terms of the growth, development, puberty, the psychology, everything changes during that period of time. And the problem with PCOS diagnosis during that period is that the cardinal things which we diagnose PCOS can be considered to be normal, at least in the range of normalcy during that period. So menstrual irregularity, hyperandrogenism, polycystic ovarian morphology on ultrasound, all these can be normal physiological changes during that period. And that's why it overlaps with the adult diagnostic criteria of PCOS. So we need to be careful. We'll just go through a case scenario, a routine case which we all see in our practice. A 16-year-old girl with a history of normal puberty and menarche at 12 years. She is having irregular periods since the onset of menses. Initially it was every 2 to 3 months, but since the last year she has had only 3 periods in the last 1 year. And her last cycle was 3 months back. She has significant hirsutism, so coarse dark hair growth on the face and lower abdomen, which concerns her. Any hair growth which concerns the patient, even though the scoring system but we adapt may not be counting to the significant score, but then if it concerns the patient, that becomes significant hirsutism. And she also has worsening acne of the face and back. She has been overweight since her childhood, has more weight gain over the last 5 to 6 years. BMI is obese. Her BP is 140/90, which is on the higher side for the child. And she has acne, hirsutism, and acanthosis on physical examination. There are no obvious Cushing-out features, and her physical examination otherwise is unrevealing. So this is a representative image. As you can see, this is the coarse hairs. This is not the villous hair, which is, this is significant hirsutism. And this is acanthosis nigricans, which I think we are familiar with. So these things, especially the acanthosis, which we should be looking for, not only the nape of neck, other areas also we should be looking for acanthosis. So when and how to diagnose adolescent PCOS, it's still a matter of debate. There are many criteria, but we'll try to find out the middle path. As said again, some features may be part of normal physiology and maturation in an adolescent girl. The key features are menstrual irregularity and androgen excess. So we don't have the other feature of polycystic ovarian morphology over here. So the two important factors are the menstrual irregularity and androgen excess. And we should always be careful with the risk of overdiagnosis and overtreatment in younger girls. So as said, some amount of menstrual irregularity is always there. So not all irregular menses has to be classified as polycystic ovarian disease, especially when you have an ultrasound which gives polycystic ovarian morphology. It can be commonly overdiagnosed and overtreated. So this is the definition of irregular cycles in an adolescent. Any irregularity is normal in the first year post-menarche. From 1 year to 3 years post-menarche, if the cycle is less than 21 days to up to 45 days or more than 45 days, it's considered as irregular. After 3 years, the 45 days comes down to 35 days. So less than 21, more than 35, or less than 8 cycles per year. And again, after 1 year of menarche, more than 90 days, more than 3 months, if the patient has any cycle, a gap between cycles as 3 months, it is irregular cycles. Primary amenorrhea by age 15 or more than 3 years post-telarche, post-breast development, if the patient is still not had a menstrual cycle, that is also considered as irregular cycle. So this is a consensus guideline as per, there are various guidelines. This is the latest one which incorporates in terms of the irregular cycles as we adolescent. So again, I should reiterate that not all irregular cycles has to be considered and branded as PCOS in an adolescent. The usage of pelvic ultrasound is actually not generally recommended for diagnosis. That's because it's not, the criteria is not well defined, and the guidelines, the adult guidelines, I said, overlap with ultrasound multifollicular appearance in an adolescent. But then it may be indicated in patients who have other features, in a severe hyperandrogenism, where you need to rule out other underlying pathology like androgen producing tumors or adrenal pathology. When we are suspecting, there an ultrasound is indicated. So again, the guidelines also mention this, ultrasound should not be used for diagnosis up to 8 years post-menarche because of the high incidence of multifollicular. Again, this is not a strong evidence-based recommendation. This is a consensus-based recommendation looking at the available studies. They looked at 15 studies. And another problem is we are not unable to use the transvaginal probe because that is more kind of representative, and the adult diagnostic criteria is based on the transvaginal probe, which is not to be used in a child who is not sexually active. We'll just go through the pathogenesis because this is important as far as the treatment is concerned. So there are, in terms of puberty, there is a spurt in the growth hormone, in the insulin level, insulin resistance. So this insulin resistance, which can be normally physiologically happening in puberty, can be tissue selective. Some tissues are more sensitive, some tissues are less sensitive to this insulin level. So The liver, adipose tissue, and skeletal muscle tissues are less sensitive to insulin. They become more insulin resistant, while the adrenals and ovaries become more insulin sensitive. So you have higher levels of insulin, and this selective action at different levels can actually potentiate the production of androgens. While the insulin resistance at the level of liver decreases the SHBG, sex hormone binding production, and while at the level of adrenals and ovaries, it can increase the androgen production. So at the level of the insulin resistance as indicated, differential insulin resistance and sensitivity at different tissues produces the state of high insulin levels, which can drive to the metabolic syndrome and other pathway complications, and also the level of adrenals and ovaries can produce more of androgens. There is also genetics involved. That's why it runs in families. Epigenetic stimuli, environmental stimuli, the weight gain and the diet and other environment disruptors, endocrine disruptors, which the child is exposed to, also plays a role. The central pathway of this is considered to be insulin resistance. So that's why the approach to treat this even adolescents is to try to measures which can decrease the insulin resistance, which can have an impact. Then we look at the biochemical and clinical androgen excess. So as said, hirsutism, acne, and seborrhea are the clinical indicators, and hirsutism, the scoring system is a modified FG score. A score of 6 or more is considered as abnormal. But the data says that in certain population subsets, for example, in Asian and also of European adolescents, actually a score of 4 or more is considered to be significant. Biochemically also you can confirm this, so it's either clinical or biochemical. The measurement, but then has to be done from a good lab. Total testosterone is to be done preferably by liquid chromatography mass spectrometry method. Most of the labs don't do that, so we need to be a little careful about the method which do that. Free testosterone is also given as report in many labs, but again, the assay has to be gold standard assay, which most of the labs don't use that. So a better index is calculation of free androgen index, which can be calculated because the testosterone levels and SHBG levels are measured more reliably, and you can always calculate this. And the timing is also important. Patient should not be on estrogen or progesterone pills, and it should be more than 2 months after that. And you have the lab-dependent cutoff values. Extremely high levels of testosterone, always you should be thinking of a tumor, an ovarian or an adrenal tumors. We should also be on the lookout for non-classical congenital adrenal hyperplasia in these adolescent children, especially when they have significant androgen excess. So you do it by measuring 17-hydroxyprogesterone level in the fasting state. And if it falls within the middle range, you do a stimulated, synactin stimulated value, which can categorically prove or disprove. In an adolescent, just like adults, we need to evaluate for other causes, thyroid dysfunction, hyperprolactinemia, exogenous medications, especially antiepileptics. Many of these children will have a history of intake of antiepileptic, sodium valproate and carbamazepine. All these are notorious for producing this. Cushing syndrome, again, subclinical or very mild cases, we should always be on the examination. Androgen secreting tumor, glucocorticoid resistance is rare, but it do come as one of the differential diagnoses. So coming to the case, our patient had an LH of 20. LH measurement is generally not needed. You can see that she's already having pre-diabetes, fasting of 106. A1C is 5.9. A1C of less than 5.7 is normal. Dyslipidemia is there. 17-hydroxyprogesterone, DHEAS, and total testosterone is okay. Thyroid is normal. So she meets the diagnostic criteria for polycystic ovarian syndrome in an adolescent. There is ovulatory dysfunction, there is irregular cycles, and clinical lab evidence of hyperandrogenism is there. And she also has pre-diabetes, so she requires evaluation for her metabolic and also for treatment. So treatment, there is still no approved single treatment. Lifestyle modification is still the key. As I said, the insulin resistance has to be tackled. With respect to the cycle regularization and the symptoms of androgen excess, the estroprogestogens in various combinations has to be used. And this combination may be far from physiological. We are just trying to induce a normal, pseudo-normal cycles by this, but it can suppress the androgen levels. So the advantage is that patient satisfaction is good. You get normal cycles. The cost is low and the risk is also low. So lifestyle measures are the first line treatment. Healthy diet, regular exercise and sleep, and also stress. Many of these adolescents are exposed to much higher stress levels than their decision making during the teen time with respect to their exams, career and all these things. So stress is also an important factor. And reduction in body weight, at whatever be the percentage reduction, even if it's not obese or overweight, any reduction in body weight actually helps. 5% is said to be significant. It also improves the other risk factors, apart from the androgens and insulin resistance, the cardiovascular risk and the future reproductive health is also improved. So any amount of weight loss leads to improvement. Pharmacological treatment for weight loss, we have weight loss medications. We have now liraglutide and semaglutide approved for weight loss. Liraglutide is approved for obesity in more than 12 years and older with risk. So one of the risks which is associated with obesity is again polycystic ovarian syndrome, so it can be used. Semaglutide is undergoing a trial and we all use it in terms of in adults and find good weight loss with that. And outcome data with GLP-1 receptor agonist also shows, apart from the improvement in body weight, the androgen excess and metabolic markers and reproductive function is that adult PCOS is improved. As I said, estrogen and progesterone preparations form the cornerstone for regularizing periods and also for improving the hirsutism. The lowest effective estrogen dose, this is similar to the adults, lowest effective estrogen dose plus progestins with an anti-androgenic activity like drospirenol or norgestimate should be considered. Anti-androgen strategies can be initiated if there is no improvement. So cyproterone acetate, I think we have a session on drospirenol and cyproterone acetate, desogestrel in the coming, in the morning itself, so we'll have more discussion on that. The lower doses of finasteride, flutamide, all these things can be tried. Flutamide is hepatotoxic, but still it can be tried and there is data in adolescents also. And an interesting concept of using insulin sensitizers, this is a recent study which they have used 3 drugs, spironolactone low dose, pioglitazone low dose, metformin again a lower dose in adolescent girls without obesity. So this is, the concept is that, as I said, insulin resistance is a central role, and if we use measures to tackle this insulin resistance, it can improve outcomes. So we all know spironolactone as an anti-melanocorticoid, but it has also has action on the brown adipose tissue, and the improved metabolism in terms of energy expenditure is also done by this. Pioglitazone is good in terms of a metabolic perspective, mainly by improving adiponectin, and metformin due to many factors. This is one of the mechanisms, GDF15, acting at a central pathway. So what they found is that the improved outcome, the ovulation, this is in adolescents, non-obese adolescents, they have improved outcome with this regime. The annualized ovulation reaches around 10, so almost from 12 it reaches 10, while with OCs it was only 3.6, so improved outcome in terms of that. So coming back to her case, she was advised lifestyle counseling and metformin and oral contraceptives initiated, and she is doing well. One thing with adolescent PCOS is that the transition to adult care is also important. These children are at risk for ongoing PCOS in the adult and subsequent risk. And couple of slides about prevention of PCOS. All kids which are low birth weight and also born as overweight children, newborns, are also at risk for developing PCOS in the adolescents later on. So preventive strategies should be initiated, moderation of catch-up growth, and preventing rapid maturation. Actually, there are studies where they've used metformin in these children with premature puberty, which can actually prevent the onset of adolescent PCOS. So it's a spectrum, right from the IUGR to newborn with increased weight gain in the neonatal period and subsequently, which can lead to adult onset diseases, which can lead on. We shouldn't forget the comorbidities. This is also part of counseling of a child with adolescent PCOS, the metabolic syndrome, the cardiovascular risk and diabetes and fatty liver disease. Screening for anxiety and depression, because psychosocial factors are very much masked in these children, so that should also be, and managing with respect to these disorders with the help of a counseling or a psychiatrist is also important. So summarizing, it's a metabolic disorder, and the two factors are persistent oligomenorrhea and hyperandrogenism, and USG is not, ultrasound is not mandatory for diagnosis, but to rule out other causes, you can use it. Exercise and lifestyle modification is the first line, and medical therapy for weight loss and hormonal contraceptives and spironolactone and metformin are the key drugs. Thank you.
Thank you, Dr. Jayaprakash, for this very elaborate talk. We would now move to the next speaker.
The next speaker, Dr. Vimal Upreti, is going to talk on how endocrinologists approach male infertility. He's a consultant endocrinologist at the Magna Center for Obesity, Diabetes and Endocrinology at Greater Noida. He's also the additional director at Jaipur Hospital in Noida. He's been previously a senior advisor to the Indian Armed Forces and a professor of medicine and endocrinology. He has various publications to his credit. You can start your talk.
Thank you, ma'am. Thanks for the kind introduction, and good morning, everyone. So today, the topic for my talk is how endocrinologists approach subfertility in men. Subfertility is a problem that affects the couple, and it is defined as couple is defined as having infertility when, if the female is less than 35 years of age, then 1 year failure to conceive, and if she is more than 35 years, then 6 months failure to conceive after a prolonged sexual exposure. Infertility affects about 8 to 12% of couples worldwide, male factor being responsible for cause in almost 50% of the cases, either primarily or in association with the female factor. Male infertility is approaching a concerning prevalence worldwide. Every time it is increasing, and the annual rise in cases is about 0.291% annually. And hormonal assessment plays a vital component in assessment and management of male infertility. So these are the causes of male infertility, as you can see from this cartoon. Here, so systemic diseases, majority of the causes are related to the urological system, but hypogonadism, immune factors, systemic disease, and unexplained. So these also form quite a bulk of patients, and among them are the endocrine causes of infertility. And various endocrinopathies that are associated with subfertility or infertility are hypogonadotropic hypogonadism, hypergonadotropic hypogonadism, and then there are others like androgen excess, estrogen excess, hyperprolactinemia, and insulin disorders. These are the commoner ones, and associated with other endocrinopathies like acromegaly, etc., that is also there. So this is the hypothalamo-pituitary axis. This shows that the normal physiology of a human being. The things start from the hypothalamus, the production of GnRH, and then down to the pituitary. The LH and FSH hormones, that is the gonadotropins, are released from the pituitary, and then they go on and act on the testicular tissues, mainly the germ cells, where the FSH acts and produces the sperms, and LH acts on the Leydig cells to produce testosterone in the males. And under the effect of this testosterone, which is produced intratesticularly, the maturation of the germ cells takes place, which leads to further production of sperms. And this process starts at the about age of 8 to 10 years, and the whole process of maturity of the puberty lasts for about next about 8 to 10 years, or maybe 5 to 8 years. That is the time when the child goes from a childhood to an adulthood, adolescence. That is the transition from a child to an adult male who is able to reproduce. So how do we evaluate such cases? The evaluation, once the patient comes, we first take the history of the patient. So we rule out any past history of cryptorchidism, mumps orchitis, testicular trauma or torsion, any history of UTI in the past. Personal history in terms of smoking, alcohol use, use of recreational drugs like cocaine, opioids, especially cannabis, and anabolic steroids. These days, many people are using for bodybuilding purposes, etc. So that should be taken into account. Couples' sexual practices are noted, including the timing of coitus, erectile function, and ejaculatory function. Use of vaginal lubricants, sometimes they may be associated with spermicidal agents also. And then we assess for other endocrinopathies. Coming to the physical examination of the patient, we assess for unicoid body proportions, decreased body hair as compared to Tanner stage 5. We look for obesity or gynecomastia. Assessment for anosmia, midline defects, or synkinesia. This leads us to a possibility of Kalman syndrome, which is a form of hypogonadotropic hypogonadism. Look for other features of acromegaly like thyroid dysfunction. Look for any acromegaly or other endocrinopathies. Then a thorough genital examination should be done to look for any abnormalities in the penile structure in forms of penile curvature, plaques, epispadias or hypospadias. In testicular presence and size and consistency of testicles, where there are any undescended testes or then testicular lumps or tumors are present or not. What is the size, what is the consistency, that is also seen. We also examine for epididymal defects, enlargement, hypoplasia, and these things are looked into, and spermatic cords are looked for varicocele, and prostate should be assessed for size and consistency. And if there are any problems are seen, then we take the help of our urology colleagues in further management of these patients. Coming to the lab evaluation or investigations, semen analysis is the foremost importance. If semen is normal, then we need not go any further. However, there is an abnormality in the semen, then we look for hormonal tests, including the testosterone and FSH as the first line. And if any abnormalities come in this, then we look for testosterone, LH, and FSH. Look for any prolactin abnormalities and other tests as indicated, including thyroid testing, GH dynamics, etc., as told by the patient's condition. Coming to the imaging, we image the ultrasound of the scrotum. The cranial MRI is seen to look for any pituitary defects or pituitary hypothalamic area abnormalities. And a detailed urinary genital examination of MRI could be done in case it is any abnormalities are found there. Then genetic testing should be done in case we find hypergonadotropic hypogonadism to rule out Klinefelter syndrome. Karyotyping is done, and gene mutation of CFTR gene in terms of cystic fibrosis. So in case of hormonal evaluation, this is the type of defects that we'll get, seeing the LH, FSH, testosterone and prolactin ratio. Normal eugonadotropic males, all these would be normal. Coming to hypergonadotropic hypogonadism, testosterone would be low, LH and FSH levels will be elevated, and prolactin would be normal. In case of hypogonadotropic hypogonadism, the testosterone levels would be low, and so would be LH and FSH, prolactin being low. And in cases of hyperprolactinemia, These three levels would be low, that is LH, FSH and testosterone, whereas prolactin levels will be elevated in these patients. So how do we induce fertility in men with hypogonadism? There are two types of hypogonadism, that is primary defect in the testes, and secondary where the defect is in the hypothalamo-pituitary part of the axis. Hypogonadism, generally the defect is permanent. If there is a testicular abnormality, that I'm afraid is not possible to reverse it. Here we should be replacing testosterone unless there is a contraindication to it, and fertility prospects are very dismal, and we should advise them other means of continuing their family. Coming to secondary hypogonadism, we need to find out the cause, as I already elaborated. Evaluate for other hormone deficiencies first. Rule out hypothyroidism, hyperprolactinemia. Use gonadotropin therapy for fertility. And secondary hypogonadism for sperm production is usually can be stimulated sufficiently to restore fertility in these patients, especially if it has happened post-pubertal. So there are various treatment regimen for gonadotropin therapy. These include pulsatile GnRH therapy, HCG monotherapy in secondary gonadotropic hypogonadism, combined gonadotropin therapy for congenital hypogonadotropic hypogonadism. Traditional therapy, there is HCG first, then there is sequential approach utilizing FSH first, and there is role for clomiphene citrate also. So coming to pulsatile GnRH therapy, the protocols aim to mimic the normal physiology of human body by delivering doses in a pulsatile manner. GnRH dose is titrated to induce serum testosterone level in the adult normal range and also to cause spermatogenesis. And dose frequency is typically 2 hours. So every 2 hours a GnRH pulse is given, and time to reach normal serum testosterone level largely depends on the baseline testicular volume. And this therapy is limited by having to use subcutaneous pump. It is costly, and availability is also an issue. And moreover, not effective for patients with primary pituitary disease. Fertility outcomes are similar between pulsatile GnRH therapy and other gonadotropin regime where we use LH and FSH. So pulsatile GnRH therapy is not much in vogue. Coming to the gonadotropin therapy, gonadotropin treatment in men with hypogonadism, it results in appearance of sperms in almost 90% of males, but the count is generally not restored to normal. Even if pregnancy does not occur spontaneously, the count is sufficient so that we can offer ART to the patient. And the traditional approach is LH first, that is using SCG in lieu of LH, because SCG has a chemical structure which is similar to the LH, and this results in intratesticular testosterone concentration, which is 100 times more than that of the peripheral testosterone concentration, and which is required for the maturation of the spermatocytes and production of sperms. SCG alone may be sufficient in many cases for stimulation of spermatogenesis. However, FSH alone is not effective. SCG preparations are considerably less expensive, and they can be given freely. And the dose is initially started with 100 units subcutaneous 3 times a week, and then gradually increased to maximum 10,000 units per dose. Monitoring is maintaining serum testosterone level between 4 to 8 nanogram per ml. And also we look for hemoglobin, hematocrit, and estrogen levels, similar to the way we are doing monitoring in testosterone therapy. And serum level should be checked every 4 to 6 weeks to make the necessary dose adjustments. So as the testes grow, it is often possible to slowly down titrate the SCG dosage to a maintenance dose. Then we can sequentially add FSH treatment to these patients. And FSH is used if the sperm count has not reached 5 to 10 millions per ml, or if pregnancy has not occurred even 6 months after the serum testosterone level is between 4 to 8. That is the time when FSH can be added. That is HMG, that is what we use. And it is necessary for initiation of spermatogenesis, but once it is initiated, it is not required for its maintenance. And a typical dose is 75 units 3 times a week, alternate day, and given along with the SCG in the same syringe. So the predictors for spermatogenesis in induction of male hypogonadotropic hypogonadism include hypogonadotropic hypogonadism that is acquired post-puberty. That means the person has already been exposed to a mini-puberty. Testicular volume, if it is more than 4 ml, it's a good prognostic sign. No history of testicular maldescent, higher baseline serum inhibin levels, and good spermatogenetic response in prior cycles. These are the good factors for predictors of spermatogenesis. So the clinical outcome in hypogonadotropic hypogonadism is the sperm quality is qualitatively normal. The timing of response, it takes about 6 to 10 months to the spermatogenetic response to come, and pregnancy takes much longer. If pregnancy is not achieved between 12 to 24 months, then ART may be offered to the patient. If pregnancy is achieved, the patient may be continued alone on SCG or even testosterone. And cryopreservation can be offered to these patients if they are desirous of future pregnancies. And virilization can be maintained, as I already told, by using SCG alone or using testosterone. A word about clomiphene citrate. It is an off-label drug for men with oligospermia or azoospermia and normal to mildly low serum testosterone concentration. Clomiphene citrate is a weak estrogen receptor antagonist that stimulates gonadotropin secretion in normal women and men. And it has variable results and in the hypothalamic secondary hypogonadism. It is not very effective if the causes are in pituitary or in the idiopathic infertility patients. Coming to other endocrinopathies, thyroid hormones, both hypothyroidism and hypothyroidism may be associated with subfertility. And thyroid hormones, as we know, are necessary for development and functioning of the tissues as well as to maintain the normal body metabolism. And hypothyroidism leads to reduced testosterone as well as SHBG levels, reduced free testosterone, and there can be reduced levels of LH and FSH. There can be hyperprolactinemia and reduced sexual drive in adult males. So restoration of normal thyroid function generally leads to improvement in all these parameters and improvement in serum parameters. Coming to hyperthyroidism, there are variable effects. The patients have high SHBG levels, low estradiol and LH, but also low free testosterone. And the sperm quality can be significantly compromised. And once the treatment is started, within 6 months to maybe half a year to 1.5 years, the parameters tend to normalize. Hyperprolactinemia, as we all know, is associated with subfertility both in males and females. It could be associated with pituitary tumor and many other causes like hypothyroidism, many drugs, etc. And it leads to a sort of hypogonadotropic hypogonadism of central cause leading to low LH, FSH and low testosterone levels. There is reduced sexual drive, erectile dysfunction and reduced semen quality. MRI cell should be done in these patients to rule out pituitary adenoma. And treatment is usually medical, with cabergoline being the cornerstone of treatment, giving a good improvement in 6 months time. Androgen excess, again androgen through its negative feedback, they suppress the central gonadotropins and cause hypogonadotropic hypogonadism. And this occurs because of exogenous testosterone therapy and illicit use of anabolic steroid, which is picking up these days. And sometimes there can be endogenous causes, including congenital adrenal hyperplasia and functional adrenal or testicular tumors. And this is very common. If patient is taking exogenous steroids, exogenous anabolic steroids or testosterone, the use should be discontinued, and otherwise SCG, clomiphene and ICSI may be helpful in these patients. Coming to estrogen excess state, it happens in patients having obesity and also patients having tumors which are producing estrogen, including adrenal and testicular germ cell tumors. So there the ratio of testosterone to estradiol is tilted in favor of estradiol, and aromatase inhibitors like anastrozole may be helpful. Insulin disorder and diabetes mellitus, again, is a variable effect on fertility. ADA says almost 90% of diabetes cases are accompanied by changes in their reproductive function. There are various abnormalities which are shown in animal models, including reduced vacuolization of Sertoli cells, reduced spermatogenesis, changes in gonadotropins and testosterone levels, etc. And also it reportedly affects the spermatogenetic cycle by impeding the FSH effect on Sertoli cells. So insulin disorders and diabetes mellitus should be looked into, and they should be evaluated and treated. Obesity is a leading cause of subfertility in men these days, and is because of increased aromatase activity leading to high estradiol to testosterone ratio. And also, obesity-induced germ cell death because of spermatogonial apoptosis due to the allostatic load, that is, increased load of body weight that causes sperm cell death at the testicular level. So that needs to be taken into account. A word about endocrine disrupting chemicals, which is there ubiquitously available. They are present everywhere. Especially obesogenes are the ones which are associated with increasing obesity in the population. So this is what we have to look for and also rule out. So as I said, obesogenes are present everywhere. You name a thing and they are there. There are various sources to obesogenes. So to summarize, male subfertility accounts for about half cases of causation of infertility and it is ever increasing. Endocrinopathies contribute to about significant proportion of men with subfertility and is potentially treatable. Treatment with LH-FSH is preferred, though pulsatile gonadotropins can also be used. And obesity and endocrine disrupting chemicals are emerging as important factors in subfertility in men worldwide. These are few references that I have taken, and my sincere thanks to Dr. P. Sudhakar Reddy for sharing his slide deck with me and helping me prepare this presentation. Thank you very much.
Thank you, Dr. Vimal, for this very elaborate talk. Can I have Dr. Jayaprakash also on the dais? Any questions can be addressed to the speaker?
Yes, ma'am.
Yes, madam.
This question is to Dr. Jayaprakash. In your study, you said some adolescent age girls before menarche, those who are high risk, for them the metformin was given. So menarche varies from person to person. So how long it was given, what dose it was given? So, can you elaborate on that?
Metformin has been tried from the age of 6 years, even in those children with who are overweight, who had a premature adenarche. There are studies in which when the weight loss usual measures, they don't work in that age group. So they have tried adding metformin and it has found to improve or produce weight loss. And the future outcomes in terms of preventing PCOS and metabolic syndrome later on has been significantly better.
How long it was given? How long?
How long is a question, and I think in that study they've used the follow-up for around 6 years. But once that ideal weight is achieved and once the endpoints are achieved, it can be stopped also.
Yes, ma'am.
Dr. Jayaprakash, could I ask you, how do you view fatty liver changes on ultrasound in an adolescent with PCOS? How seriously do you take it?
Sorry, I didn't, how do you view?
Fatty liver changes.
Fatty liver
Ultrasound
disease.
changes of the liver.
Fatty liver disease is part of that spectrum of metabolic syndrome, and it shows adverse metabolic profile which is going on in their child. So as in the discussion, the insulin resistance at the level of liver is said to drive the hyperinsulinemia and all the subsequent pathways. So fatty liver is a marker of insulin resistance at the level of liver, and that has to be taken in significance. So at that age itself, and you get that finding itself, even if the child has not had menarche or the irregular cycles are not yet there, but it's a risk factor and we need to address that.
How do you follow it up? Do you investigate liver enzymes, etc., as part of routine? And do you think they would develop NAFLD in adulthood? Sorry. Yeah. How do you investigate them? Do you do liver enzymes for them routinely? How do you follow them up?
Yeah.
And are they at risk of serious NAFLD in adulthood?
Yes. the marker, one of the markers, easiest things that we can do is the liver function test and elevation of any transaminitis, SGOT or SGPT. If it's elevated, even though we take significant levels as more than 3 times, but then any elevation is to be taken as significance in the presence of an ultrasound detected fatty liver. To quantify, you can have always elastography, but at this age, the normal indices of elastography in children, the normative data is yet to, I think, get standardized, but then it always is there, and obviously these children are at high risk for developing the metabolic spectrum of fatty liver disease and later on steatohepatitis and all these things.
If I can add something there, Madam was more concerned about the side effect profile of metformin is what I understand. Is that the one? And whether metformin worsens it?
No.
Not
Would some of
necessarily.
them
You're just worried
develop-
about the pathogenesis of.
Yeah. Would some of them develop serious NAFLD in
Later on,
adulthood?
yeah.
And what type of PCOS can develop that was my question. Thank you.
Yeah, this is Dr. Jayaprakash again. We are definitely seeing a spurt of obese adolescent post-COVID, and lifestyle modification is easier said than done. I mean, it's a real challenge. So, is there a measure, do you quantify the insulin resistance? Is there a role of measuring the fasting insulin and, accordingly manage them? Is there a role of starting metformin early in them?
No, there is no role for measuring fasting insulin resistance, no role for measuring the insulin resistance with the HOMA-IR and other things. That has to be done in a research setting, in an individual patient, looking at the clinical markers, acanthosis nigricans, simple height and weight measurement and serial follow-up, and family history of diabetes. All these things give a clue. And obviously, if the weight gain is significant from the previous visits, there is nothing else which prevents us from diagnosing metabolic syndrome and implementing the lifestyle changes at that time itself. Metformin, yes, but then metformin doesn't work alone. The problem with using metformin is that patients tend to think that, okay, I'm on a drug and it's going to work. It is not going to work. It is just to augment the lifestyle measures. As you said, it's very difficult to implement it. Even in adults, it's difficult. So in these children, but then somehow you have to counsel them and involve the parents, and the home environment, I think, has to be modified accordingly so that there is the fatty liver disease going into a severe spectrum that we are seeing now in adulthood, and now the leading cause of chronic liver disease has become, and stage renal liver disease has become fatty liver. And females are also, there is an increasing preponderance and malignancies, all these things. I think post-COVID, when these children are growing up into the adulthood, we are going to have an explosion of these complications also.
My question to Dr. Jayaprakash. You said that oral contraceptives can be given to regulate the cycles. Yeah. Usually what we see is over a period of 6 months, 8 months, the cycles get regular. I'm here to the cycles get regular. But once again, after another...
Actually, a pseudo normalization of menses, just inducing withdrawal bleed. So we have to look at the causative pathway to improve that instead of continuing with the OCPs or estrogen pills.
I think due to paucity of time, we can't take any more questions. Questions can be taken later on during tea time. Thank you so much, Dr. Vimal and Dr. Jayaprakash. It was a wonderful discussion. Thank you, co-chairperson.
Please go there. We'll be getting the memento. And thanks, faculty, for the wonderful session. So now we'll go into the session 3. And to chair this session, I invite Dr. Sunanda Kulkarni, Dr. Madhuri Patil, and Dr. Sagar Reddy. So in this session, we are going to see about the expected and red flag changes in hormonal levels during fertility treatment and about the osteoporosis treatment. Please come to the dais. Dr. Shobha Gudi. So Dr. Madhuri Patel, she is a clinical director of Dr. Patil's Fertility and Endoscopy Clinic Bangalore, and she is affiliated to various organizations, Aspire, Fertility Preservation Society of India, PCOS Society of India, etc. Next slide. Dr. Sunanda Kulkarni, Madam, presently working as a DNB coordinator at Chenmaya Mission Hospital, Bangalore, retired professor and HOD from Bangalore Medical College and worked as a professor at AIIMS, Belur. She has achieved various publications, had more than 500 publications, and she has various achievements. Next slide. Dr. Shobha, she is HOD at St. Philomena's Hospital, Bangalore, postgraduate teacher and examiners. She also has various affiliations and she has a lot of achievements. So over to the chairperson to introduce the speaker and the topic.
First, I would like to thank Dr. Anantram and his team for inviting me. I would like to introduce Dr. Deepa Datta, and there are two speakers today. And the first one is Dr. Deepa Datta, and okay, and I cannot see properly. Okay,
Okay, I think the font is a little small for that distance. So I will do the honor of introducing you, Dr. Deep Datta. It's an honor to chair a session for a young endocrinologist, member of RSSDI, ESI, IBMR, ISPA in India, and several other endocrine societies, reviewer of major global diabetic and endocrine journals, editor also, European endocrinology and US endocrinology. That's an achievement there, and member executive committee, Endocrine Society of India. I hope you go higher than that. Several publications, of course, and probably I will mention a research interest of vitamin D, bone metabolism and parathyroids, and especially in diabetes and autoimmune. So the floor is all yours. Please take it. Thank you.
Thank you so much, ma'am, for the kind words. It's indeed a big honor to be part of the Magna Endo update. Thanks to Dr. Anantram and the entire Magna family we have here. Maybe the last major conference of this year. So I have been given a very difficult topic. Magna conferences are always special for thinking out of the box, giving very difficult topics for the speakers. Hope I'm able to do justice to red flag changes and hormonal changes which we see in fertility treatment. So fertility treatment is here to stay. My knowledge is zero. I only read for my DM exit exam and I've forgotten everything about it. But yes, we have expert gynecologists and fertility experts who routinely are taking care of so many patients. And this is a problem like diabetes. It is the pandemic of infertility also going to increase across the world, even more so in a country. This is a recent paper which got published in PLOS ONE just last month. This is the data from the NFHS survey which just got published, the recent one after 10 long years, which has shown that secondary infertility is as high as in 30% of all married couples. And the occurrence of primary infertility is also going up exponentially because we don't know, or maybe we know a bit of it. More sedentary lifestyles, more metabolic syndrome, more exposure to endocrine disruptors, as Dr. Vimal highlighted beautifully in his last presentation, and late marriages. So a lot of factors are there in that. And this is an interesting paper I came across, published nearly 10 years back in Fertility and Sterility, which is from the Sweden. Sweden is a small country. They have the entire health database of the entire country digitalized. So somebody surveyed the data of all the women who underwent IVF therapy from 1990 to 2008, 18 long years. They could get data of around 8.5 years of follow-up. And what interesting thing they came up with that, women who had IVF pregnancies, they actually had a higher incidence of hypertension, even a higher incidence of stroke in the long run. So maybe these women, they need a close monitoring for different aspects of metabolic syndrome even after childbirth. That's the message should go out to the entire physician fraternity. Now coming to endocrine disruptors, major issue. Just to highlight, bisphenol A is the largest produced plastic across the globe. It is banned in USA and Europe, but it's still unfortunately available in India because it's extremely cheap. All the cheap toys, plastic items, they contain bisphenol A. Of course, we get to see those feeding bottles of the kids. They write BPA free, BPA free. You get, it's a new marketing strategy. Another important is the plasticizers like phthalic acid or phthalates. Now, plasticizers are very ubiquitous because they help in making plastics malleable, so they can fold them, shape them into whatever thing they want. So virtually almost every plastic containing item contains plasticizers, and they are pro-estrogen, they are estrogen mimetic, and they have been linked not only with increased occurrence of diabetes, also infertility both in men and women. There are a lot of studies published showing that increased levels of phthalic acid derivatives in the blood has been linked to lower circulating AMH levels and increased occurrence of infertility. So as a rule, I tell all my patients, I predominantly get maybe male patients with oligospermia or azoospermia. I tell them, get rid of all the plastic utensils, bottles from your home. I think that's the first thing we should be doing in our practice. I have done that in my home also. So yes, coming back to the topic, I think we shall be covering the different hormonal aspects, because as a part of assisted reproductive techniques, a lot of different hormones are used in different protocols by the IVF experts depending on what the patient has the major issue. So none of the hormones work holistic. They interact with different axes. So I shall be highlighting how the different hormonal preparations which are used in ART actually interferes with primarily the prolactin levels, secondly the thyroid hormone axis, thirdly the occurrence of dysglycemia. These three major things, and does actually interfering them makes a difference or not would also be covered. Well, when we think of ART, I think one is to include, when you're talking of female factor infertility, we are trying to improve ovulation in a good subset of patients, and another subset we are going for assisted reproductive techniques. So we can use aromatase inhibitors are commonly used in a clinical practice to improve ovulation. So regarding the hormonal therapies, these are the different hormones which are used in different permutation and combinations for ART. So when we talk of HCG, HCG is again commonly used. We must know that the alpha subunit of HCG is similar to that, is common to that of TSH. So whenever we are using HCG for whatever reason, you may use it in a male factor infertility also to improve spermatogenesis as part of your treatment protocol. It interferes with the thyroid hormone axis. It will cross-react with the TSH receptor. So in a person on HCG therapy, the TSH typically comes low, and they may have variable increase in total T4 or free T4. So as a rule, if a person is on HCG therapy for whatever reason, please do not measure thyroid hormone levels at that point of time. It will be difficult to interpret that report. A good practice would be to check the thyroid profile at least 2 weeks before or 2 weeks after that. So this is a sample hormonal protocol I have put only for representational purposes. It highly varies again from patient to patient what regimen is being used. We know that hypothalamic pituitary gonadal axis, how it works from the GnRH from hypothalamus to LH, FSH from pituitary, and then of course the production of estrogen, inhibin, and AMH from the level of ovaries. But this is a very simplistic representation. A lot of interaction happens at different levels at different points of time, which again I shall be coming to. Coming to a simple, this is a typical menstrual cycle. If you see how the LH surge happens, then the estradiol surge happens, and there's an ovulation happening. If you see the typical fluctuation of levels of estradiol, it ranges from maybe 50 to 250 picograms per ml. Now, when we talk of controlled hyperstimulation, when we are trying to induce ovulation by different hormonal therapies, look at the estradiol levels. They are nearly 10 times higher. It goes as high as maybe 2,500 picograms per ml to even maybe 3,500 picograms per ml. So such supraphysiologic circulating levels of estradiol also brings about different hormonal changes. First of all, estradiol has a direct permissive effect at the level of pituitary to increase the prolactin hormone release. So it is very common to see mild increase in prolactin levels, typically around maybe 20 to 18 nanograms per ml. They almost never cross 100. If you come across a level of prolactin more than 100 nanograms per ml, I think it's a red flag. We need to take a full history. Any common causes are drug history. Any medications which are being used to increase prolactin, which can lead to rise in prolactin, like most commonly is the proton pump inhibitors with domperidone like containing preparations. Are the patient on any antipsychotic agents or antidepressant medications? This history has to be taken. Pituitary cause is extremely rare, and pituitary tumors typically have prolactin levels more than 200 nanograms per ml. Of course, we do have some overlap also. So consequences of high serum estradiol is, one is the impact on direct prolactin levels. The second is that estradiol will lead to increased formation of different globulins. The globulin synthesis from liver is upregulated, so the thyroid binding globulin level goes up, so you will find high levels of total T4. So another important, any treatment which can lead to high levels of estradiol in the lady, please don't measure thyroid function at that point of time. We'll have a hard time interpreting that report, and with the bold, the patient will keep on bugging us, doctor, what should I do for this? And we will really don't have any good answers at that point of time. Now, transient hyperprolactinemia in IVF. We saw that it's a part of the treatment. So should we treat it or should we not treat it? The last word is yet to be written. There are a lot of papers to show that if you don't treat it, it really doesn't happen. Any harm happens to the lady, especially for levels around maybe 20 to 60 picograms per ml. And there are even papers to show that if you treat them with very low dose of cabergoline, say 0.25 milligrams per week, the prolactin level does come out, and it also has no adverse impact on the pregnancy outcomes or the fertility outcomes. And again, we must remember that when we are talking of mild increase in prolactin, we should always keep in mind the thyroid profile. Another most common cause of mild increase in prolactin is uncontrolled hypothyroidism. So as a rule, if you are measuring prolactin and thyroid profile, do before starting the hormone therapy for assisted reproductive technique, ART. This is a beautiful paper which has shown that in women who had a mild increase in prolactin in the apparently so-called normal range, say more than 16 or 20 or 30 nanograms per ml, these women actually had better outcomes of fertility. They had more successful pregnancy outcomes. So not all patients with mild increase in prolactin does need treatment, especially if they are already on ART. So next is I think we covered already how the TBG levels goes up with high circulating levels of estradiol. I'm not going to repeat. And this also we have covered. Thyroid dysfunction, again, as you said, the cross-reactivity of HCG, the impact of estradiol. So please don't check thyroid profile during the ART treatment is going on. Even the ATA guideline says that you check at least 2 weeks before, 2 weeks after your hormonal therapy. There are also data to show that people who have underlying autoimmune hypothyroid, people who already have underlying TPO antibody positivity, people who are already on thyroxine replacement, they would have a greater fluctuation in thyroid functions. So we need to tell our patients and counsel the patient that you may have some fluctuation, and that is common, expected, and it is not going to do harm. So as a rule, please don't take thyroid profile as a part of ART treatment. So this is the ATA guidelines which I just highlighted. Levels of TSH, I think this is the older ATA 2011 guideline. The ATA 2017 guideline says that ART is a high-risk pregnancy, so we should keep TSH less than 3.5. It is no longer 2.5, it is now 3.5 during the entire course of preconception and as well as during the entire pregnancy. Now, growth hormone, yes. Growth hormone is also increasingly being used as a part of different permutation and combination as a part of ART. The growth hormone has been shown to improve the chance of conception. It improves the chance of implantation also. Now, growth hormone, we know it's the opposite to counter-regulatory hormone to insulin. Even in kids or adults with growth hormone deficiency, when we are using growth hormone, there is an increased risk for dysglycemia. Mild increase in blood glucose levels can be seen, especially in metabolically challenged people. Growth hormone therapy has also been linked to increased occurrence of thyroid dysfunction. So these women also, if are using growth hormone as a part of your ART, the risk of dysglycemia would go up, and these patients would need close monitoring of their blood glucose levels. So IVF and the risk of gestational diabetes. Another beautiful paper coming from the Scandinavian country. The strength is in the numbers. This paper beautifully showed that 25% of all women who underwent IVF therapy in this Scandinavian country, 25% of women who did not undergo IVF therapy, who had normal pregnancy, they had GDM during their pregnancy, as compared to 31% of women who underwent IVF therapy. Look at the numbers. If you talk of normal pregnancies, data from nearly 4 lakh patients, 1 lakh had GDM during pregnancy. In terms of IVF pregnancies, 760 odd IVF pregnancies, which led to around 239 reports of GDM. So yes, ART is linked with higher occurrence of GDM. And what happens in this GDM? In women who had a pregnancy because of ART and then they develop GDM, they have a higher risk of preeclampsia as compared to normal pregnancies who had GDM later during the course of pregnancy. That's an important message coming from a very good journal, Placenta, published just 2 years back. Now metformin, a lot of hue and cry. Should be using metformin or not? Some studies say use of metformin in pregnancy leads to a greater risk of small for gestational age child. So ultimately, I think we have to realize pregnancy is a state of physiological insulin resistance, and in a person who's undergoing ART, who's exposed to different supraphysiological hormone levels, which would increase the risk of metabolic syndrome. I think metformin data is pretty good. It has been tried with different ART protocols. Advantage is that metformin has been known to, there's data to show metformin itself improves fertility. Metformin also has a beneficial effect in increasing implantation and increasing the chances of conception. Now, myo-inositol versus metformin, again, the last word is not out. This is a good meta-analysis showing that when head-to-head comparison of myo-inositol and metformin, not many studies, only 9 studies, 330, really we couldn't make a difference, whether it really makes a difference or not. One point of metformin I'd like to highlight is the previous study showed that at least in women who had BMI more than 26, preconception, metformin indeed made a difference in terms of improving fertility outcomes, but not so in lean women. So I think dexamethasone is also being used in some ART protocol. I just came across a few of them. Again, it's a very potent glucocorticoid, and use of dexamethasone itself would significantly increase the risk of dysglycemia in these women. So I'd like to end by saying that hormonal interaction is universal. It happens in all. Monitoring of thyroid function, monitoring of prolactin levels should be done before 2 weeks or after 2 weeks of the entire hormonal treatment of ART, and dysglycemia should be specifically looked for, especially in Indians who have a thrifty phenotype and per se have a higher risk of high blood glucose. Thank you so much. I would like to end by specifically thanking Dr. J.P. Sahu. I think he provided me with 90% of all the materials and slides which I presented today. Thank you so much.
So the floor is open for discussion. Any questions? Any questions?
There's one thing which comes to the mind regarding prolactin. I think many practitioners are really kind of, we are stumped when we see a mildly elevated prolactin level. So often it is there. And in the background, there is this knowledge that prolactin levels are very sensitive. And even if the woman has had intercourse early in the morning or last night, the level might be more, though she might have given a fasting sample, etc. So we need some enlightenment on the interpretation and when to red flag it. Which test would you recommend? Is there anything more to be done? Yeah, mildly elevated prolactin.
So mildly elevated prolactin, it may be a lab error also. It's a good practice to look at the thyroid profile with prolactin levels. Mildly elevated prolactin with raised TSH, just correct the TSH, prolactin level comes down. Another important thing which I missed in my presentation is macroprolactinemia, which is not uncommon. 6 to 10% maybe the prevalence in some studies they have shown, is that prolactin level comes falsely high because of circulation of big clumps of prolactin. So it's a genetic thing. A simple test called monomeric prolactin, where they measure the prolactin levels before baseline, they add polyethylene glycol to the blood sample and they look at the prolactin levels. If they have a macroprolactin levels, the prolactin level in the circulation, it would come down by more than 60%. So I think that would really help us in avoiding over-treatment in this situation.
Best to ask for before I hand over to the expert here.
I think simple thing is, if this patient has no clinical symptoms of hyperprolactinemia, recheck. Recheck after a few weeks, I think.
No, you said macroprolactin. So what is the test called?
The monomeric prolactin. The test is called test for monomeric prolactin. It's not very costly. What they do is they measure prolactin before and they add PEG to the blood sample and again check the prolactin levels.
Monomeric prolactin.
Yes,
okay, I hope.
Yeah, so basically,
Dr. Deep, I have a question here. You told metformin in BMI about 26 definitely improves the fertility outcome. What's your recommendation? Should we continue metformin once conception happens, or is there any role to continue or not?
Again, it's a highly individualized based on the patient profile. If it's a lean patient who has been undergoing using metformin for PCOS, we may stop in the first trimester and there's no need to continue. Many times, some of these women will develop gestational diabetes later in pregnancy. Commonly, what we are doing is we are using insulin as the first line treatment, but we know simple insulin in a state of physiological insulin resistance, the dose goes up really high. We do add metformin to this patient. That really helps in keeping the total dose of insulin down to manageable levels in that lady.
And how does metformin increase the risk of SGAs?
I think that's a very major question. I think we can have a whole day session on it. The first thing said, we really don't fully understand. Another thing is that pregnancy is a state of physiological insulin resistance because the nature wants the child to get more glucose. The child is given a priority as compared to mother. Metformin brings down this insulin resistance. The amount of glucose reaching the child is also goes down. That also contributes to the SGA.
I have seen few cases when patients are on metformin, there is a reduction in the amniotic fluid. I don't know whether it is a direct effect of metformin or what. Just want to know your opinion on this.
I have no idea, ma'am.
Because one of my fetal medicine specialists has commonly seen when GDM patients are on metformin, she has noticed a lot of reduction in the amniotic fluid level. So just wanted to know your...
I'm really sorry, I don't know.
Thank you.
Thank you.
Basically, it could be related to the PCOS itself, because we know that PCOS is associated hyperandrogenemia, and that then results in insulin resistance, because hyperandrogenemia results in abdominal obesity or the central obesity, which increases the insulin resistance and hyperinsulinemia. So these patients are as it is prone to hypertensive disorders as well as other cardiovascular disorders. And that is the reason probably these patients also would have higher incidence of PIH, and that could be related. But metformin directly does not affect the amniotic fluid.
Very interesting talk, Dr. Deep.
Thank you, ma'am.
Wanted to ask you, is it mainly due to, those ART and long-term maternal health issues were quite alarming. Okay, so is there a subgroup analysis to say that it is mainly due to the age that they have come across these, or is it generally the ART treatment that has increased the incidence of hypertension, diabetes, CVD, and CF? I don't know whether he mentioned it. Sorry about that. Age factors were excluded?
In that study from Sweden, they excluded that in that study. Yeah, it's a pretty alarming paper coming, but that's only from one country. I think we need to study in
No, so basically, Lata, I would like to tell you, so there's increased instance of PIH and gestational diabetes, basically more of PIH and other placental abnormalities in a frozen embryo transfer cycle as compared to the fresh cycle. And there are several studies which have been done which have said that this is basically related to the absence of a corpus luteum. So today, most of the ART clinics, who have a good experience are, even if they're doing a FET and they're doing it in a natural cycle or a ovulation induction cycle where they can give letrozole or clomiphene, and then they're doing the embryo transfer. But the only problem with when you're doing a natural cycle or an ovulation induction cycle is that you have to have a stringent monitoring, because you have to detect the exact time of ovulation, because your embryo transfer is going to depend on that. Whereas when you do an HRT cycle, once the endometrium reaches a particular level, you just start the progesterone and you can just do the embryo transfer. So if you're ready to do a stringent monitoring, then always a natural cycle or an ovulation induction cycle for FET is preferred. So that is the reason why the hypertensive disorders are increasing in pregnancy, because there was 1 or 2 papers which said that FET a freeze-all cycle with the subsequent FET results in higher pregnancy rates. So many people have moved to that, but now a lot of research all over the world has been done, and they said that no, wherever possible you should do a fresh cycle only in indicated cases. One is PCOS with hyper-response is one of the indications, and where you're doing a PGT, where you're going to do a pre-implantation genetic diagnosis. These are the 2 main indications where you do a freeze-all cycle. Otherwise, most of the other cases, it's best to do a fresh embryo transfer.
Yeah, so that you bring down all these complications. Thank you. Thank you.
Thank you so much.
The next, I would like to invite Dr. Sagar Reddy, who's the president designate and assistant professor. At present, he is at the Vaidya Institute of Medical Sciences and Research Center, and his major achievements are that he's a gold medalist in DM endocrinology, and he has 7 papers published to his credit. He would be speaking on denosum, teriparatide, and biphosphonate. When and what order? Dr.
Thank you,
Sagar
ma'am.
Reddy.
Thank you very much. Good morning, everyone. So my presentation is regarding bisphosphonates, denosumab, teriparatide, when and what order for osteoporosis. So osteoporosis includes low bone mass and architectural deterioration, which can increase the bone fragility and susceptibility to fracture. So coming to Indian scenario, around 230 million individuals are there above 50 years of age. And according to various small studies in India, the prevalence of osteoporosis ranges between 8 to 62% in Indian postmenopausal women, whereas in men over 50 years, it is 8.5 to 24.6%. And on an average, we encounter around 440,000 hip fractures per year, and the ratio between male to female is about 3:1. So females are more affected than males. So because of this, so let us see the indications for the management. So IOF has laid 5 indications for postmenopausal women and men more than 50 years for treatment. That is a hip or vertebral fracture or prior fractures with low bone mass, that is T-scores between -1 to -2.5 at any 3 sites. T-scores of very low bone mass, that is T-score less than -2.5, and low bone mass with other secondary causes like glucocorticoid use or total immobilization, or low bone mass with a high risk of fracture which has been assessed by Frax-Stool, that is 10-year probability of a hip fracture more than equal to 3.5% or 10-year probability of major osteoporotic fracture more than 10.5%. So what are the medications available for the treatment? So yeah, FDA has approved a few drugs, that is we can categorize them into anti-resorptive and osteoanabolic. So anti-resorptive includes SCRMs like raloxifene, bezoxifene, which mainly inhibit production of rank ligand, thereby reducing the proliferation and differentiation of osteoclast, and also increases osteoblast proliferation. Denosumab, which is a rank ligand monoclonal antibody, which blocks the rank ligand and inhibits the osteoclast proliferation. And bisphosphonates, mainly the nitrogen-containing bisphosphonates, that is alendronate, risedronate, ibandronate, and zoledronic acid are used. So they mainly inhibit farnesyl pyrophosphate synthetase, which inhibits the binding of osteoclast to the bone matrix and hence prevents bone resorption. Osteoanabolic, we have 3 drugs, that is teriparatide, which is 134 PTH analog, abaloparatide, which is N-terminal PTH-RP analog. They both act through PTH receptor and increases the bone formation, whereas romosozumab, which is an anti-sclerostin monoclonal antibody, inhibits the synthesis of osteoblasts. So among these, how do we select? So let us see this case scenario. So 65-year-old female was admitted with a right trochanteric fracture sustained following a fall in bathroom. So the patient already underwent intramedullary nailing, but during surgery, surgeon felt that bone was slightly osteoporotic and endocrinology opinion was sought. So this is the most common way we get referral for osteoporosis, not before the fracture, but after patient has sustained a fracture. So how do you manage? First, initially, we evaluate and see for secondary causes. And once all the secondary causes are ruled out, we give the general management, that is adequate calcium, vitamin D supplement, and of course, prevent further fall. But what drug to be selected? So choosing an osteoporotic agent, we can divide them into 2 classes. Either patient who has sustained fracture or who didn't have a fracture. So the patient who have prevalent fractures, we can categorize them into vertebral fractures and hip fractures. So patients with a vertebral fracture, teriparatide is the first line of drug. So that has to be given for a maximum of 24 months and then has to be shifted to an anti-resorptive agent. We'll be discussing about that. The second, if patient is not willing or does not want an injectable, zoledronic acid is, that is IV zoledronic or denosumab are the second line, and later oral bisphonols can also be tried. For hip fractures, definitely IV zoledronic acid is the first line of choice. We have plethora of data saying that IV bisphosphonates improve the BMD hip or femoral neck BMD and also reduces the fractures, hip fractures. Denosumab does equally good job as zoledronic acid, but it has its own problems, that is it is not bound to the bone. So as soon as you stop zoledronic acid, whatever the BMD has been achieved will start going down. Second, how to switch it to how do we change to another drug is an issue which we'll discuss. Third, teriparatide, we have very limited data regarding teriparatide and prevention of hip fractures. So definitely hip fracture, we have to give IV bisphosphonate zoledronic acid as in this case. So coming to our second case, here a healthy 60-year-old woman underwent a routine health check and everything was fine. A FRAC score was calculated. 10-year probability of major osteoporotic fracture was 11.5%. So she is a high risk for fracture. And DEXA was done. Spine DEXA, the T-score was minus 2.4, whereas total hip, it was minus 2.2. So definitely there is a low bone mass with a high risk of fracture. So how do you proceed over here? Again, we need to rule out the secondary causes of osteoporosis, general management, adequate calcium, vitamin D supplementation, prevention of further falls, and of course, muscle strengthening exercises should be advised, but what drug to be selected? Yes. So the patient who didn't have a fracture, so with the use of FRACs, we can divide them into a low risk, intermediate, or high risk or very high risk category. So the patients who have very high risk are directly fit for therapy, whereas others we can go ahead with do an DEXA. And based on their BMD, we can again categorize them into low risk, high risk, or very high risk. Very high risk is the patients who have already have a multiple fractures, or high risk, low BMD, that is less than minus 2.5, and low risk. So those with very high risk and high risk definitely require a therapy, preferably an anabolic agent, that is teriparatide, for a maximum of 2 years, followed by an anti-resorptive. Or we can go with denosumab or bisphosphonate. Denosumab, once started, has to be, risk fracture assessment should be done in 5 to 10 years once. And bisphosphonate, depending upon oral or IV, 3 to 5 years. And those with a low risk of fracture, reassessment every 2 to 4 years. So for this patient, which falls into high risk, we can either start bisphosphonate or denosumab. So the same patient, now she was started on alendronate 70 mg weekly once for 2 years. Now a repeat DEXA was done after 2 years. As we see, the T-scores have actually gone up. At spine, from minus 2.4, it has gone to 2.7, and at hip, minus 2.2 to minus 2.5. Yes. So even on therapy, the patient is deteriorating. So what are the causes? There are 4 important things we need to look over here. Compliance to medication is an oral therapy weekly once, so is she compliant or not? Second, is it getting adequately absorbed or not? So for these 2, we can do a bone marker test and see bone resorption markers and see if they are elevated. Definitely it is not working. Third, have we correctly diagnosed as a postmenopausal osteoporosis or as a secondary osteoporosis? So yeah, we need to recheck our diagnosis, and once all these things are sought, then we can label this as a treatment failure. Yes, we need to, now what should we do? Should we switch the therapy, or so when do we consider switching the therapy? So most commonly we switch therapy at the end of an anabolic therapy, that is after 2 years of teriparatide, or like in this case, inadequate response to anti-resorptive therapy, a patient persisting to have low BMD or may have sustained a fracture during the therapy, or after 5 years of bisphosphonates, maybe the targets were not achieved, hence we are planning to switch. Stopping an anti-resorptive for various reasons, maybe a side effect or a monetary issue or anything. So how do we switch a therapy? So there are 3 possibilities. Patient who was started on anabolic therapy, we can be shifted to anti-resorptive, which is most commonly what we see, or who has been started on anti-resorptive is being shifted to anabolic therapy, or it can be a weaker anti-resorptive to a stronger anti-resorptive therapy. So let us see these scenarios. So first anabolic followed by an anti-resorptive. So here is a study by PATH study wherein 238 members were included. Sorry, it's not seen. Okay. So 4 groups were randomized. In the first group, the red line, the PATH parathormone was given for first year, and then for the second year, placebo was given. Whereas in the second group, the teriparatide, the parathyroid hormone, was given for first year, and then later followed by an alendronate, that is a bisphosphonate. So if you see in the graph at the total spine, when teriparatide was given, in the both the red and blue lines have a good amount of increase in their BMD, but once the placebo was added, there is a fall in BMD to 4%. Whereas the blue line, after starting an alendronate, the BMD changes persisted and further increased to 12% at the end of 2 years. So yes, definitely at the hip, at the spine, the PTH followed by alendronate helps. But if you see at the total hip and femoral neck, there is a totally a flat line in the red, flat red line, that is PTH, has no much effect on the hip. Whereas after adding an alendronate, the blue line, there is an increase in BMD. Similarly, in data switch study where patients received teriparatide for 1 to 2 years, followed by denosumab, the blue line. So whatever the increment was noticed with teriparatide after 2 years, there is further increase in BMD at both spine and the total hip, the blue line. So definitely we can say that changing from an anabolic to a bisphosphonate, there is definite improvement at spine and hip, which has been seen in PATH and data switch, and also with romosozumab, similar analysis was seen. So with this we can say that yes, after anabolic therapy, definitely an anti-resorptive has to be given. We can't stop just after giving a teriparatide. So coming to the second sequence, that is anti-resorptive followed by an anabolic therapy. So again, coming back to our data switch study, with the second group, where initially for 1 to 2 years, denosumab was given, followed by teriparatide for another 2 years. As you can see, the lumbar spine, the red line, there is actually a sharp fall within 6 months. So the BMD has come down in 6 months, and slow recovery is there, though it is above the baseline, but still it is not significant. Whereas if you see at the hip, there is a further decline for another 12 to 18 months. And the recovery was not complete, it is lower than the baseline. So definitely switching from anti-resorptive to anabolic does not help at hip or at the spine. Similarly, in the structure trial, these patients were initially on oral bisphosphonates, were then transferred to either teriparatide or romosozumab, anabolic agent. So if you see at the hip, the red line, though the final BMD change was 5.4%, which was significant, but if you see at femoral neck and total hip, the red line has totally gone down, and so it is in minus 0.2 and minus 0.5. So we can safely say that denosumab followed by teriparatide or bisphosphonate followed by teriparatide, though some changes may be there at spine, but there is no benefit at hip, and further there is loss of this BMD within 18 months. Interestingly, when a weaker anti-resorptive like raloxifene was tried, followed by teriparatide, there was some spine and hip benefits. So we can say that this is, this is a last resort. We can't use this sequence in normal thing. So coming to the third sequence, that is anti-resorptive followed by a stronger anti-resorptive. So if you see this studied by Kendler et al., where the patients initially were on alendronate, were shifted to a denosumab, that is a stronger anti-resorptive. So the denosumab group actually had a better increase in their BMD at both total hip and lumbar spine. So when changing from a weaker anti-resorptive to a stronger anti-resorptive, there is a further benefit. So whereas in this McClung et al., where the patients initially were on alendronate, were shifted to IV bisphosphonate. So after 1 year, though the alendronate group had higher BMD, but it was not significant. And you can see the bone resorption markers, they came back to premenopausal levels in zoledronic acids group. So we can say that yes, after changing from oral to IV bisphosphonate, though we may not expect a very good increase in their BMD, but it will not be a loss also. So the same thing, summary, after shifting from a weaker anti-resorptive to a stronger anti-resorptive, yes, we can find some benefits. So finally, summarizing the three sequences, the best one would be the anabolic followed by anti-resorptive. Second will be a weaker anti-resorptive to a stronger anti-resorptive. And third, in the last, whenever it is required, we can shift from anti-resorptive to an anabolic agent, but not much of benefit. So another interesting is a combination therapy. Instead of going for a sequence, why can't we add both? That is anti-resorptive and anabolic agent. So this was seen in this PATH study, the third group, where the combination of PTH and alendronate were given for 1 year. But if you see at the total spine, the yellow line is along with the blue and red line. So monotherapy is equivalent to the combination therapy. So there was no much benefit at total spine. But at the total hip and femoral neck, if you can see that it is actually better than teriparatide, but not with, than alendronate monotherapy. Similarly, the data trials where the patients were randomized to either teriparatide or denosumab or combination of both, the combination had a better BMD at all the three levels, that is at spine or femoral neck or total hip. So combination therapy may fare better than monotherapy, which was also seen in this data extension trial where the BMD persisted in the combination group than the alone. So yes, so we can summarize that data, and data extension trial did say that the combination is better than monotherapy, but other studies have shown that it may not be so much significant. So we don't have a definitive data to say that yes, combination therapy should be tried in all. And there are some CVETs, as the cost, it is not cost effective, than monotherapy. Second, the side effects may be higher with combination therapy than the monotherapy. So keeping that in mind, only selected patients can be taken up for the combination therapy, later shifted to an bisphosphonate. So finally, so the take-home message is osteoporosis requires lifelong management. So the optimal management must be individualized, and to achieve that final goal, we can take any path. So the most optimal path will be initiating with teriparatide, then going for denosumab, then IV bisphosphonate. But the most cost-effective will be oral bisphosphonate to IV bisphosphonates. And we can definitely go from teriparatide to IV bisphosphonates or denosumab to IV bisphosphonates. So finally, we need to achieve the goal of prevention of future osteoporotic risk fractures. Thank you.
Okay, thank you, Dr. Reddy. I think it was a very well captured presentation with very, very strong take-home points, no doubt. But I think it is for those who are managing osteoporotic fractures. Well, a good percentage here are those who would like to prevent osteoporotic fractures. So since we have an active menopause society in Bangalore, and currently I have the privilege of being the president for the current year, we have been driving home the point of prevention. I just want to know from you your take-home message on should 60 be flagging for doing a routine DEXA score? What is your message for assessing the risk of fracture? When should it begin?
Yes, ma'am. So all postmenopausal women have to undergo, they have to be first evaluated with FRAC score. And if they are coming under high risk or very high risk, definitely they have to get a DEXA scan done, the spine or hip. Okay. For women. For men, it is more than 50 years.
Yeah, and I could see some difference in the molecules used, whether it was for the spine or the hip. So can you tell us why did you choose some other?
Yes, ma'am. So finally, at the hip, it is the IV zoledronic acid, which is the first line of agent. Denosumab can be used, but it has its own problem. That is, switching to another agent is an issue. But definitely, it is also a good molecule. Teriparatide for hip prevention of hip fracture or sustained hip fracture will not help much. So, whereas at the spine, teriparatide has the best outcome, followed by potent anti-resorptive, that is IV zoledronic acid or denosumab. Yes, ma'am. So
by the change of treatment, yeah.
So as we have seen in PATH study and data study also,
Yeah, so it
the
is evidence-based. It's an
teriparatide does
evidence-based.
not increase the BMD at spine much
Okay.
because of
Okay, so accepted. My question is the cost. What is the cost? Yeah.
So obviously anabolic agent is costlier. Maybe around per month it may cost around 10,000. So whereas IV zolintronic acid, it's just a one-time injection per year. So it is around 4,000 injection. So obviously
but
anti-resorptives are
the treatment that you are recommending, and the cost seems to be high.
but in the long run, if they have not sustained the fracture, yes, ma'am, that will.
It is high. Yeah.
One question.
Yeah. Yes, please.
Like in your IV zolintrate, whatever you are giving, what is that which makes you stop, like in some moment, like any side effect which will warrants you to stop it and not to go ahead with it? Anything in your experience, like?
As such, in my experience, most of them had a initial drug reaction for 24 hours,
Yes.
but that is done. IV zolintronic acid, no. They can have osteonecrosis of jaw or atypical femur fracture. I have seen only 2 atypical femur fractures till now. So, yes.
Because first of all, the complaints of our patients is something like not so much like
But
accepted.
IV zolintronic acid, as it is a one-time injection, most of them agree.
I have a question. So if you are giving bisphosphonates to the patient, how you will continue for 5 years, isn't it? How long you will continue?
Bisphosphonates, ma'am. So actually, IV bisphosphonates, at least after 3 years, you need to reassess if the BMD has.
No, again, you can repeat.
Again, we can give. Yes,
How,
ma'am.
how many times you can?
It can be continued. That's what, ma'am. It's a lifelong therapy. So, but only thing, as the treatment duration increases, the complication, that is atypical femur fracture or osteonecrosis of jaw increases. So we need to give drug holidays in between.
Sir, I want to know the combination of the drug that you told treatment, does it contain vitamin D part?
Sir, vitamin D is a part of general management. This I have told only as osteoporotic management. In the general management, definitely we need to give adequate vitamin D, calcium. That is there. That is part of, that is the first part of the treatment. Then the osteoporotic agent has to be.
Yes, sir. In the treatment management of osteoporosis, I think vitamin D should be stressed, and because nearly 87% of the Indian population are suffering, 50 to 87, the figure changes. You must make it mandatory in the treatment of the osteoporosis, vitamin D. I feel so. Is it correct?
Yes, sir. Yes, definitely.
So is there any change in the molecules which you use for a post-cancer patient, post-cancer therapy?
Yes, ma'am.
A breast or ovarian?
So there we need to think of, as a secondary cause of osteoporosis, and definitely depending upon their risk, that is they are high risk or very high risk, that is prevalent fractures are there or not, either we can directly go for anabolic therapy followed by a IV bisphosphonate or a bisphosphonate therapy.
Sir, I would like to know, since you have spelled out a long time treatment, lifelong treatment, what are the likely side effects and complications of drug adverse reactions, sir?
For all this, sir. So bisphosphonates, as I told you, sir, the osteonecrosis of jaw and the atypical femur fractures are the one which we should be worried. Yes, teriparatide is only for 2 years, and most of the time, it is just an injection site reaction. That's all. And coming to again denosumab, it's same as your bisphosphonates. That is osteonecrosis of jaw and atypical femur fractures are common.
Hi. How long do you give calcium and vitamin D supplements? What the vitamin D levels do you aim for?
Yes, ma'am. So
do
calcium.
you need to keep checking vitamin D and how often?
Yes, ma'am. So calcium supplement and calcium and vitamin D is for osteoporosis is lifelong. So you need to continue them, and maintaining vitamin D above 30 is sufficient, ma'am.
Yes, so I thank both the speakers. Probably you can ask.
Last. Is there any method to prevent osteoporosis?
Yes.
How,
So how frequently should we check?
Vitamin
If
D.
patient is on supplement, no need to keep checking, ma'am. if patient is on supplement, compliance is there, monthly once of 60,000 IU of vitamin D, no need to repeatedly check, I mean, we should repeat the vitamin D levels.
So monthly once lifelong person can use.
Sir, for prevention of osteoporosis, yes, sir. So we have so many methods to identify high-risk individuals for osteoporosis. So we can follow that, or we can apply this, as I told you, to apply FRAX score. FRAX India's tool is there online for all postmenopausal women and men more than 50 years. And then we can go ahead with further management of them.
So I thank both the speakers, Dr. Deep Datta and Dr. Sagar Reddy, for their excellent talks. And if you have any further queries, you can catch them during the lunch and you can clear your doubts. Thank you. And I thank Dr. Anantharaman for giving us the opportunity to chair this session on behalf of all three of us. Thank you.
Pushpa to come on to the stage. And I think, we can just, have lamp lighting ceremony with Madam. Can I call Dr. Lata Venkatram to help, do the lamp lighting, please, ma'am? Photo thing. Madam, first.
शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिः परब्रह्म दीपज्योतिः दीपज्योतिः परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपं
Ma'am, please say a few words. I think it's not possible without IMA involvement. So, medical conferences of this sort, I think Dr. Pushpa has, helped me organize several conferences in the past. I think we didn't do anything for the last 3 years due to COVID. And I thank Dr. Pushpa mainly, and I want Madam to say a few words and we can proceed with the rest of the meeting. Yeah, ma'am.
Good afternoon, all. I'm so happy to see all of you on Sunday. And I congratulate Dr. Anantharam, and I'm thankful to Magna Trust. Every time they, through IMA, why they are doing is to get the CME credit points. And I just do one signature, everything he only does, all formalities. And he has all supporting staff to help him. And he's doing very good job. I'm very happy to support him. Thank you very much. All the best.
Thank you. Thanks for all of you to, taking time from your busy schedule and coming over to the next for this great event. I mean, without, the participation of faculty and more importantly, delegates. So, I mean, there's no exchange of knowledge, or knowledge doesn't grow actually. I mean, there's definitely, even there are so many meetings, but in every meeting we learn something new. So that's the purpose of our foundation. So Magna Code Healthcare and Education Foundation is not for profit Section 8 company which is indulged in doing CMEs for doctors mainly, and hope we are able to do some more even in the light of the present regulations and all that. So we'll try our level best to continue our activities. Thank you.
And this is not at all related to endocrine thing, but evening from IMA, myself and Dr. Chandrika Dutt from Apollo Hospital, we are demonstrating CPR. So please attend, it is just 20 minutes. So in emergency situation, what to do, you may be knowing, but now Indian guidelines have come. Our Indian Resuscitation Federation has come up with guidelines. All these days we are following American Heart Association, and they are same, but just through Indian Society of Anesthesia and Indian Resuscitation Council, we are demonstrating. Please do attend. Thank you very much.
Over to Prithvi, who's our young endocrinologist from Hyderabad. He'll be the next MC. Yeah.
Thank you, sir. Thank you so much. Now moving on to next session. In this session, we are going to discuss pubertal disorders in girls. For this session to chair, I would kindly like to ask Dr. Chandrika Anand madam to come onto the stage. Dr. Chandrika Anand madam. Okay. Dr. Mekala Dwarkanath madam to come onto the stage, and Dr. Shefali Tyagi madam to come onto the stage. Dr. Mekala Dwarkanath madam is a medical director and consultant reproductive medicine in ICHA Fertility Solutions and Diagnostics, Bangalore. And she is also visiting consultant at the Milan, the Fertility Center, Indira Nagar, and Apollo Cradle, Koramangala. She has many achievements in her prolonged career. She has many publications on her name, and I would like to ask her to take over the mic to introduce Dr. Vijay sir. Sorry. Dr. Shefali Tyagi has 20 years of experience in obstetrics with specialization in complex and complicated pregnancy, as well as many gynecological cases. She is also a member of Royal Australian and New Zealand College of Obstetrics and Gynecologists. She has publications in various reputed journals and has over 150 YouTube videos on patient education, explaining different aspects of obstetrics and gynecology in simple, easily understood language. She has also authored a book on safe journey to motherhood, which is applaudable, and she has many publications. Now I want to hand over the mic to Dr. Chandrika Anand ma'am. Sorry.
Good afternoon. I'd like to welcome Dr. Vijaya Sarthi, who's the endocrinologist, and she is presently affiliated with Dr. Sarthi's Diabetes Endocrine Nutrition and Wellness Center, Bengaluru. So in her awards and recognition, he is the Best Super Specialty Resident Doctor of 2011 and Young Researcher Award of 2013. So please, Dr. Vijaya Sarthi.
Thank you. So, very good afternoon, everyone. So, it's going to be a very interesting topic, indeed, probably a curious topic. The precocity in girls. So, why is it on the rise? Why girls are developing puberty earlier in these days? So, if you look at this fantastic meta-analysis published recently in JAMA Pediatrics, there's a clear and consistent, though it's a slow decrease in the age at onset of puberty. So, but the question rises, why? So indeed, like as all of us are aware, so there's a rampant increase in the prevalence of childhood obesity, which is actually one of the very important causes of early puberty. As you can see in this beautiful meta-analysis, the overweight as well as obesity was associated with almost around 2.2-fold higher risk of early puberty in girls. So indeed, like we know that it's not just obesity, there are several other factors which could confound the association of obesity and early puberty. So and to nullify these factors, there was another interesting study where they tried to match the siblings and analyze the impact of BMI on the onset of obesity. Again, in this interesting study, as you can see here, the age at onset of breast development, that is stage 2 breast development, was decreased by almost around 2.5 years in those girls who are overweight and obese, that is with a BMI of around 22, when compared to those who had a BMI of 12. So even it's also there in the boys, but not significantly. And if you look at the effect of BMI on the completion of breast development, that is Tanner stage 5, again there was a rapid, there's a drastic earlier onset of completion of puberty in those who had a BMI of 22 compared to those who had a BMI of 12. So, but this probably was a slightly less pronounced effect with only a decrease of around 1.5 years compared to around 2.3 years with respect to the onset of puberty, that is stage 2 development. So it's also true for the pubic hair. There's the onset of pubic hair is also a little earlier in obese girls, also in obese boys, but is only around a factor of around 0.5 years. So also for the Tanner stage 5 development, there's a completion of the pubic hair development. There is a significant preponement both in boys and girls, and it's maybe around a factor of around 1.5 years. So we know that it's obesity probably, and also looking at another scenario, what happens if there is an acute nutritional rehabilitation on the puberty and in comparison to the chronic obesity we talked about in the previous slides. So probably the best scenario we can look at for this is actually the adoption, especially from the underdeveloped countries to the developed countries. So as we can look at this data, those who were adopted before the age of 4 years are the ones who increased their BMI rapidly from 1.7 to 2.4, and they're the ones who entered puberty as early as 6.5 years. So if we compare that with the next cohort who were adopted after the age of 5 years, indeed they also entered puberty, but at the age of around 7.2 years. So definitely there is a strong role for obesity in the girls who are adopted at an younger age, less than 4 years, but probably for those who are adopted after 5 years of age, there is a more role for the psychological factors, which I'm going to come up a bit later. On the other hand, so we know that the obesity is a risk factor, and also the rapid increase in BMI is a risk factor. But are we able to prevent this earlier onset of puberty, if at all, if we give weight loss for these girls and boys? So let us look at this interesting data. Indeed, in this study, the girls who reduced weight over 1 year, they were less likely to enter into puberty. But it's the vice versa on the boys' side, because the boys who lost weight were more likely to enter into puberty. So at least today we are talking about the girls. So if the girl is obese, she is around 6 or 7, definitely you try to make them lose weight. You can definitely delay the onset of puberty, at least in a proportion of them. So what is this association? Why this obesity is associated with the puberty? Where does it comes along the HPG axis? So indeed, it's actually not the direct effect. It's just a permissive effect, and that is typically mediated through leptin. We know that leptin is a hormone which is proportional to the fat mass of a given person, whether it's a child or an adult. And this leptin has a permissive action at every level of the HPG axis, which may be hypothalamus, or it may be pituitary, or even the gonad. So not only that, it also has action on the adrenal gland, where it increases the adrenal androgen production. That's also the reason why we could appreciate even the advanced puberty in some patients. Not only that, even it also has direct action on the epiphyseal growth plate. So there could be sometimes a small discrepancy in relation to the pubertal staging and a slightly advanced bone age, which could still be appreciated in obese girls. And again, it's because of the direct effect of leptin on the growth plate. So is it just obesity, or it also matters on what the children consume? So let's look at this data. So probably this next slide I'm going to do that, but probably this is again the nutritional factors we're looking at. So what happens to breastfeeding? Probably like we know that there are several advantages of breastfeeding in several aspects of health, but what is its effect on the early puberty? So definitely the longer the breastfeeding was, or at least 6 months of breastfeeding was associated with a significantly later onset at breast development in girls. So we know that the breastfeeding is beneficial to delay the onset or to prevent the earlier onset of puberty. So what about the consumption of total energies or carbohydrates or proteins or fat? So if you look closely, it was only the intake of the proteins actually which increased the earlier onset of puberty. Again, there are a lot of discussions why the excess intake of proteins is actually leading to earlier onset of puberty. The one proposed mechanism is actually increased production of IGF-1 in those who have increased protein intake. That probably would be enhancing the bone age advancement and in turn the earlier onset of puberty. But there could also be other issues linked to this. So as I'm going to take up in my next slide. So but in this slide we also look at what about the milk and dairy products, are they going to have any effect? In fact, the effect was not there, but yogurt definitely had an effect. Those who consumed good amount of yogurts in their early life actually had a relatively later onset of puberty. So yogurt is going to be protective on the earlier onset of puberty. Again, the answer is not very sure, but probably we know again the lot of role is coming for the gut microbiota and the several health regulation. So probably the yogurt consumption may alter gut microbiota in such a way that it's altering the puberty, but we are still missing the link. As I told earlier, the proteins were actually advancing puberty, but is it only the IGF-1 increase, or is also because of the adult trends which we see in the proteins? As you can see here, the study from Saudi Arabia, those who had chicken and beef in excess were the ones who had early puberty. I also mentioned in one of my previous slides the carbohydrates were not significantly associated with early puberty, but is it all or none phenomenon, or is there a relation? Indeed, if you see this particular study, those who consumed a simple carbohydrates, typically in the form of the fast food and French fries, and also in the form of soft drinks, were again more likely to develop early puberty. So though overall carbohydrate intake may not matter, but someone who consumes excess of simple carbohydrates are definitely at higher risk of having an early puberty. Of course, even not only the onset of puberty, even if the age at menarche is closely related to the consumption of the red meat as well as the poultry. So again, it may be a dual effect of both protein intake as well as the estrogen contamination of these products. What about the vitamin D? Again, vitamin D is making a buzz in every area. So what about vitamin D in this particular scenario? So again, the vitamin D deficiency is associated with significantly higher risk of early puberty. So indeed, if you look at this almost by again 2.2-fold higher risk of early puberty. So it's more so in China. So probably it's also applicable for Indians because we closely resemble them being Asians. And even there was a stronger association with those who had a deficiency when compared to those who had an insufficiency. So probably we need to keep the children vitamin D sufficient, not only for the bone health, but also to encourage a timely puberty in them. So I think the COVID-19, again, it has brought up so many changes in our life. So what is it bringing to the onset of puberty in girls? So we know that there was rampant increase in the childhood obesity. This could be a reason, as also we can see the proportion of patients who had central precocious puberty was significantly increased from 2019 to 2020. But again, after the COVID has gone off our life, now the chances of CPP have come down. So one possibility for this could be obesity itself, but the second could be a stress. So probably, again, the stress is something which is going to play a major role, which also reflected in this particular study. Those who had a early life household intactness, they had a relatively later onset of puberty, whereas those who did not have this, probably those who had like a single parent, they had an earlier onset of puberty. So let's move on to understand what is the role of phytoestrogens on the onset of puberty. So there were several studies which showed that probably the exposure to higher phytoestrogen levels will lead to earlier breast stage development, but equally good number of studies which either said there is no effect or probably there may be a later onset of effect. So we need to take the effect of phytoestrogen with a pinch of salt as of today. But when it comes to endocrine disrupting chemicals, there is no question about it. Indeed, like there's a large number of studies which have consistently shown that the peripubertal exposure of these endocrine disrupting chemicals, maybe phthalates, maybe bisphenol A, they are significantly associated with earlier onset of puberty. I think this point was already highlighted by Dr. Deep with respect to the fertility. So indeed, like the holistic studies which are looked at also brought out some association of sleep deprivation on earlier onset of puberty. So, and also the passive smoking, like somebody is smoking in the family and these girls are getting exposed to passive smoking, they're also likely to get, develop puberty a bit early. So with this, let me move on to briefly discuss like whenever a girl comes with early puberty, how do we manage them? So, and the first thing is, why should we treat them, right? We know that like when they enter early puberty, so of course, this is a disastrous case which happened like many decades ago. So they will attain the reproductive potential and then they can become pregnant as early as less than 10 years of age. And on the other hand, so which is the common scenario for us is that they may not be able to handle the menstrual cycles, especially the hygiene part. And they may also have some psychological issues when they enter into puberty where none of her peers into puberty. Other important aspect is the physical stature. In fact, like we may be happy to see these girls who are in the age of 6 or 7 or 8 because they're taller than all their peers. But if you look at the future, they're going to be the shortest of all their peers because they may be tall at initial years, but they fuse their bones faster and they end up as short in the adulthood. So of course, this is a very well-known sequence of events that happens in puberty that starts with the breast development, followed by pubic hair appearance. And in stage 3, there's typically the growth spurt, that is the peak height velocity, followed by menarche. So how do we define precocity? Anybody developing breast development before the age of 8 years, we define it as a precocious puberty for girls. And in fact, like why this data came is actually from the initial studies of Caucasian, and where the lower end of the 5th percentile to enter into puberty was actually 8.45 years. But the point I would also like to share here is that like in the Caucasians, especially in the African Americans, the onset of puberty is much earlier. Indeed, they have revised the definition to define precocious puberty to 7 years in Caucasians and 6 years in African Americans. Probably we are on that verge, though we don't have much data to look at the secular trends in India on the onset of puberty. If we do a proper study, I'm sure at least we'll reach a level of 7 years to define precocious puberty. So earlier we used to think that pubarche is going to occur only in patients who are going to have an precocity before 6 years of age, whereas, the other way around, like those who have a precocity after 6 years of age, whereas those who have precocity before 6 years of age may not have pubarche. Indeed, we recently published a data in Indian Pediatrics that it's not true. The pubarche can appear as early as 3-year-old girls, so which actually contradicts this old belief. So how do we classify precocity? Just to briefly say, it may be a gonadotropin independent, where there is an excess sex steroid production directly from the ovary without stimulation from the hypothalamic pituitary axis, whereas the most common variety what we see is actually the central precocious puberty, which is dependent on the GnRH and the gonadotropins, where the ovaries are producing estrogens via the signals of the hypothalamus and pituitary. When we talk about the spectrum of central precocious puberty, we start from the normal variant, that is the premature thylache, which is almost non-progressive, whereas then we come through something called as a solely progressive CPP, which progresses to progressive puberty. If you look at the premature thylache, it's very common in younger children, less than 3 to 4 years of age, whereas the other two variants are more common in children who are between 6 to 8 years of age. So again, if you look at the gonadotropin response, you can see here in the first AB, it's actually premature thylache. The LH response is not that great, but they will have a predominant FSH response, that's the black arrows. Whereas in the C, so that there is slowly progressive puberty, both LH and FSH response is not that great. Whereas in the right-hand side columns, where there is a central precocious puberty, there is a profound LH response. Indeed, this is how we are going to differentiate the two conditions. So those who have a LH response of more than 5, so they are the ones who are more likely to have central precocious puberty. But in a very young child, if you have, be careful that this increase of more than 5 is not concomitantly associated with a profound response. For example, somebody who have a LH of simulated LH of around 6, but FSH is around 30, definitely it is not just central precocious puberty, very likely to be a premature thyroid who need to be followed up rather than being treated with gonadotropin analogs. So indeed, like we always have a question also, like though we know that the LH basal, which is more than 0.3, is suggestive of a central precocity, how specific is it? So, but again, looking at this data, it says that even if you have 0.3 to 1, it is still good to go ahead with a GNR stimulation test to confirm the central because having 0.3 to 1 is not uncommon in the premature thyroid group as well. So, but if once you stimulate, if it's more than 5, but not associated with the concomitant FSH predominant response, then we know it's a CPP, and then we need to treat that. So coming to this quick case capsule, 7-year-old girl with breast bud, bone age is advanced to 10 years, and basal is 0.65. As I told earlier, it's not more than 1. So we need a GNR stimulation test. We did that. It's more than 40, and FSH was 15. So we know that it's a predominant LH response, and the diagnosis is central precocious puberty. So and definitely we need to treat that. Ultrasound is also revealing the enlargement of the uterus. We know that when it's more than 34 mm, it's an indicative of a pubertal uterus. And next question comes, do we need to do MRI for this girl, whether it's going to be an idiopathic or it's going to be something wrong with the brain, what we call it as organic. Indeed, the chances of having an MRI abnormality comes down significantly as the child of the age increases. So especially between 6 to 8 years of age, somebody is coming to you with puberty, the chance of having an abnormality is only around 3.2%, whereas in younger than 6 years, it's going to be 7%. So what we do is that if in this particular age group of 6 to 8 years, unless they typically come with some neuroophthalmic features like a raised intracranial tension or a visual field disturbances, usually we don't order an MRI. But however, this child we ordered, and there was an hypothalamic hematoma sitting over there. And once we know that she's a CPP, we need to treat. What are the armamentarium we have to treat? Typically, long-acting depot preparations of GnRH analogs. Though they're agonists, when we give in a high dose in the long-acting form, over time they become antagonists, suppressing the HPG axis. Typically, it's not indicated for the premature thyroid or the slowly progressive puberty, but indicated only for the progressive central precocious puberty. Indeed, if you have any doubt whether it's a progressive or non-progressive, no harm in waiting for 6 months and then looking at the progression of the puberty. That probably will justify our management. So another important point that actually it's there, like even the guidelines say if it's less than 6 years at onset of puberty, you treat them with GnRH analog therapy, it's going to give a height benefit. If it's more than 6 years at onset of puberty, there is probably the height benefit is very minimal, so you may or may not consider treatment. But this recommendation was based on this study. If you look at closely at this study, the first group is actually less than 5 years, whereas the second group is predominantly after 8 years. Indeed, there is no clear data to answer the question, what should we do for 5 to 8 years? So, and let's move on to another interesting study that where we have this data. Here you can see that those who had less than 6.4 years, more than 8.3, and 6.4 to 8.3. So there is no doubt, as also recommended by the guidelines, we have to treat those who are less than 6.4. Definitely we are going to increase the height SDS by at least around 0.6. But when we treat more than 8.3, we are not going to make any big difference for them. So there is no need to treat them. But 6.4 to 8.3, there is definitely a benefit of 0.2. But obviously, it's true that all of them are not deriving benefit. Only few of them are deriving the benefit. So who are them? They're deriving the benefit. Those who have a larger gap between the chronological age and the bone age, they're the ones who are going to derive a greater benefit and who require treatment. As you can also see here in this, those who derived a good benefit had a bone age minus chronological age of 2.7 years versus 1.9 years for the other group. So as coming back to our patient, so we started this patient on GnRH analog therapy, which almost like increased her height from the predicted of around 140 to the real achieved of around 154. So definitely it's a great boon for this girl. So to summarize my talk, so we have several modifiable risk factors for early puberty. So starting from obesity, stress, decreased sleep, excess protein intake, especially poultry and meat, exposure to phytoestrogens, endocrine disrupting chemicals, as well as the passive smoke. So we know that many of these are modifiable. Probably if find someone around, definitely we need to modify it. So if you look at the puberty in a girl aged, coming at the 7 years of age, they require definitely evaluation. Most likely it is an HPG axis activation, that is the central precocious puberty. And slowly progressive variant should be differentiated from the true CPP. And unless it's indicated, no need for GH analog therapy. MRI brain could be reserved for those who are aged less than 6 years at onset of puberty, unless they manifest some neuro-ophthalmologic involvement. And GNH analog therapy for CPP within the age of 6 to 8 years should be offered, especially for those who have a longer chronological age to bone age difference. Thank you so much.
So thank you very much. I think it was a very elaborate talk which covered everything, including the stress factors, the diet, which is very important in bringing up a child, and you even spoke about the COVID-19 effects. So do you think there is any connection between the higher number of hours of screen time during the COVID for all school-going children with the age of early onset of puberty? Is there anything at all?
There could be definitely, ma'am, but usually we know that the highest screening time is indeed one of the very important causes for the obesity. So I really don't know whether this higher screen time has a direct effect on the onset of puberty, but definitely indirectly through increased obesity, it should contribute for early puberty.
Thank you so much, sir. I think everything else has been covered in this and may not be any more doubts.
What I have heard is gonadotropins are given to the cows. Hello? Gonadotropins are given to the cows. Hormones are given to the cow. So the girls who drink the milk, they have early puberty.
Could be, I mean, in fact, like that could be one of the possible reasons, but we don't have any data who looked at that. But I do believe whatever is the form of excess estrogen exposure, so that should be contributing for early puberty.
Role of growth hormone in precocious puberty, when do you use it?
Right. So, ma'am, usually if at all, if we have a patient, we analyze something called as a final predicted adult height, so without treatment and with treatment. So one is with GNH analog therapy, one is GNH analog therapy with GH. So whenever the predicted adult height with GNH analog therapy alone is not able to reach the final adult height which is actually desirable for that particular child, in that scenarios we try to give a combination of GNH analog therapy with GH.
How soon, may I ask you? Assessment.
We do assess at the diagnosis of precocious puberty only, ma'am. So we do calculate the final predicted adult height at pubertal, the onset of puberty itself. So if there is a clear answer, yes, with GNH analog therapy alone, this girl is going to reach the final adult height, we don't consider GH in that particular child. But if we feel that like GH analog therapy alone is not going to give the final desired height, we do start GH therapy with the GH analog therapy from the beginning of treatment itself.
Here, I have two doubts. One is on 6 years being a cutoff. Any reason for that? The second thing is what is the long-term follow-up of these girls in terms of fertility or further menstrual behavior and the need for treatment in future? What kind? Do they they are at risk for an earlier ovarian insufficiency because they have started so early and all that? Yeah.
Yeah. So like definitely to the 6 years actually came out from the data only, ma'am. So like when they treated with GNH analog therapy for less than 6 years, there was a clear benefit of height benefit. So that's why they started saying that you less than 6 years to treat, more than 6 years we were doubtful. So whereas coming to the early onset of puberty, again definitely early cessation, it is there. Definitely they are at least 1 to 2 years they cease off early when compared to those who had a later onset of puberty. But clinically it's not very significant when it comes to fertility issues because most of them complete their families by 40 years. And again, once we stop the GH analog therapy, how soon they develop a pubertal progression? It's typically around like 3 to 6 months later they start progressing. By the end of another 1 to 1.5 years, most of them will attain menarche.
Yes.
There's maybe like there are two reasons why we consider GH analog therapy between 8 to 10 years. So if you look at whether psychological trauma is there for the child, definitely your answer is yes. But are we going to give for also the height benefit in between 8 to 10 years? The answer is no. But somebody like, for example, parents come and tell us like 8.5 year breast development, my daughter may not handle the menstrual cycles even when if she attains say menstrual cycle at around 10.5 or something. Definitely you can consider, but you are not, by doing that, you are not going to give her any height benefit.
Apart from all the causes enumerated, one more cause may be added, that social cause. In a street where the girls are of the same age, about 4 to 5 girls, if one girl attains the menarche, may not be of the precocious puberty, other girls also I have seen our street, on competition they attain the menarche. Do you agree with this?
So there could be a plausible effect on this. So indeed, like we used to hear about this during my pediatric thing, though we have not explored it much on during my endocrinology experience. But there could be possible mechanisms on that. So, but like not very well spelled out in the studies.
Yes. The long-term effect of the precocious puberty, those who attain the precocious puberty are more prone for cancer cervix in future. Any observation?
Yes, sir. Probably there is small concern regarding the endometrial carcinoma risk in them, but not with any other cancers.
What is the role of
diabetes on puberty?
Effect of? Diabetes on puberty?
Puberty.
I mean, sir, diabetes in the future or before you're saying? No. In the future, sir?
No, child is having diabetes at the age of 4
Juvenile diabetes on puberty.
Yeah.
So usually it will be delayed, sir. So compared to the compared controlled children, type 1 diabetes children, whether boys or girls, they will usually will have a later onset of this one. Whereas the neurological illnesses, they will have a early puberty.
Role of counseling in these girls, at how much do you encourage?
So, ma'am, like it's actually like more than our counseling, it's actually the larger role for the mother will come. So, in the counseling of these children, how to deal with the puberty. So, but probably some children who actually have any issues, usually we refer them to child psychologists or child psychiatrists. But majority of the work is usually done by the mothers and they manage at their level.
Yeah, I had two observations to make. One is that concern is very genuine, because early puberty also means early sexuality.
Yes.
And they may need some specific counseling for sexual debut, and the peer interaction is also very strained in them, because they are at a more advanced sexual maturity. Having said that, they need protection then for contraception and prevention of infection. So that's a different kind of, and a higher, more advanced counseling, as you said.
Definitely. So I absolutely agree with you.
Yeah, yeah. The other thing is the observation some gentleman made about concomitant, pubertal maturity. So there is some role of pineal body activation in groups of women, and it's observed in the dormitory, etc., that in hostel life, I think sooner or later, most of the girls fall into the same menstrual pattern, and dates and their LMPs, etc., start matching up when they live in a group.
True, ma'am. This is what I mentioned, that like we have read
some
about
research like that.
True.
So we don't know about onset of
this
puberty.
is there, ma'am. I agree with you. In fact, like these are data.
Maybe more to do with lifestyle, I think.
Yes.
Yeah.
I agree with you. In fact, these are data we used to read during our pediatrics. But like in the last 20 years, there is no much data which is evolving in this particular area. Thank you so much. If no more questions.
Thank you, Dr. Sarthi. It was a wonderful presentation.
Welcome Dr. Sudhakar Reddy to give his presentation on the next session on hypogonadism in the girls. He's a senior consultant endocrinologist at Magna Centers. He's a consultant endocrinologist at Sunshine Hospitals, and he has spoken in several conferences to his kitty. He's got a huge experience of 9 years plus in this field. I welcome you to give this talk, sir.
Thank you, madam. So, good afternoon, everyone. So, now I am going to speak on this topic, hypogonadotropic hypogonadism in girls. So, complete contrast topic, that is precocious, this is delayed puberty. And in fact, precocious puberty is 10 times more common in girls, and delayed puberty is 10 times more common in boys. Not that common in girls, this entity, okay? So some overlapping slides are there. Normal puberty in girls starts with thelarchy, then pubarchy, followed by menarche. And remember, adrenarche, which is responsible for onset of pubic hair, is independent of gonadarchy. So adrenarche initiates the onset of pubic hair, and gonadarchy is helpful in progression of that hair growth. And next to B1 to B4 stage of breast budding to B4, you require estrogen, but B4 to 5 progression, you require progesterone. These are the simple definitions of abnormal puberty. And coming to delayed puberty, absence of signs of sexual maturation by an age more than 2 to 2.5 standard deviation values above the mean of the population, we call it as delayed puberty. So in girls more than 13 years, no development of breast, that is breast stage 2, we call it as delayed puberty. So it's not a rare entity, but this is much more common in boys compared to girls. But timely assessment and management is mandatory to achieve successful long-term outcomes. So when to assess for this delayed puberty? So naturally, after 13 years, if still there is no B2 stage of breast or no menarche 5 years after thelarchy, that means if there is no progression of puberty, onset is important, at the same time progression of puberty is also very, very important. So if there is no menarche 5 years after thelarchy, then also they require evaluation. And most children with a delayed puberty represent physiological variation, that is CDGP, constitutional delay in growth and puberty, which is a physiological condition. But to label it as physiological entity, you must have sound knowledge of this CDGP and other pathologies. So by and large, we divide this into two categories: hypogonadotropic hypogonadism and hypergonadotropic hypogonadism. These are pathological entities. But CDGP, which is a physiological variant, is common in both boys and girls. So coming to hypo, basically it is due to loss of function at the level of hypothalamo-pituitary. That is the switch for onset of puberty. So this loss of hypothalamo-pituitary function can be reversible. Examples like anorexia, athletes. So that is common, delayed puberty. But it is a reversible entity. And structural or irreversible conditions like you have genetic causes, any trauma, radiation, infection, lesion at the level of hypothalamo-pituitary can cause either delay in puberty or precocious puberty. So there are long-term consequences of this delayed puberty in girls. These are the observations like increased risk for early natural menopause. There are some reports of malabsorption and celiac disease, low IQ, asthma, poor overall health, poor sleep and short stature, and reduced risk for obesity. These are all observational studies. And a recent review on this self-limited delayed puberty by Ju and Chan, they summarize that in some of the patients, adult height may be reduced, and the late menarche is associated with the decreased bone density in early adulthood, and there is an increased risk of fracture in future. And late puberty reduces the risk of breast cancer in females and reduces the risk of testicular cancer in males. Coming to the etiology of hypo, so just now I mentioned any injury or infection or inflammation near hypothalamo-pituitary can cause this hypo, and there are some genetic conditions like classic example Kallmann can cause hypo. So whenever you evaluate for pubertal disorders, whether it is precocious or delayed puberty, think about the hypothalamo-pituitary gonadal axis. In endocrinology, any disorder generally we think about that particular axis. So problem can be at the level of hypothalamus or pituitary or gonadal level. So any metabolic, catabolic or inflammatory stress can cause rise in either cytokines or cortisol excess state. So that is CRH excess will suppress the axis, that is kisspeptin and GnRH, which is a pulse generator. So it is like a switch. So either switch early on or early off or permanent half. That is the problem. So early on is precocious puberty, late on is delayed puberty, and permanent half is permanent hypo. Okay. So this hypo can be physiological or pathological, congenital, organic, or isolated or combined. Sometimes you will have associated pituitary hormonal deficiencies. In addition to gonadotropins, you may have associated growth hormone deficiency also. And this is the approach. So in endocrinology, first we start with clinical history, then physical examination, then biochemical evaluation, then imaging. That is the order we follow. Okay. So delayed puberty with low gonadotropins. That means we are suspecting hypo. So next step is to see the growth pattern. So if it is consistently short for chronological age but appropriate for bone age, think about constitutional delay in growth and puberty, and normal growth pattern with without growth spurt. Then think about this isolated gonadotropin deficiency or Kallmann syndrome like picture, and late onset growth failure, especially with concurrent diabetes insipidus. That is suggestive of, in case if they have associated intracranial pressure or any central neurological issues, then go for MRI. If you find the mass lesion, then approach will be different. But in general, delayed puberty with short stature in girls, unless proved otherwise, it is Turner syndrome. And but in that situation, you will have high levels of LH and FSH. But here we are interested in hypo. So that is a different entity. So in history, definitely you will see some red flag features. So that is the reason history taking is very, very important, so that we can avoid unnecessary investigations. Okay. Clinical history and physical examination, you will get some clues, like for example, if central midline defects are there, so a single incisor and this micrognathia, any midline defect, think about that central level problem. Coming to CD, so there is basically a diagnosis of exclusion. CDGP, constitutional delay in growth and puberty, is a diagnosis of exclusion. So physiological variant of delayed puberty. And here we have two things. One is transient dysfunction of growth hormone axis and delayed reactivation of hypothalamo pituitary gonadal axis, that is lazy pituitary syndrome. So not only this delay in puberty, even bone age will be delayed by 2 years and adrenarche will be delayed, and most important thing is olfaction will be normal in CDGP, Kallmann. And here we have that genetic component, dominant inheritance with incomplete penetration. Variable expression will be there, and majority are lean. Then how to differentiate this hypo versus this constitutional delay in growth and puberty? So not that easy. So you have so many overlapping features. So gonadotropins, according to this Chinese medical journal published in 2015, gonadotropin stimulation test is sufficient to discriminate between HH and CDP in males, but it is not required in females. But see the contrast picture published in JCM. So they have concluded that in girls, overlap of basal values are marked and indicating the need for GnRH stimulation test for differentiating these two entities. So we use this GnRH stimulation most of the times in precocious puberty to prove biochemically. So we have two molecules, decapeptyl comes like 0.1 mg, and one more thing is lupride 1 mg, that is 0.5 ml. So 100 microgram per square meter of triptorelin or leuprolide of 20 microgram per kg. You can give subcutaneous. Simply you can use 100 IU syringe. So differentiation of these two entities, both will have that hypo picture. IHH versus CDGP is not that easy. So inheritance, CDGP is autosomal dominant with variable penetrance, and IHH, that is isolated hypogonadotropic hypogonadism. We have autosomal dominant conditions, recessive conditions, X-linked sporadic. and there is some genetic overlap between these two. So there is a clinical overlap, genetic overlap, and biochemical overlap. Even after stimulation also, it is not that easy. So ultimately, spontaneous or kickstart onset of puberty by the age of 18 years is the gold standard for differentiating these two entities. So why this problem? Because most of the studies are in boys, not in girls. So as such, delayed puberty is 10 times more common in boys compared to girls. That is the reason most of the literature is with boys. Coming to the management, once it is confirmed, then aim is to gradually induce puberty mimicking physiological development. Okay, so rapid induction is not good. We see common blunders even from senior gynecologists of starting directly OC pills. That is not correct. And better to start with estradiol valerate and then micronized progesterone. To start with estradiol valerate of 1/4 of adult dose. Then every 6 months you can increase the dosage. Transdermal estrogen availability is a big issue. In case if it is available, definitely you can go for the transdermal because it is superior to oral estrogen. See the equivalent doses of ethinyl estradiol, starting doses and incremental dose and adult dose comparison. Of course, all these things are available in India. And sometimes, even if you are confident it has a constitutional delay in growth and puberty, that is physiological variant, sometimes to overcome parental anxiety, child anxiety, we may use this low dose estrogen for some period, like for 3 months or 6 months maximum. So in that situation, unlike permanent replacement, minimum dose without incremental in dosage, you can give it for 3 to 6 months and can repeat it again after 3 months if there is no response, with a maximal trial for 1 year, that is 2 attempts. So these are the ideal sites for application of that estraderm patch. So basically non-hairy area, twice in a week you can apply. But problem is in India we have only 50 strength is available, especially in Hyderabad only 50 strength is available. So we want only 1/4 of dose. So in that situation we have to cut it. So that cutting and pasting, leakage issues will be there. That is a problem. But estraderm 50 microgram strength patches are available. So definitely superior to oral, you can try. So when to add progesterone? So confirmed case of hypo started on estrogen, and after 2 years of estrogen therapy, you can start progesterone, or whenever you see breakthrough bleeding or spotting, you can start, or ET, endometrial thickness of more than 5 mm, you can, and breast staging of 4, you can start. Okay. So 200 mg daily of micronized progesterone or 10 mg of medroxyprogesterone for 10 days, like 1 to 21 estrogen and 11 to 21 progesterone. And full adult dose of estrogen should be used till the age of 30 years to mimic normal physiological estradiol peak. Between 30 to 50, you can lower the dose to prevent, so basically lower to minimum dose to required to prevent osteoporosis. And after 50, then assess the risk. So that is the up to the age of natural menopause, you can continue. If it is permanent hypo, up to the age of natural menopause, you can continue. And at the age of 50, depending on osteoporotic risk, you can extend it for next 10 years. And this is the most common blunder we see from gynecologists. Starting of OCP in delayed puberty, straight away giving high dose of estrogen plus progesterone. So do not use this for initiation of puberty. Okay. So after full development, then you can go for this cyclical OCP. So other options, theoretical, practically not that easy. You have gonadotropin regimens, GnRH regimens, psychology of child, handling of child psychology is very, very important. And whenever fertility issue comes, so HCG, HMG regimens, are useful because it is hypo, not gonadal problem. So these are the 10 important points regarding this delayed puberty, hypo. So delayed puberty is 10 times more common in boys, and whenever you evaluate for pubertal disorders, think about hypothalamo-pituitary gonadal axis. And first step in the evaluation of this pubertal disorder is to look for red flags in clinical history and also physical examination, so that you can avoid unnecessary investigations. CDGP, constitutional delay in growth and puberty, is a physiological variant, is a diagnosis of exclusion. Here puberty is delayed but not stalled. And differentiation of these close differentials, CDGP versus IHH, is not that easy. There is a genetic, clinical and biochemical overlap picture. There is no gold standard test for differentiating these two entities. And important thing is bone age. It is a very good reflector of hypothalamo-pituitary axis maturation. So persistently low levels of gonadotropins with bone age of more than 13 years is an otherwise healthy child, is possibility of permanent hypo will be high. And CDGP reassurance is enough, no need of any medication. Otherwise, if parents are anxious, then you can go for diagnostic induction. Then OCP, this is one of the common blunder, not used for puberty induction, remember that. And in case of multiple pituitary hormonal deficiencies, or in case if they have associated growth hormone deficiency, first stabilize that one. After that you can go for induction of puberty. And remember, all these hormonal cutoffs are not magical numbers. Okay, thank you. With this I will conclude my talk. If you have any queries, I will be happy to answer.
We know that the age of puberty has come down. So like girls are getting their periods around 9-10 years. Suppose a girl at 12 years comes that she has not attained menarche. So how do we take it forward? Just wait for another year, not doing anything, or start some investigations?
I think they will redefine the cutoffs, madam. So as of now, up to 13, we can give assurance.
Just assurance that
Yes.
nothing to be done,
Yes,
and
yes.
we wait and see.
Yes, madam. Sometimes we face that situation from parents. So nowadays every girl is getting her periods around 11 years. So my girl is 12 years, still not yet attained. Like that we see in our routine practice.
Good morning. I just want to know, like this IHH, if they present very late, like 21 years, do we still go about inducing the puberty at that age?
Sorry,
After
madam?
ruling out IHH,
Yes, madam.
gonadotrophic hypogonadism, when the girl presents at the age of 20-21, so do we still go about inducing the puberty at that age?
So
After ruling out everything, like it's like an isolated idiopathic gonadotrophin deficiency, we can go about inducing.
that 2 years standard protocol we can cut down to 1 year, madam.
Okay.
That is a practical approach.
So we can give estrogen for 1 year, then add.
Yes,
So
yes,
just on
yes,
looking
madam.
at the progress of the.
That is the
development.
practical approach.
Thank you.
But better always start with low dose. Shall we close?
One more question. I think the most difficult aspect of treating this is about the fertility part.
Yes,
Whenever
madam.
they come to you, they just ask, am I going to have children? So how do you go about counseling such girls?
Theoretically, yes, madam. So basically, gonads are intact, function is okay with supplement. So 100% possible. Theoretically, yes. Practically, there are so many issues.
We do encounter these HH cases for fertility, and it is not all that very difficult to treat. It is that we just have only FSH is not going to work. letrozole, clomiphene citrate, these are not going to work. The first flag point should be that both FSH and LH are definitely less than 5, and they do very well with HMG. Invariably, if you see, most of them do have a good AMH, and they look like PCO ovaries, but they don't hyperstimulate like how a PCO hyperstimulates. You just have to go on a slow step-up dose itself rather than give a high dose and then land up with complications of OHSS. And I think now even the ISMART, that is the International Consensus of Medically Assisted Reproductive Techniques, they have also included gonadal failure into the part of HH management, where the FSH and LH may be normal, but despite the normal routine stimulation, they don't achieve their full potential in terms of developing eggs. They could be mostly because of polymorphism or some other things which require a higher end workup, but even that is also included in this. Your FSH, LH will be normal, but with the standard doses, they don't respond.
Generally, we endos refer to fertility centers, madam. So no more experiments with that hypo.
That's a wonderful and engaging session. I would like to thank the chairpersons, and I would like to apologize for the last minute confusion. Sorry, ma'am. Sorry, Dr. Meghala Dwarkanath, madam, and Dr. Shefali Tyagi, ma'am. Now, moving on to next session, I would like to invite Dr. Santosh R onto the stage to moderate the next session.
Of Dr. Shefali and myself, I thank the organizers for giving us this opportunity to chair the session. Thank you all.
So the next session is going to be also mainly on fertility and all on the very controversial topic, when we should give OCPs which contain sapropterin, drospirenone or desogestrel. And the first topic will be on overt hypothyroidism in fertility and pregnancy. So I would like to introduce the chairpersons. Dr. Rashmi Yogesh, I think she's still in the process of joining us. Can we have Dr. Sham Gupta on the stage, please? So Dr. Sham Gupta, as we know, is the Chief Fertility Specialist based out of Indira IVF Center. Academically, very oriented person. And Dr. Rasya Dikshit, she's a consultant dermatologist, cosmetic dermatologist, I'm sorry to put that word. We know her as an academic powerhouse and also a good social media influencer and a good friend. So we would ask the chairpersons to please introduce the speakers and the topics.
Good afternoon. Can we have Dr. Prem Kumar on the stage? Dr. Prem Kumar is a consultant endocrinologist with over 14 years of experience. He is currently in Salem and practices in the SKS hospital, and he has gained proficient skills and knowledge in the segment. Dr. Prem Kumar will be talking to us about overt hypothyroidism and pregnancy. Thank you, Dr. Prem.
Very morning to all the delegates here. At the outset, I thank the organizers for having me here. And after a brainstorming session on hardcore endocrinology, we'll be talking on a much slight topic on thyroid dysfunction in pregnancy. And my talk will be focused on overt hypothyroidism. So there are a lot of controversies with subclinical hypothyroidism and pregnancy, and I won't be dealing with that. So in the next 15 minutes, we'll look at the epidemiology of thyroid disorders during pregnancy, thyroid physiology in pregnancy, role of thyroid gland in fertility, and also overt hypothyroidism in fertility and also in pregnancy. So if you look at thyroid disorder, these are the most common endocrine disorders during pregnancy. But if you look at the figures, what you get from the Western countries, the elevated TSH is seen in only 2 to 3% of all pregnancy, which may be shocking to many of you. In fact, these data emerge from a region which is fully iodine replete. And if you look at the prevalence of overt hypothyroidism, it's just 0.1 to 0.5%. And the 2 to 2.5% subclinical hypothyroidism is seen in their population. And if you look at hyperthyroidism, it is seen in only less than 0.5% of the population. But the scenario is totally different when it comes to our country. And postpartum thyroiditis is another 4 to 10%. There are many observational data which are available in our country in various states. And if you look at the prevalence, it goes from as low as 5% to more than 30%. One possible reason could be the iodine depletion, which deficiency, which is still seen in many inland and also in many mountainous areas, even after the universal iodization program. And this one particular meta-analysis took into account all the observational data which has been published so far in various centers around the country. And this is their figure. Subclinical hypothyroidism is seen in 9.5% of the pregnant women. And overt hypothyroidism is seen in 2.7% of the pregnant women, which is much more than what is usually seen in the Western studies. And this is the regional representation of the prevalence of hypothyroidism during pregnancy. As you can see, the states seen in yellow, our one South Indian states are all actually iodine replete. And the prevalence of hypothyroidism in pregnancy is less than 9%. Whereas if you look at the northern part of the country in the mountainous hilly areas, it's still it can be up to as much as 30%. So let's look at the role of thyroid and fertility. If you look at the TSH receptor, sorry, it should be T3 receptor. TSH and T3 receptors in ovaries and in the oocytes. They have an important role, as you know, in embryogenesis, in folliculogenesis, and in feminization. And they are also has an important role in endometrial receptivity. And what happens in a patient who has hypothyroidism? There is delayed clearance of androstenedione and estrone. We say hypothyroidism as a state of secondary PCOS because of the mild hyperandrogenemia that prevails. There is increased peripheral aromatization in them, and because of the receptor spillover, they have a slightly elevated prolactin. And all of them leads to an environment which is inconducive to pregnancy and for a good fertility. Around 80% of women, all women with thyroid dysfunction have menstrual irregularity, which all of you know. And if you do ovarian reserve studies, usually in overt hypothyroidism, the TSH level is more than 14 and the anterior follicular count will be less than 5. And these are the reasons why infertility is highly common in this population. And moreover, the thyroid peroxidase is expressed in ovarian in an antral follicle and in the granular cells. When we see anybody with highly positive thyroid peroxidase antibody and thyroid globulin antibody, what meaning you should take worries? It is a state of generalized autoimmunity, and they have got a high incidence of natural cytotoxic activity that goes on. So it doesn't mean that TPO and anti-TG itself is responsible for the infertility. They are susceptible for any autoimmune disorders, or they have a generalized autoimmune dysfunction in them. That should be a thing. In a person who is TPO positive or anti-TG positive, they have a deteriorating thyroid function when they undergo pregnancy. The thyroid is not able to produce T4 hormone with HCG stimulation. So we generally say thyroid autoimmunity is a state of unexplained subfertility. So if you ask me, if you evaluate 100 patients with infertility, how much percentage will have thyroid dysfunction? Study says it's to the 1/4 of all infertile women will have, women with infertility, will have thyroid dysfunction. And if you ask me when you treat, how much of them conceive? The figure says in study from various studies shows around 75% of them, if properly treated with thyroxine, they will conceive in the next 3 months to 1 year. So if you identify hypothyroidism in a patient with infertility, if you adequately treat and also wait for around a period of 1 year, around 75% will not require any further enhancement for their fertility. Not only female fertility is also closely related with thyroid function. There is a role for Sertoli cell maturation with thyroid hormone, and there is a leading cell dysfunction which has been observed in an uncorrected overt hypothyroid state. And if you look at the semen quality, the quality is poor with reduced motility. They have reduced acrosomal integrity and reduced mitochondrial function. So it's equally important you treat the male partner too when you identify thyroid dysfunction in them. And what about the outcomes by the thyroid dysfunction? You all know that there is an increased risk for preterm delivery, there is increased risk for preeclampsia, which is more strong data for that. Antepartum hemorrhage is seen, first trimester miscarriage is seen with subclinical hypothyroidism and preterm delivery. And there is also the risk for postpartum hemorrhage, which is because of the uterus atony, and there is low birth weight. And if you look at the fetal loss figure, it depends upon the severity of the thyroid dysfunction. And odds ratio are there between 1.8 to 3.9, depends upon the severity. So around 60% risk for fetal loss is there with overt hypothyroidism, not subclinical hypothyroidism. And you know, IUGR is common, and when there are prolonged period of exposure to low thyroxine, there is neurodevelopmental delay because of the defect in the brain maturation and neuronal migration in presence of the thyroxine deficiency. And when these people were followed up for the next 6 years and an IQ examination was done, what they found was there was a 7 to 8 point reduction in the IQ score in overt hypothyroid when they were not corrected during pregnancy. And you all know that there is a change in the thyroid physiology during pregnancy. HCG, because of its receptor spillover, because it shares the same alpha subunit, it acts on the TSH receptor, it increases thyroxine production. But at the same time, in the placenta, there is increased placental deiodinase activity, which degrades this T4 and T3. As a result of that, there is T4, which is available in the hypothalamus, and it causes negative feedback and further increases the TSH. This is what happens in the thyroid physiology. As a result of that, what you see is the thyroid gland size increases by around 10 to 40%. Size increase is there. And again, in iodine replete area, the increase in the thyroid volume is 10%. In iodine deficient area, it can be up to 40%. That's why presence of goiter may not be an representation of thyroid disease, it may be just a representation of an iodine deficient state in that particular patient. And the TSH level decreases by 20 to 50%, and the first trimester TSH can be is usually 0.1 to 2.5 micro units per liter. And there is an increase in thyroid binding globulin. As a result of that, the T4 is elevated, and T4 is 1.5 times elevated. There is a controversy what to examine in thyroid in a pregnant state, whereas T4 or T3. Let's deal into that in detail. What happens when there is an increase in the HCG, there is an increase in the FT4 in the first trimester. But later what happens, there is a fall in the free T4 in the second and third trimester. The assays for FT4 is not fully standardized, especially there is an issue in pregnancy. The best test to do during pregnancy is a free T4 index, which is not widely available. We do thyroid T4 estimation with an enzyme immunoassay, whereas equilibrium dialysis and LCMS could be the ideal method for estimating FT4. Because these tests are not widely available, it will be sane to go for a T4 during pregnancy because of the falling FT4 during the second and third trimester. And what happens is there is a 50% increase in the thyroid binding globulin level during pregnancy. As a result of that, T4 level gets elevated in the first trimester and remains elevated in the second and third trimester, whereas the FT4 level progressively reduces during the second and third trimester. So pregnancy is a stress test for the thyroid gland, and there are a lot of changes. So in a nutshell, what happens in first trimester, there is a reduction in the TSH level, the T4, T3 and FT4 all remains elevated, whereas in the second and third trimester, the T4 level remains stable, whereas the FT4, there is a progressive reduction. So what do you mean by overt hypothyroidism? Elevated TSH with a subnormal T4, or TSH level, absolute level more than 10, with symptoms and signs suggestive of hypothyroidism is what we call overt hypothyroidism. And we all know that during the pregnancy, the fetal thyroid gland is detectable as early as 5 weeks of gestation, but it attains maturity and could sustain after a period of 16 to 18 weeks of gestation. Till then, you should adequately supplement the mother with thyroxine to aid the neurodevelopmental process that happens. With this introduction, we'll have 3 case scenarios, which we commonly see in our routine practice. What we have is a 25-year-old female, married for 1 year. She is a known case of hypothyroidism for 5 years. At the time of presentation, her TSH is 2.35. She is thyroid peroxidase antibody positive. And though she has a well-controlled thyroid function, she was apprehensive what will happen when she gets pregnant. She lives in a remote area where the access to thyroid function testing is not available, and she can come back only later. So she asks you this question, is my present control sufficient, or should anything be done more? So if you look at studies, in people who have got a TSH, we know that times the TSH should be maintained below 2.5, and preconception for those who are on treatment with thyroxine is less than 2.5. So in people, studies have shown that when the TSH is less than 1.2 preconception, the chances that they will require an increase in the thyroxine dose in the 6 to 8 weeks of first trimester is less than 15%. Whereas a patient with a TSH between 1.2 to 2.4, the chances that they will require a hike in the dose of thyroxine is more than 50%. So in this particular patient who has got a TSH of 2. Not going back, okay. What I'll do is, in this particular patient who has got a 2.35, I would rather go increase the dose to by another 25 microgram, because she lives in a remote area and she will not be. Can I have it the 2 slides previous? Yeah. Previous. Okay. Yeah. So I would like to increase the dose by 25 microgram, because testing as soon as the pregnancy is confirmed is not possible. So if it is between around 2.4 to 2.5, we need not increase. And as soon as they become pregnant, you always give the advice at 6 to 8 weeks, or 7 to 8 weeks is a time where they usually require increase in the TSH level and get a thyroid function test done and get it reported. So usually when the pregnancy is confirmed, when testing is not possible, we generally advise increase the thyroxine dose to 25 to 30 micropercent of the preconceptual dose. And this is the target for the first trimester, less than 2.5 TSH, and second, third trimester it should be less than 3. And the T4 value which we would like to examine is, it would be 1.5 times the normal. So many times the referrals are for elevated T4 with a normal TSH, and because the TBG is elevated, T4 and T3 cutoff should be 1.5 times the normal. So again, follow up, how frequently do the repeat the thyroid function test? Every 6 to 8 weeks till mid gestation, which is 20 weeks gestation. Usually after the 20 weeks, the dose increment may not be required in most of the patients, and are less than 25% require only when they have got a overt hypothyroidism. Subclinical hypothyroid patient, after 20 weeks, they do not require a dose increment. As a result of that, after 20 weeks, you just have to check the thyroid function to once at 30 weeks at least. And the last 2 months of pregnancy, do not call them to make and wait in your this one clinic for a long time to just show a thyroid function, which usually will be normal in these patients. So this is one particular meta-analysis where they have found that there is by giving thyroxine to patients with subclinical hyperthyroidism, where you can make them an artificial hyperthyroid state or hyperthyroxinemia. Many patients ask, will it harm my pregnancy or the outcome? The data shows that there is, in fact, even if you make them artificially hyperthyroid by improper dose adjustment, there is no any adverse outcome observed in this particular study. It reduces the preterm delivery. It also reduces the neonatal deaths. And case number 2. So this is a 30-year-old female with post-ablative hyper. She had a Graves' disease. She underwent radioiodine ablation. In this particular state, what is known is they don't have any residual thyroid function. They totally depend upon what you supplement from the external source. She is gravid to para-1 L1 and 10 weeks of gestation. The TSH is 12. She is already on 100 microgram daily, and the compliance we usually check it when they have got elevated report is actually good. So overt hypothyroid with elevated TSH on regular medication. How to proceed? So this particular patient has no residual thyroid gland functioning. The same thing will be to double the dose. So whenever patient underwent thyroidectomy or had a radioiodine ablation done, it will be good to double the dose of thyroxine. Otherwise, this is a simple thing which American Thyroid Association gives. If the TSH is between 5 to 10, increase the dose by 25 to 50 microgram. If the TSH is between 10 to 20, increase the dose by 50 to 75 microgram. More than 20, you increase by 75 to 100 microgram from the pre-existing dose. And at the same time, you also should know about the absorption status of the thyroxine. We call it the thyroxine malabsorption. There are many factors which impair the thyroxine absorption and produce a elevated TSH at time of presentation. So if you look at the commonly used drugs like proton pump inhibitor, iron and calcium, they impair the absorption of thyroxine. If you are giving iron and calcium, they should have a window of around 4 hours before between thyroxine administration and the iron and calcium administration. And consumption of soy milk, coffee also can impair. So the adequate interval should be there. And there are other states of malabsorption. Common things are lactose intolerance, which is very common in our population, can also impair thyroxine absorption. We commonly see gluten hypersensitivity, wheat allergy being a cause. Though celiac disease is more common North India, we also do see in the southern part of the country. Just stopping the gluten-rich diet, absolutely improves the absorption for not only thyroxine but also to iron, B12 and other things. And many atrophic gastritis and other post-bariatric surgery also have got impairment of the thyroxine absorption. So if these things are there, we either double the dose, we do more frequent monitoring, and even B12 deficiency is there, we do correct preconceptionally, and the absorption improves wonderfully well. So this is another study where I just want to focus on isolated hyperthyroxemia. Though there is no strong indication to treat isolated hyperthyroxemia, because I told in first trimester free T4 will be elevated, and second and third trimester it gets reduced. But there are certain studies which have found isolated low FT4 is associated with increased autism in children. So there is some recommendation telling that if the low T4 with normal TSH is present in first trimester, you can treat it. But if it is detected in the second and third trimester, it is a normal phenomena, and they need not think about central hypothyroidism or proceed in treating them. And they have to, and postnatally what should happen? And you have to get back to the previous preconceptional dose. However, this transition should not be quick once they deliver, because thyroxine is also required for breast milk ejection and also for quality breast milk production. This transition should happen after 2 to 4 weeks after delivery. And then repeated thyroid function is 6 to 8 weeks, where there is usually a phase of postpartum thyroid in certain women, where a transient dose reduction is required, and repeat tests will show a further increase in TSH, and you have to go back to the old dose. This happens in certain group of population. In the last study, and this is a 28-year-old female who presents first time for the antenatal visit, and she has got goiter, she has got an overt features of hypothyroidism, and on evaluation she has got a TSH more than 100 and T4 of 7, which is within the normal range. So this puts into a lot of questions. What does guidelines say? Universal screening in Western guidelines is not told. Basically what they say is risk-based screening when the patient has got a goiter, antibody, positive family history, or past thyroid dysfunction, or patient has got a thyroid surgery or neck irradiation, or when the patient has got type 1 diabetes, infertility, age more than 30, type 2 diabetes, morbid obesity, they needs. But in the prevalence of thyroid dysfunction in our country, the prevalence figures are high, as we saw in the previous slides. So universal screening, if the at the first trimester, should be provided to all of the patient because of the iodine deficiency state and also the higher prevalence what we see in our country. So this is another study which have found the meta-analysis of thousands of patients' data, which found that there is increased risk for autism and also ADHD when the overt hypothyroid state is present in the first trimester. So again, onus lies on us in detecting this patient and treating them adequately to prevent this subtle, a significant neurodevelopmental abnormality that happens in an uncorrected thyroid state. And how to start? This patient is overt hypothyroid, detected first time during pregnancy. The dose in a pregnant woman is 2 to 2.4 microgram per kg, not the 1.7 or 6 what we usually do. Right? And another thing to observe is we have to normalize the T4 as early as possible. So what we usually do, though it's not a guideline recommended, is we give a double dose of what we calculated by the weight formula, 2 to 2.4 microgram for initial 2 weeks. Make sure the T4 is normalized. Then go back to the old dose. So normalizing T4 is of prime importance in an overt hypothyroid detected during first time during pregnancy. And follow up, yes, every 6 to 8 weeks till mid-gestation. But you should also anticipate pre-eclampsia in this patient, should monitor that, and also monitor the fetus for any intrauterine growth restriction they have. Since these people are also on high risk for the pre-eclampsia, aspirin prophylaxis can be thought of in this particular group. because of the delayed diagnosis. So fetal surveillance is must in these cases, and many people do ask, should we go for MTP? There is no any indication for that, and treat and make the T4 as much as normal as early as possible. That's the only thing we can do for this particular subset of patients. And yeah, postpartum thyroiditis occurs in 10 to 15% of the patients. So do an repeat TFT at this particular period of time and reduce the dose and re-increase the dose after this particular period of time. And it's more common in those who are TPO positive. With this, I end my presentation. Thanks for patient hearing.
Hello, good afternoon. Dr. Prem, you have already briefed a lot of things here, and the case scenarios are definitely a very practical case scenarios, and it is very helpful for everyone. And I have a basic one or two queries I just like to understand. And as you mentioned, when there is an anti-TPO positive, and also in overt, definitely there is most of the chances anti-TPO are positive. Even anti-thyroglobulin antibodies are positive. So in those cases, when you feel this is autoimmune part, do you investigate more in the terms of the autoimmune system? Like, because we found some association between the interleukin 2, mostly 2, 4, 6. And sometimes we go for it because if you deal with the pregnancy and IVF and all, we always think about the NK cell activities. Is there any relationship with the NK cell activity and the interleukin, those who have anti-TPO or autoimmune parts?
Yeah.
So any
As you rightly say, I also told that this is a state of generalized autoimmunity. So actually we should look for other autoimmune markers which are present in them. So usually do lupus anticoagulation, APLA workup, and even ANA in certain cases. That should trigger you to, if there is a recurrent pregnancy loss, no other factor identified should be done. Regarding your question on IL-2, I am not much aware actually. It's more into your territory. You can, yeah, I'm not aware of that.
So thank you, Dr. Prem. Okay.
Thank you.
And I would like to welcome next speaker, Dr. Krantik Kadilkar. And she's going to present and giving you a good overview on the compositions of OC pills having the sapropterin acetate, desogestrel, and drospirenone. And welcome, Dr. Kranti.
Okay, so yeah, I would be talking on sapropterin versus desogestrel versus drospirenone, when and why. Disclaimer, I may not be able to answer that question after the talk, but let's go ahead. Agenda would be classification of synthetic progestins, choice of progestins as per clinical scenario. Do we really have data for such choice, or is it a personal preference? Types of progestins and risks of venous thromboembolism, do they differ? And risk-benefit ratio. At the end, all practice is going to be the balancing the risks with the benefits. So a short history, progesterone, as the name suggests, is something which supports the gestation. So it was first isolated by these gentlemen from the placenta. And today what we have are all the synthetic derivatives called as progestins, but we generally call them as progesterones. The generations, generations generally do not come alone. They are part of the combined oral contraceptive pills, but they are differentiated based on the types of progestins. So first generation, second, third, and fourth, as I have highlighted, the three ones which we are discussing today belong to the newer progestins, which are the third and the unclassified or the fourth generation progestins. And the classification of progestins goes by the chemical structure. Too complicated. I want to see is why are we dividing them in classes. So we are dividing because of some difference in action. The highlighting point is none of them have estrogenic action at all. The initial generation progesterones had some amount of androgenic potential, or we can call it something to counteract the estrogen. So they are up to, say, levonorgestrel. The lower ones, the third generation, they are neutral. So desogestrel is androgen neutral. Does not mean it is anti-androgen, but it is androgen neutral. And the fourth generation, which is a drospirenone, and the another class, sapropterin acetate, they are the anti-androgens. So drospirenone closely can be called as an anti-androgen, and the sapropterin acetate is definitely an anti-androgen. So it is similar to almost spironolactone. So they are commonly used in combination with estrogens I don't have to spell out the uses because we have all esteemed gynecologists here, but I would be discussing my role as an endocrinologist mainly for PCOD. So we use it mainly for PCOD. So I would be discussing the data on this from an endocrinologist point of view. PCOS complex syndrome, I would not go in detail, but what are we tackling by giving the combined oral contraceptive pills? They are supposed to be the first treatment of choice, especially when you have hyperandrogenism or hirsutism, and we have irregular cycles. We need to have at least 6 to 9 cycles in a year so that we do not have endometrial thickening and irregular bleeding in between. So how do the COCPs tackle this? So what they do is they reduce the hyperandrogenism by directly negative feedback on the LH, and usually a lower estrogen quantity is along with a progestin, especially the one with low androgen potential or an anti-androgen potential, does the work of A, LH drive is reduced, and B, the estrogen per se is the main player. It is going to increase the SHBG, so sex hormone binding globulin, which will take up all the free testosterone, and it will try to reduce the amount of androgens in the blood or try to maintain the balance which is disturbed in PCOD. Here the progesterones have no role. So progesterones, if they are androgenic potential, they are going to just counteract the estrogen, and the SHBG elevation might come down. So here we have the anti-androgenic progesterones, who it is thought of help the estrogen in improving the SHBG. Does this really translate into clinical benefit? What do the studies say? Let us go through it in detail. What are the common names? I'm not allowed to use the trade names, but for familiarity, the overall L was supposed to be the second generation with levonorgestrel. Here we are all talking about low dose estrogens, 20 or maximum 30 micrograms of estrogen, estradiol basically, ethinyl estradiol. The desogestrel is the novelon femilon, difference is the estradiol content, and the cyproterone acetate, and then the desogestrel and drospirenone. So do we have data to choose between third and fourth generation? I am not going to talk too much about the second generation, some amount in the end. So it started with this, which was a direct comparison. So when we have this question, I searched, is there a direct comparison? So yes, there was a direct comparison, of course, in PCOD. At 6 months and 12 months duration, they directly compared 3 groups. One on, say, desogestrel containing pill, one on cyproterone acetate containing pill, and one on drospirenone containing pill. The cyproterone acetate is going to be the low dose cyproterone acetate, which is available as a combined pill. So what was the results? Results were at 6 months, no difference. Now again, problem in assessing the difference is really difficult. It's based on the patient data. Basically, we are treating patient. We are not treating the levels of androgen. A particular patient will be really affected by hyperandrogenism. The blood levels might be almost normal. So what was the patient response? What was the androgen levels in the blood? And was there any difference between the score, between the SHBG level and the free androgen index? At 6 months, they couldn't find any difference. Of course, not a very big study, not a very robust statistics here, but they did not find any difference. So at 6 months, okay, any of the 3 can be used. All are newer anti-androgen pills. At 12 months, what they could see was cyproterone acetate, since it is the only one with anti-androgen action, showed some benefit over drospirenone and desogestrel. So it was cyproterone with the greatest benefit, then came the drospirenone as expected, and the neutral one, which is desogestrel, came third. Quite close to each other, but at 12 months, they could find a difference. Metabolic parameters, same. Venous thromboembolism, in this study, they did not have any events, luckily, so they couldn't comment anything on the DVT problems. So then came the recommendations, 2018 guidelines for PCOD. So we generally look at good data in the guidelines, because guidelines are the ones who are going to look at RCTs and who are going to get the best possible quality evidence. Small studies can give you either or results, but the good quality evidence is important. These guidelines told that, of course, it is recommended to give COCP based on the pathogenesis for hyperandrogenism and irregular cycle management in PCOD. but the recommendation as to which type of COSCP can be given is not known. Everybody knows that it has to be low dose estrogen and it has to be progesterones based on the choice and the general population data, whatever is happening, and the experience. So they did not commit that the desogestrel is better or drospirenone is better or the other one is better. So there was no adequate data available for them to give first rank or second rank or third rank. Then we moved on to 2023. Luckily, before I did this talk, this meta-analysis came about. So this is a very good meta-analysis. It was done by comparing directly. They had multiple RCTs. They compared high dose versus low dose ethinyl estradiol, compared different types of estrogens, ethinyl estradiol versus natural estrogens versus estradiol valerate, and different generation progesterones. So first with second, second with third, first with fourth, all combinations. We are more interested in the generation progesterone comparison. What happened? What were they looking at? Is there a real evidence in clinical hyperandrogenism reduction, one compared to the other? Is there a difference in biochemical hyperandrogenism? Are we really benefiting and losing in some other aspects like, say, lipid profile or some other metabolic issues? And this was done to recommend and guide future research. So this is a very busy slide, so I have just circled. So this is a meta-analysis comparison between third generation and fourth generation progesterone. So desogestrel versus drospirenone, cyproterone acetate. So they couldn't find much difference. So if we see here, we have total testosterone. Of course, fourth generation, that is anti-androgen, of course, had testosterone levels which were low. But when they looked at the outcome of SHBG, no difference. There was no difference in outcome of other lipid issues. Some of the fourth generation had decent amount of HDL. So we are all looking at anti-androgen effects. So most of the fourth generation had good effects, but there was no obvious improvement or a good ranking for the fourth generation in terms of overall hirsutism. There was definitely improvement in the biochemical hyperandrogenism, but not so much in the clinical hyperandrogenism in the studies which they have collected. Same here. So outcome as a hirsutism as a whole, there was no difference between the two. And that is what I think we find in our clinical practice. Most of it is about experience, about which you are comfortable giving to the patient and which has given you better results. Most of us use third and fourth generation progestins itself. Difference between second and fourth. Why I have gotten second is because when the third and the fourth generation came, the second generation were like literally left behind levonorgestrel. Levonorgestrel, mind you, does not have any increase in hirsutism. It is mildly androgenic, but there is an estrogen to counteract it or to have with it. So it basically did not change anything. We think levonorgestrel will increase the hirsutism, will cause increase in acne. One or two patients might have that, but in this study, they couldn't find much difference in the hirsutism between second and fourth. Why I am harping on second generation, I'll come to it later. So basically, they did second and third comparison, again, not much difference. So there was no difference. This entire meta-analysis proved us that on paper, cyproterone acetate, again, anti-androgen progestin, had effect on biochemical hyperandrogenism. How much it translated in clinical practice, they are unsure because of the quality of data. There was a lot of biases in most of the studies, so it became difficult to recommend. So for comparison, there is no evidence as to one is better than the other. Why I took in second generation, I will tell you. So there is no difference between second and third also for hirsutism. What are the downsides? When we give COCP, especially as endocrinologists, we are worried about thromboembolism. Though it's a relative risk, there are so many women on OC pills, but this is a risk which we need to discuss and which we need to find out, especially in subgroup of PCOD because they are at slightly higher risk. Obese, more cardiovascular issues, so they might be at a higher prevalence of VTE. So combined OC pills essentially double the risk of VTE from 2 to 10 events per 10,000 women to 7 to 10 events per 10,000 women. It is a way it is written. If we just light the first line, doubles the risk. It becomes a really big risk. It's not, so it's a relative risk. And baseline risk is slightly doubles from the baseline risk. Pregnancy is going to double it. It is highest possible risk as compared to any COC. Why it happens? When you have ethinyl estradiol increasing the SHBG, the coagulation profile also changes, so you become more procoagulant. in your blood when you are on estrogen. When you have progesterones, if you are on the earlier generation progesterones, it is thought of that they counteract the estrogen because they have some androgenic potential, so that procoagulant levels slightly come down. That is why levonorgestrel had the least amount of VTEs in comparison to the newer progestins. The newer progestins are giving you anti-androgen effect, but then they are increasing the procoagulant actions of estrogen. So that is for the postulation. There are a lot of studies for and against it. We can have an entire day debate on this. So the data was the risk varies with the estrogen level, the doses. The higher the estrogen dose, higher is the risk. But the progesterone type also matters. If you have anti-androgenic progesterones, the chances of the VTE goes up as compared to the other progesterones. So how bad is it? It is a relative risk. Additional 5 to 10 events are increased, especially with cyproterone acetate. So there was a BMJ publication, which I will show in the next slide, which directly showed that drospirenone and cyproterone acetate had the highest VTEs as compared to the levonorgestrel, saying that cyproterone, though reduces hirsutism, should not be the first drug of choice for hyperandrogenism. What does the WHO say? Need to weigh the risk and the benefit. I just told you the risk is basically the procoagulant nature of estrogen-related protein increase causes the VTEs. So this is why it happens, and that is why the anti-androgen, which was beneficial in one arm, is becoming harmful. So this is one of the papers which said that there is some procoagulant effects which are increased when you are giving cyproterone acetate and desogestrel and drospirenone. So though we have versus here, we should ideally have been levonorgestrel versus the newer ones, because all the newer ones go hand in hand and are giving same risk. So this was the BMJ paper which actually made us slightly think, because we were all on to cyproterone, drospirenone and desogestrel. Even in my practice I was doing that. But this has shown, this paper at least has shown that the earlier progesterones have a lesser risk, no zero risk, lesser risk as compared to the newer ones. The higher the anti-androgenic potential, technically higher is the risk of VTE. How it translates to clinical practice? Very small increase in relative risk at clinical practice may not be accountable that much, but you need to counsel, need to have at least a checklist in place where I say you have a family history, past history of DVT, protein C, proteinase deficiency is extremely common in normal population, has to be told to the patient so that they are not caught up in a sudden surprise with the DVT. And dehydration scenarios, marathon runners need to be a bit careful when you are on COCPs. So yeah, this question I am not able to answer, risk and benefit. So what the meta-analysis showed was there was not much difference in hirsutism. We can handle hirsutism with dermatological cosmetic practices or procedures. Look at the pathogenetic mechanisms. The risk and benefit needs to be weighed. Doesn't mean that you don't give cyproterone, but maybe give it with the risk in mind. The three people whose versus I was supposed to talk are the same in terms of the hirsutism control. Cyproterone being the best but has the highest risk. So I would maybe go with the middle one, desogestrel, which is I think androgen neutral, or safely go with levonorgestrel with an anti-androgenic spironolactone in the mix and cosmetic procedures. So key knowledge gaps, all of these studies are full of biases, not good quality studies to say that no, don't give cyproterone. So it is a problem in terms of the quality of data, and I don't know the answer for the question which is being asked. What I can say, take home message, research needs to be done on this. Maybe come up with reduction of estrogen or quality of estrogen. Say natural estrogens are supposed to affect the coagulation pathway lesser. So if you have pills with natural estrogens, and say cyproterone acetate, maybe the cyproterone acetate effect on VTE will come down. So this is what would be my take-home message. I do not know the answer to the three. Risk and benefit has to be analyzed, and levonorgestrel is not that bad. Thank you.
Thank you, Dr. Kranti. You're leaving for another conference, and I know that you're not here to take any more questions, but this was really wonderful presentation.
Yeah, congratulations, Kranti. You did bring in the evidence which is so far existing. Well, there are some, some observations to be made with so many years of COC use, especially with desogestrel and drospirenone and cyproterone. I think if you take the specific population of PCOS with hirsutism, then cyproterone has had a very successful journey. 6 to 9 months of use does give a FG score alleviation. That is very, keenly observed by all practitioners. And I think the prescription of cyproterone right now is on the higher side in the practicing population. I can safely say that. Having said that, there is a very strong ground for prescribing drospirenone-containing drugs, which are low-dose COCs, especially the 24/4 combinations with drospirenone have got huge metabolic, endocrine, and reproductive benefit. The one major advantage I can tell you right away is that cyproterone-containing COCs have not been approved by FDA US as contraceptive pills. And neither by the Indian government, they are not contraceptive pills. So when we come across PCOS girls, today the sexual debut is very early and many of them are sexually active. And so therefore, when we prescribe cyproterone containing medications, we do tell them that they are not completely safe from pregnancy. They are not approved. They may provide contraception, but we are not sure about that. So therefore, that is one thing for you. Another thing is, I think girls who are on the obese side in PCOS, they do benefit with drospirenone combinations. Because I think we need to look at the subset of population, the girl who has, it's a very heterogeneous presentation, PCOS. We need to look at the, her clinical markers which need to be addressed. And obesity is there, then drospirenone does benefit. It may not actually help in reduction of weight, but if a girl is reducing weight, I think there is some benefit in drospirenone containing.
there is.
So there is, I think these are the nuances in clinical practice which we are looking at. Data is awaited, and we are always kind of, at crossroads when it comes to data. And the main reason is that we fail to create our own data. PCOS today is very common in India. And the champion of PCOS is with us, Dr. Madhuri Patil. And I think we need to have some very genuine studies coming from all of you in terms of data collection. So if there can be some registry for use of hormones in PCOS in younger girls, especially with obesity, then we may find an answer to your solution, which is essentially not funded by the pharma, because these are all hotly contested products in the market, and very often we get swayed by this company and that because there is a very intense marketing going on for these. So we need to be very discerning as clinicians, and we need to have in-depth knowledge, and most important of all, we need to have our own data. So that is what I wanted.
Madam, yes.
Acetate should not be the first drug of choice.
Yes.
So the recent one, which is just released this month.
Correct.
Yeah.
Last week, last month. Yeah.
So
because of the VT,
the PCO Society was part of it. Plus, as I Aspire, the thing, we also had this thing in it. And according to them, they still feel that the first and the second generation progesterones are much better than the third and the fourth generation.
But for hirsutism, the problem comes when they come with hirsutism.
Yeah, so they prefer giving spironolactone.
Yes, we actually do that.
So they prefer giving spironolactone
as an add-on to a basic OC preparation. That is also possible.
Yeah, so as far as possible, they prefer, because in the girl, if you give a OCP, because the estrogen can cause stunted growth, because early closure of the epiphysis, they just give progesterone for her regularizing the periods, and they give cyproterone for anti-androgenic action. But they still say that the lifestyle modification as well as cosmetic therapy is the best option for the adolescent girl.
Yes, that is what has been told. And madam, we should also have a registry for the VTEs which happen. Is it really so?
It is high, yes. Dr. Rama Vaidya has presented a very good paper because she is doing a lot of research on PCOS. So she has looked at it and she said that the incidence of deep vein thrombosis and thromboembolism is very high, even in the adolescents. So they also, and even the NIRRH, what research we are doing, we also say that it's preferable not to give oral contraceptive.
Okay.
Thank you.
Thank you, audience, for the active participation. I thank the chairpersons and the speakers, Dr. Kranti ma'am and Dr. Prem Kumar sir, for the wonderful presentation. Now moving on to next session, that is a panel discussion on the life journey of a woman with PCOS. I would like to invite again Dr. Rasha Dikshit ma'am onto the stage and Dr. Santosh sir onto the stage.
Good afternoon. We are having a panel discussion today, and I'd like to invite my panelists on the stage. We have first up Dr. Shubha Rama Rao. Ma'am is a senior gynecologist, and she's currently working with she's a HOD at St. Martha's Hospital. She's the current president of the BSOG. She's a DNB teacher with over 32 years of experience. Welcome, ma'am. And she's been the vice president of the BMS Society, and she's been faculty at national and international conferences. Then we have my friend Dr. Santosh from Magna Clinics, Hyderabad, and we all know him as one of the people who are the founder directors of the Magna Clinics, and a very academic and practical endocrinologist. I like the word practical. And the third person to join us is Dr. Poojita. She is working as a consultant dermatologist, and she is basically more into aesthetic dermatologist under Dr. Janet Alexander in HSR Layout, Bangalore. And I want to remind I want to first thank my audience, because I know we are standing between you and lunch. And I want to remind my panelists that we are standing between them and lunch. So let us keep our answers very crisp and to the point, discuss clinical scenarios efficiently. So we are talking today about the life journey of a woman with PCOS, and we know that this is a very important topic, and it is a it's a multi-speciality problem. It is a problem which is going to come present to either a gynecologist or an endocrinologist or a dermatologist. So all of us need to deal with it. So let us start right away. We'll start with Dr. Shubha. Ma'am, this is a 15-year-old girl. She had menarche at 12 years of age. She's presenting with irregular cycles and acne. And what would you like to investigate? And basic question is, how is the diagnosis in this age group different from a diagnosis in an older person?
Since she is 3 years since menarche, definitely her cycles are regular. She fits into the criteria. And the thing is, I would first like to see her clinically, whether she is obese, whether there are any other, like we heard hypothyroidism, so anything suggestive of hypothyroidism, or what is her lifestyle, how much weight she has put on recently, whether she is, clinically all right, mentally, depressed, anxiety. All this first I would like to see. Examine her for any galactoria, because I would like to rule out hyperprolactinemia itself. So having done look at stria, whether to rule out Cushing's. And so clinical examination is very important. And if she is obese, look at the BMI and the type of obesity that she's having. And then I would like to do, at this stage, minimal investigations. We don't have to do a scan to rule out PCOS. At the most, if she just has acne, so we have to see whether it is acute, whether it is moderate or severe. If it is moderate or severe acne, then she needs some treatment. If it is mild, it may, we have to counsel and say that it's going to go away. Then investigations minimum, if she has been obese, I would like to do a TSH. And apart from that, I don't think I would do anything immediately. Then, of course, later on, this age group, yes, as I have already said, we have to do minimum investigations. It may be a clinical diagnosis. Sometimes we may have to substantiate it by doing maybe testosterone levels. And depending on other symptoms that she is having, appropriate investigations will have to be done. Whether I'll do anything like a lipid profile and all, I don't think so. I would look at her family history And my mainstay of treatment is going to be counseling and counseling, lifestyle modifications, and I would encourage her to lose weight, because losing even to 5 to 10% of her body weight if she is obese is definitely going to regularize her menstrual cycle. So that would be my first line of management.
Okay. Ma'am, we are also seeing Dr. Santosh for this patient. Any other investigations you want to do? How common is hypothyroidism and PCO seen together in this age group?
So we usually say that hypothyroidism incidence, the first time that people get hypothyroid are usually at 3 times in a lady's life. One is during the adolescence age group when they are attaining puberty. Second is when they are pregnant or immediately post-pregnancy. And third is when they are nearing menopause. So these are the times when hypothyroidism is very common. So in this girl, I will definitely think about hypothyroidism as being one of the causes for a PCOS. Another very important thing for this girl, especially if she's a very lean person and she's having irregular cycles since menarche, then we should think about late onset congenital adrenal hyperplasia, which is not very uncommon actually. It is not very uncommon condition at all. So we as endocrinologists, we'd like to do a basal 17 OHP, and depending on the values, we may go for a stimulated levels. And as ma'am said, obviously we would like to do a serum prolactin as well to rule out hyperprolactinemia.
So can you just sum up the investigations for me, Dr.
Yeah. So for any girl comes with PCOS at this age or at the age of 28 also, we first, as per the definition itself, as per the Rotterdam criteria, you're supposed to rule out the conditions that mimic PCOS first. So that is TSH, a serum prolactin. Serum testosterone we do not because we are expecting the testosterone levels to be high in PCOS. Serum testosterone is being done because if the testosterone is very high, we have to rule out androgen secreting tumors from the ovary and from the adrenals. That's why testosterone is being done. We don't monitor the testosterone, see whether it's actually coming down, etc. So serum testosterone, prolactin and TSH is a must. Fasting blood glucose or a GTT bad lipid profile, as ma'am said, the older the person is, we would like to do for everybody, but for a young girl at 15 years old, probably we will give that a skip at that moment. We in our institution, we measure something called as HOMA-IR. Why we measure the HOMA-IR, fasting blood sugar, fasting insulin is, especially in lean PCOS, we don't have any other parameter to fall back upon when we tell them to follow lifestyle modifications. For example, diet, exercise. HOMA-IR is not recommended by any society. We use it mainly to motivate our patients to have better HOMA-IR levels when they come for follow-up.
Okay. Yes, Dr. Madhuri wants to add something. Can we have a mic?
So basically when an adolescent comes, one should not diagnose PCOS. One thing is because irregular periods and acne are part of pubertal changes. And therefore, also according to the guidelines, they say that at least you must wait for 8 years post-menarche to diagnose PCOS in an adolescent, unless the patient has all the 3 signs. That is, there was a very good paper by Enrico which said that if they have hyperandrogenism, wherein they have to have everything. They have to have hirsutism, they have to have acne, they have to have alopecia, along with the biochemical changes, as well as irregular periods, as well as PCOS morphology. But because we are doing ultrasound for PCOS morphology, basically we don't take the number of follicles into consideration, and what we take is the volume. So that's the last test what we need to do. So I don't think any girl coming should be labeled as PCOS. We need to wait for some time because these are normal features of normal pubertal growth which happens. So that's the most important thing all of us should remember. Otherwise we are over-diagnosing PCOS.
So that brings me to the next slide, ma'am. Thank you. When I was studying about and making questions for this. This is the study which came up, which said that we are under-diagnosing PCOS. Would you agree that we are under-diagnosing, or in India, like Dr. Madhuri is saying, are we over-diagnosing PCO? What is it that we are doing, and how should we do it correctly?
No, we are over-diagnosing PCOS. Every patient, adolescent girl, comes with a scan report saying that I am suffering from PCOS, and she would have Googled everything. So as Madhuri said, and as I also said before, that if it is under 1 year from menarche, then you just have to reassure her. If it is beyond 3 years, then she must definitely need some treatment for irregular cycles. But I'm not going to think of PCOS right away unless there are other indications. And scan I will not do unless, there are something else that she has severe dysmenorrhea or she is having heavy menstrual bleeding with her irregular cycles. Then only I would do an ultrasound, especially not for looking at the ovaries, but for ruling out other pathologies.
Okay.
It
So
definitely is a overdiagnosis nowadays.
So the take-home messages are rule out other concomitant conditions which could mimic, think of a normal physiology itself, and don't over-investigate. Coming to the next slide, Dr. Santosh and Dr. Pujita, the questions are for both of you. She's a 28-year-old lady. She's single, periods are irregular. She has hirsutism, acne, acanthosis nigricans. And what is the evaluation? I think Dr. Santosh has answered this question. But now we will ask you, what is the treatment? How would you like to proceed with her treatment?
So once we are sure that this lady is actually suffering from PCOS and not the other things that we spoke about just now, PCOS treatment, what we tell when we teach our MBBS students and MDs, it's divided into three things. One is to treat the basic pathophysiology that leads to PCOS. And we all know that insulin resistance is the one that actually precipitates PCOS at this stage. So basic pathophysiology treatment, we don't prescribe metformin for everybody who walks into a room. So we ask them to meet a dietitian who tells them what is the basic diet that needs to be followed for insulin resistance. We ask them to actively exercise at least for 150 to 180 minutes per week, which includes cardio and strength training. And we ask them to do a little bit of meditation because these are the things which actually reduce the underlying insulin resistance. The second set of treatment by an endocrinologist, especially a person who is having hirsutism, acne, is we need to suppress the androgens actually that is there in the body, because otherwise none of her cosmetic treatments are going to work. So we use combined oral contraceptive pills, and that was discussed in detail as to which we should prefer, which we should not prefer, along with spironolactone. So in this lady, you can see she's having a very bad FG score. So we will not initiate step by step. Let's give OCP, then wait for 6 months, then give spironolactone. In this lady, we would like to give OCP plus spironolactone to begin with only, and monitor her with serum electrolytes and LFT once in 2 to 3 months. Of course, we use the help of doctors like Pujita and Dr. Rasya for the third level of management, that is treatment of the concern. So she has presented with her main concerns of hirsutism, acne and acanthosis nigricans. So treatment of concern is the third one. Treatment of the androgens is the second one. But the most important thing that we need to stress in every visit is that just by taking medicines and undergoing laser, bar, OCPs is not going to cure your condition forever. You need to concentrate on treatment of the cause, that is insulin resistance.
So we go to Dr. Pujita. Now the third concern, could you please tell us how would you counsel regarding the treatment? What treatments can you offer for both acne and hirsutism?
As Sir said, the underlying PCOS treatment is very necessary.
He's done that. He's now sent you the patient.
So after that, we'll be telling them that the patient firstly has to be little patient enough to see the results. So that has to be told to the patient first. And then we can parallelly start their laser hair reduction for the hirsutism. They will be seeing the results after around 2 to 3 sessions. But initially also, like with every session, they will start noticing the changes. Like there will be decrease in the hair pigmentation. There will also be decrease in the thickness of the hair as well. And along with that, topical eflornithine can also be given for the maintenance sessions. And
why is laser a better method of hair removal for a patient with PCOS when compared to other methods like waxing or epilation?
Because firstly, laser has good results. It is not painful, and the side effects with laser is less. Whereas all treatments like waxing and all causes folliculitis. It causes skin irritation. So it also increases the skin hypersensitivity, which will worsen the hair growth again. So that way, laser hair removal or reduction is better.
Correct. So it is more long lasting. It's longer lasting. And when combined with the medical treatment, the results can be significant. So you will get to do your laser at the end of the treatment, maybe 1 or 2 years. If they are doing all the things that Dr. Santosh is also asking them to do, they would be coming in for laser once in 3 months, which will be a significant life-changing event for them. Otherwise, they would have to go to the salon every week or every 10 days. Ma'am, now Dr. Shubha, the lady is now 30 years old. She's going to get married. Periods are still irregular. She is obese. She has an altered lipid profile. She has fatty liver. She has a HbA1c of 6.9. What she wants to say, what is my ideal contraceptive? She is saying, I'm not sure I'm going to get married. Should I use a contraceptive? What contraceptive should I use? Will I have infertility? How can you evaluate and how would you counsel this patient?
See, I really don't want to touch on the COC. It has been discussed so much.
Yes.
Practically, I would, use a second generation pill with the low estrogens. And here, her main problem is contraception. So as has been told, I would like to, first thing, find out whether she wants to get pregnant soon. Because if she wants to postpone her pregnancy, then I'm definitely going to use some OCPs, COCs, which is going to be an effective contraception, and also partly is going to help her for other things. But she needs more treatment in terms of her lipid profiles, and the other thing is she has abnormal lipids and all. So use a pill which is, as we have discussed, which is friendly to her lipid profile. And otherwise, one thing we could also do is give her progesterones every 40 days. And normally we would use dydrogesterone if she is, does not want to postpone her pregnancy and she would like to get pregnant as soon as possible. So apart from all the other treatment which is needed, I'll send her across to an endocrinologist or physician for, her lipids and things like that. But counseling is most important. And if she is keen on a pregnancy, as soon as possible, I would put her on progesterone from day 21 to 25 or from 40th day, so that she gets a withdrawal. And the idea of using dydrogesterone is that it is the least androgenic and it is safe for pregnancy. I mean, we give it to maintain pregnancies also. So I would put her on that. And other thing is use of metformin. So since her HbA1c is little high, so metformin also can, we would advise metformin. It will also help her lose a little weight and, not much of course, but that would motivate her to exercise and diet and lose some weight.
Dr. Santosh, would you like to add something?
Yeah, so as I said, as an endocrinologist, we will mainly concentrate on her diet, her lifestyle, and at an HbA1c of 6.9, we would definitely put her on metformin. Nowadays, there is growing interest in other agents also, which are helping in weight loss for women who are extremely obese before they conceive. So we are using something called as GLP-1 receptor agonists for help them, although it is not approved by Indian DCGI for use for obesity management. We do use it like off-label for some patients to help them to lose weight quickly, because it's one of the proven methods for weight loss. It's already approved in multiple countries for weight loss, the GLP-1 receptor agonists. Of course, but if it's still expensive, so we concentrate definitely more on diet, exercise, management of lipids, metformin, and about contraception. Many people, the moment we talk about OC pills, they'll talk about infertility because of OC pills. Yeah. Then I tell them immediately, see, OC pills will not cause infertility. It is after marriage, going out with your husband for eating a lot of biryanis and ice creams and cooking at home with a lot of oil. That is the one which is actually going to cause infertility, not the contraceptive pill. So please take care of your lifestyle. And if you require an OC pill which has been prescribed by your gynecologist, dermatologist, please take it for that limited period of time.
And one practical thing, I look at the husband also. If he is obese, I tell, because to maintain cook a diet separate for herself and that husband is not going to take place. So I recommend that the husband go out with her for a walk and follow the same diet at home and exercise together if they are not fighting, of course.
Thank you, ma'am. I'm a dermatologist, so I always tell them about barrier contraception, which doesn't have many of these side effects, but it's super difficult for newly married couples to use. So that counseling in mind. This is something I have experienced in my practice, is that sometimes when we start on OCPs and these people are having irregular cycles also, is that, and I'll tell them, okay, they don't want to come back to you. They want the prescription. They'll say, give me the prescription, I will take the tablet on the 5th day of my period or whatever. And sometimes they're pregnant. Have you experienced it, that when you're starting so that's a very important part of the counseling, is when you're starting a COC, to make sure that they're not pregnant before they start off this one. Would you like to comment, Dr. Shubha?
Yeah, I mean, in practice, I would definitely rule out a pregnancy if she has come to me amenorrheic. But of course, if she has come amenorrheic, I'd like to give her a withdrawal and then only start the COC from her 1st or 5th day of the period, mostly from the 1st day. So that is how we do. Because amenorrhea, whether she says she's had relations or not, or once engaged, they could be pregnant. So that's very important. And one disadvantage with the COC is that, newly married couple finds difficulty. I mean, it decreases the libido to some extent for some people because the androgen levels are a little low, and also vaginal dryness is what they complain about. So I think these are practical problems which they may not come out with, but unless asked, they find difficulty in having relations. That spoils this thing. So we have to really consider those practical aspects before prescribing COCs for them.
Ma'am, PCOD, PCOS, now she's pregnant. How do you avoid GDM? Can you avoid GDM? Is there some things that you can counsel her regarding?
See, if she is trying for a pregnancy, I really hope she has come to me early. If she has come to me early, I would assess her, look at her HbA1c, and start the thing of lifestyle modification, diet and all the exercise. And then, of course, universal screening for GDM we do. Right at the first visit, we are doing the glucose challenge test. And depending on that, we carry forward, repeat the tests, diet modifications. If she's on metformin for some reason, at least we wouldn't stop it immediately. She can continue that for 3 months at least. Post that, we screen again and see that, preventive is diet, lifestyle change, exercise. And if she was on metformin, as I said, I wouldn't stop that immediately. Other than that, you screen her for GDM and appropriately treat her at that time.
Sure. Dr. Santosh?
Yes, I will concur with Madam for everything that she said. So especially if she's on metformin, the institution in which we work, that is Magna and at Fernandez Hospitals, we continue the metformin till the 13th week of pregnancy. Then we stop it for 1 week and then do a screening for, that's called as early GTT. So we do early GTT in the 14th week only. All women with PCOS, they have to undergo an early OGTT. We're not talking about screening for diabetes here. Screening for gestational diabetes in the 2nd trimester itself is necessary as per the guidelines. We do that. And even if they don't have screen positive GDM, we still advise them to follow a healthy diet. They need to go through a dietitian and understand what are the things to prevent the GDM.
Dr. Santosh, she is 35 years old, known case of PCOS, not on any medical treatment. She's married. I don't know why we lost it. Can you help me here? Yeah. But she's got hirsutism. She has been going to Pujita and she's done about 6 sessions of laser, but she feels the thickness of her hair is not become reduced. What would you like to add if she's not on any medical treatment?
So married women, first thing we need to ask is whether she's planning for pregnancy soon or no. So if she is going to plan for pregnancy, say within a few months, then it might be difficult for us to even initiate other forms of treatment. Otherwise, for her also, we will follow the same principles which we 28-year-old lady. Diet, exercise, meditation is a must. We do start on COC plus anti-androgens in adequate doses for this lady as well for management. Of course, we have to rule out the other things which could be interfering with the treatment. That is hypothyroidism being the main cause at this time. Also hyperprolactinemia. So we need to rule out these conditions before we go ahead with a conventional COC plus anti-androgen treatment.
Dr. Pujita, sorry, I'm going to ask you this question. So a lot of patients who have lasers, they come and tell us, I am not better. is there any objective way of telling them why they are not better or something like that? Can you suggest something?
One thing, they may not be taking their underlying PCOS treatment correctly, and they'll be solely dependent on the laser hair reduction itself. And
The second thing is that to have photographs is very important, especially before and after treatment. Sometimes people feel they're not getting better, but there will be a significant thinning of the hair. So when they say they're not better, they mean they're not completely better. That is one thing. The other thing is to also watch out for the weight, watch out for the HOMA IR, so that you see. The third thing is how regularly they are coming in for their sessions. If they're not coming regularly, they are coming only once in 6 months, once in 4 months, they will not be better, because the laser targets the hair which is in the anagen phase, which is in the growing phase. So usually in the initial phases when we start laser in the face, it will be around 6 weeks. By the time they come to the 8th session, it will be once in 3 months. So you'll have to maintain a record as to how frequently is this patient coming and whether they are following all the instructions which they have given, like Dr. Pujita mentioned. Thank you. Back to you, Dr. Pujita. She is 35-year-old. Again, she is married. She is planning on pregnancy. She is currently on minoxidil and oral contraceptive pill with spironolactone. But she now wants to plan a pregnancy. So how will you manage her?
So firstly, we need to ask her to stop minoxidil, OCP and spironolactone, all the three. And later we have to tell her that, pregnancy itself helps in hair growth. The hair shedding also falls during pregnancy. It reduces during pregnancy. So along with that, if she's still keen, then we can start her on vitamin supplements like biotin, iron, vitamin D. And along with that, we can also use caffeine solutions. And nowadays, even low light laser therapy is also useful.
Okay, thank you. How to monitor a patient with PCOS for type 2 DM? So is there or lipid profile? How often would you call this patient back for monitoring in your clinic? And can we prevent type 2 DM in PCOS? Does PCOS mean that you are going to have type 2 DM?
Yes, if a patient has PCOS, the risk of developing type 2 diabetes is extremely high. So instead of making the patient depressed, I tell them this is a God-given sign that you might develop diabetes in future. So we should start making some certain lifestyle modifications right now only, which will help you to prevent type 2 diabetes in the future. So initially, diagnosing type 2 diabetes used to be doing a glucose tolerance test. But luckily, for the last 6 or 7 years, we are now started using HbA1c criteria for diagnosing diabetes. HbA1c is now a very simple test. We ask the patients to do it as often as once in 6 months also, because anyway, they like to do those multitude of tests from other labs. So HbA1c is always included in them. So an HbA1c, good HbA1c should be maintained at below 5.7. So if it's above 5.8 means they are entering into pre-diabetes and they will end up requiring a diabetic diet. They need to follow good exercise. There are certain treatments nowadays we talk about as far as diabetes reversal of pre-diabetes is concerned, that I will be talking post-lunch actually. So yes, so HbA1c is now being used more and more rather than OGTT for monitoring patients for type 2 diabetes. And once a year is recommended, but nowadays, because of the ease of getting it done, we ask them to do it as much as once in 6 months also.
Can I just add that if this lady wants to become pregnant, it is very important that, according to, I heard Professor Seshaya say this, that her HbA1c should be 5.1, and that should be the thing around 8 to 10 weeks. 10 weeks is most important because 10 weeks, at that stage, the insulin production starts. So, in utero, the programming changes if the sugars are high. So, we have to tell the woman who wants to get pregnant that it is very important for her child's future. So, that would probably motivate her to, keep her sugars low and get pregnant only when she is in an ideal situation.
Then quickly now, Dr. Santosh, I think one of the speakers covered this, where they spoke about the role of environmental toxins in early onset of menarche. Now, in our PCO patients, If they ask you what is the role of environmental toxins, what would you advise them?
So you can, anyway, that's put up on the slides already. So we have BPAs and EDCs, which they do cause a lot of changes in the hypothalamo-pituitary gonadal axis. They are unfortunately there in many of the fertilizers that are being used for growing vegetables and other things. It's something that we cannot really fight against the industry, but it is definitely shown to affect the hypothalamo-pituitary gonadal axis, which leads to precocious puberty and also endometrial hyperplasia in future and also development of PCOS. But we have to remember that PCOS itself is an environmental illness. So there is a large genetic component involved, but it doesn't occur in a person who is not having insulin resistance. And as we know, insulin resistance is highly dependent on what you eat and how you exercise every day. So I call PCOS itself as an environmental hazard actually. If you don't take care of your environment, you might end up developing PCOS, abdominal obesity like how I have, and then type 2 diabetes as well after that.
Yeah. At least you won't get PCOS.
I'm good to know that.
Dr. Shubha, the role of, I think this one also spoke about his role of physical and emotional stress. We are down to our last couple of slides. What is the role of physical and emotional stress on PCOS?
Sorry,
Physical and emotional stress in PCOS.
Yeah, chronic stress is a real bad thing because, we are born with a certain number of fat cells, but chronic stress causes release of the stress hormones, cortisol and all that, and that acts on the adipocytes and, makes them hypertrophy. So to break that cycle is very important. That is why, mentally we have to be, take any thing, which will reduce our stress. And the other thing is, gynecologist or whoever sees this patient, and if she is really stressed and has a mental problem, we have to refer them appropriately to the psychiatrist so that, she takes treatment as necessary. And the other thing is that these people are generally depressed a lot because, the endogenous estrogen causes some problems and therefore there is depression. So mental health is very important, and they could be also having eating disorders. And eating excess may be a comfort, or they could also be having anorexia. So it's very important to deal with all these psychological issues. And of course, nowadays, social media has made things very bad, body shaming and whatnot. So these are stressors which really cause problems, and they have to be broken in some way.
Okay. Dr. Poochita, role of nutritional supplement in PCOS?
Basically, vitamin D deficiency also increases the PCOS and its comorbidities as well. And that is why even calcitriol, it upregulates the insulin receptors. So it has two activities. One is the direct effect and also the indirect effect. So direct effect occurs by activating the PPAR delta, and this is basically involved in fatty acids and metabolism of adipose tissue, and also an indirect effect in the regulation of the intracellular calcium, which is very important for the insulin-mediated signaling in fat and muscle.
So supplementation is of vitamin D in your PCO patients. Ma'am, back to you. Role of myoinositol, role of supplements like myoinositol in patients with PCO. We see a lot of it, but there are no randomized control trials. Do you still give them to your patients?
I think, when they come, there are studies which say that because of their anti-inflammatory action, that it does help in so many ways. And therefore, when you cannot give them anything else, I think you must at least give them. And diets may be deficient, so all these omega-3 fatty acids, myoinositol, D-chiroinositol, they all have known to be, helpful. Therefore, only thing prohibitive is the cost many a times, but because it has to be taken long term. So I think I would definitely advise, especially if they are obese and then they are planning their pregnancies. So I would like to correct all the deficiencies, which probably will help the sugars or whatever to come down and will have a better impact on their health as well as pregnancies and all which they are planning.
Dr. Santosh, one line take-home message for our audience. We are wrapping up with this one-line take-home messages from all three of you.
As I said, my one line is treat the cause, treat the cause, treat the cause, and treat the concern. So treating the cause is more important. Environmental change, treating the insulin resistance, suppressing the stress in the life is more important. Treating the concern with XYZ treatments, that could be ovulation induction while they're trying for pregnancy or giving oral contraceptive pills or undergoing laser. Whatever has to happen, it has to be accompanied with lifestyle changes.
Take-home message?
As sir said, underlying treatment is very important. Along with that, counseling of the patient as well is very important from our side.
Yeah. Ma'am?
I would say counsel, 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 because I feel sorry for the lean PCOS because they don't have, what can you do for them? We can't ask them to lose weight. So for the obese PCOS, I say do whatever you want, join any gym, join any diet program, but you have to lose weight. That would be the primary thing. Remain in ideal weight, remain active, and this has to start from school. So I think I must urge the adolescent or the teachers who should inculcate the habit of exercise in all the children.
Okay, so Vidya Balan said entertainment, entertainment, entertainment. I think we have had the final word from ma'am. It's counsel, counsel, and counsel. Thank you so much, ma'am. Thank you, Dr. Santosh. Thank you, Dr. Pujita. Can I please request you to join us there for the mementos? I think lunch is served.
So we'll request Dr. Anantraman to close the pre-lunch session.
Yes.
There has been a fantastic, overwhelming response. I mean, I'm delighted. I think we've had more than about 160, 170 registrations even as of now, and I think some people are still coming in. So it's been fantastic to host you all, and hope we'll see you next year or the year after, depending on the situation. Thank you.
Good afternoon, everyone. Welcome back. We are going to start our afternoon session now. For the first topic, today afternoon session is evidence to practice clinical perspectives of diabetes management with new generation insulins. For this, I would like to invite Dr. Mahesh DM onto the stage to present the talk.
Good afternoon, dear friends. I thank Magna team for organizing this wonderful meeting today, which is filled with a lot of education material, especially endocrine and diabetes talks that are not only encouraging for us who talk, but also those people who attend will get a newer perspective as to what we usually see as evidence in our clinical practice and how we use the modern generation new insulins in current clinical practice. So today I will be briefly talking about the long-acting basal insulin and the ultra-fast-acting insulin and co-formulation that have come in the last few years. So if you look at the evolution of basal insulin, the first insulin we all know discovered 102 years ago, which led to the improvement or the first time having hope for those patients, especially with type 1 diabetes. There was a survival benefit, but unfortunately the first few years of survival ended up in either patients coming to hospital with extremely severe hypoglycemic episodes, or because of the formulation that is unpure insulin, they used to get multiple insulin abscesses and sepsis and succumb to the some other illness rather than diabetes. So the first 20 years of the discovery of insulin was led to the situation that the patients used to take treatment, survive, but the quality of life was very poor. That is when the intermediate acting insulin came in 1946, and for almost another 45 to 50 years there was no significant discovery with respect to addressing the problems that the patients were facing. So because for almost 3,000 years we were only bothered about survival. From survival, we moved to purity of insulin, which helped in survival as the only goal. But the quality of life was extremely poor in those patients who used to take insulin. Surviving with poor quality is as good as getting to stay in a jail for a longer period of time rather than succumbing. So that stage moved on to the discovery of glargine U100, which is one of the landmark discovery in insulin because it helped reduce the nocturnal hypoglycemic episodes to a major extent, almost 70% reduction in the nocturnal hypoglycemic episodes. Further, there was Detimer which came in, which was also having a slightly much better action profile compared to the NPH, but still the hypoglycemic episodes were there. So after some time, we used to see that the quality of life of patients was better, but not as good as what we expect that is normal. So our goal in the last 100 years has moved away from just survival to improving the quality of life by reducing the hypoglycemic episodes, and now moving towards normalcy and flexibility. So the goal of modern day therapy is not only reduction of the glucose levels, it is also avoiding hypoglycemia, improving the quality of life, reducing glycemic variability, and at the same time ensuring that the patient has flexibility in administering the insulin. So that means that the patient who has diabetes and is on insulin should be able to lead a life which is almost normal to somebody who doesn't have diabetes. That is the goal of the modern day insulin. That is why the discovery of insulin is progressing, because we are now moving away from survival to normalcy, which is a journey of 100 years. And if you look at these graphs, you can see here the NPH insulin had a peak effect, glargine had a slightly lesser peak effect, and if you look at glargine versus degludec, the peak is almost nil. And again, glargine U300, the peak is almost nil, which means that the risk of hypoglycemic episodes, especially nocturnal hypoglycemias, are significantly less. So what is the difference between glargine U100 and U300? U300, as we all know, means that in 1 ml, we used to have 100 units of insulin. Today, the same 1 ml contains 300 units of insulin. What is the advantage of having a reduction of the volume by 2/3? What we have seen is that this has helped improve the PK/PD, that is the pharmacokinetic and dynamic properties of the insulin, which has led to more gradual and slower release from the depot surface. Therefore, the peak effect is significantly come down. Therefore, this has led to full day coverage. Once daily insulin injection is enough, even at very large doses like 40, 50, 60 units also. Reduced risk of hypoglycemia, because of which there is significantly reduced weight gain. The insulin dependent, dosing dependent of the meal time is also less. Patient can take 1 hour, 2 hours or 3 hours on either side of the meal. This definitely has led to quality of life improvement. Therefore, obviously when the quality of life improves, better adherence can be seen. So the reasons to select new generation insulin are stable pharmacokinetic properties, flexibility, significantly less weight gain, available both as disposable and reusable pens today. The injection force is less. Not only the technology of the insulin has improved, but the delivery technique has also improved. And therefore, two more most important things that are required today are reduction of glycemic variability and reduction of the nocturnal hypoglycemia as well as daytime hypoglycemia. And the journey of glargine U300 has moved from PK/PD studies towards the addition, deliver specific type 1 diabetes patients, comparison with the long-acting degludec, and the in-range study which has looked at the glycemic variability, and the other studies that have looked at real-world data to see how this drug is doing. So this is the PK/PD data which shows the glargine U300 has a better steady state as compared to glargine U100. And if you look at the duration, it is almost reaches 30 hours in the body. So there are many trials which have looked at both type 1 and type 2 diabetes patients, both as a basal insulin, basal bolus insulin, basal only insulin. And when they have compared both in type 1 and type 2 diabetes, the significant conclusion of all the trials has been reduction in nocturnal hypoglycemia, improvement in the daytime hypoglycemia also. Along with that, there is also significant reduction of the glycemic variability. So again, when you look at BRIGHT study, which looked at the other long-acting insulin, that is degludec and glargine U300, they are almost similar in their action profile, and HbA1c reduction also is almost similar for all practical purposes. So glargine U300 has also been used in the renal impairment patients, and if you see, even in those patients, because of the lack of peak effect, there is 19% lower risk of anytime hypoglycemia, 27% reduction of the inpatient hypoglycemia, and also the emergency department related hypoglycemic admissions, greater HbA1c reductions, and almost 1.84% reduction in HbA1c at the end of 12 months with very low risk of hypoglycemia. So even in elderly patients who are at risk of fall and who have a poor renal outcome, you can see that there is a significant improvement in the HbA1c along with reduction of the hypoglycemic events. So glargine U300 today has been reducing the patients who are at risk of hypoglycemia. They are the best candidates. You have those with glycemic variability, those with busy erratic lifestyle, that is the most important, which is the flexibility in modern day practice, those with renal impairments, and also those with elderly with complications. In these groups, glargine U300, the next generation insulin, is answering or trying to address the problems that we used to see with the previous generation insulin, are being addressed with the new generation insulin. So if we look at the other basal insulin, what is the onset of action? Glargine U300 is around 2 to 6 hours, U100 is 2 to 4 hours, and degludec action onset of action is quite fast, almost 1 to 2 hours. Again, if you look at the time to achieve steady state, also it is around 2 to 3 days in all the three insulins. They are good in terms of attaining the steady state, and therefore one of the advantage of slow attainment of steady state is that the risk of hypoglycemia is very less, and you can always do the titration once in 2 to 3 days rather than doing the titration every day on an everyday basis. So what is unique about degludec is that this molecule is injected in a dihexamer form. There is a rapid phenol depletion which results in multi-hexamers, and then after the zinc diffuses, causing the individual hexamers to disassemble, slowly releasing the dimers and then monomers. Therefore, this process of diffusion that happens very slowly in a stepwise manner is one of the major reasons why there is no peak effect, and that is adding to the longer duration of action. If you look at degludec U100 versus glargine U300, the fasting mean plasma glucose was slightly better with degludec as compared to glargine U300, which is almost similar. But the goal is to convey that these insulins, the modern day insulins, are much better than the previous insulin in terms of better control of hypoglycemia or improvement in hypoglycemia, along with achieving the glycemic control, that is HbA1c of less than 7 is achieved at a much better rate because of the reduction of the glycemic variability. So the problem with the previous insulin glargine U100 was always the flexibility issue, because if you take 2 hours this side or that side, you used to have either an hypoglycemic episodes or a nocturnal pre-dinner hyperglycemia. Especially in type 1 diabetes, we usually use the word dawn phenomena when sugar is high in the morning, but this was a dusk phenomena where during the evening hours, because of the lack of action of the insulin continuing throughout the day, that is more than 24 hours, it used to result in hyperglycemia in the evening. So the patients used to have glucose levels normal at around 2 o'clock, 3 o'clock, and again at 6 o'clock, even if they don't eat anything, the glucose levels used to shoot up, resulting in glycemic variability. So today we have flexibility of degludec and glargine U300, almost 3 hours with glargine U300, and flexibility with degludec is almost 8 hours. So there is a wide range of population where this drug can be utilized, both renal hepatic impairment, elderly and pediatric patients. Study has been done with showing safety efficacy of this molecule. Again, if you look at the data from the evidence that we are seeing with glargine U100, the evidence is very good. Switch to begin, devote, EU treat type 2 diabetes. All trials have shown that the nocturnal hypoglycemia reduction is by 50%, and look at the most important, severe hypoglycemia reduction is almost by 86%, and even in this real world data 92%, which is very, very important. You don't want a patient to have even a single episode of severe hypoglycemia when they are started on insulin. Hypoglycemia will always be a part and parcel of their management, but severe hypoglycemia means going to the hospital, fear, and that fear will stop the patient from doing titrating the insulin, and also it will affect their lifestyle. In the end, you will get poor glycemic control because of one severe hypoglycemic episode. Therefore, the goal of modern day treatment is not just bringing down the sugar, but also preventing low sugars and trying to eliminate the very, very low glucose levels. Again, you can see the glycemic variability, the insulin variability within the day. Also at various time periods, if you see glargine U100, there is a peak effect around 6 to 12 hours. The insulin content in the body is quite high. Again, if you take degludec, it is almost similar toward the 24 hours. Therefore, within the day variability is significantly less with degludec compared to glargine U100. Again, the day-to-day variability is also significantly less. Almost, you can, if you look at glargine U100 versus degludec, the variability is just 20%. Here it is up to 82% with day-to-day variabilities. So now today we are moving towards what is TIR. TIR is the next HbA1c. So till now HbA1c was the top goal for us to reach. today HbA1c with time in range of 70% or more should be the term that will be used in future. So if you talk to any patient who is long-term diabetes, if after a few days the patient will come and tell, sir, my time in range is only 60%, though my HbA1c is 7, which means that he is spending more time in low glucose levels as compared to what he should do. Therefore, if you look at the time in range and time below range, it has to be significantly better with the modern day insulins, and that is what we are seeing here, that the modern day insulins are resulting in superior action profile with reduced time below range, that is the nocturnal hypoglycemia is less, overall daytime hypoglycemia is less. Therefore, the amount of time the patient spends in low glucose levels are significantly reduced, and that will result in improvement in the time in range. The patient will spend more time in the range of 70 to 140 or 180 depending on the type of patient, and that will help them to get better quality of life and reduce the complications related to diabetes. Again, we have real world data that shows 30% lower risk of hypoglycemia with degludec, and also when you look at comparison with glargine U300 also, there is a slight better hypoglycemic range. Glargine U300 also has some variability, though the action profile is very good. Degludec is far more stable than glargine U300. Again, day-to-day variability was also good for degludec. Insulin degludec is also considered to be more potent because of the duration of action profile is more. When you start using the drug for more than a month or so, you see that the insulin dose requirement with degludec is almost 20% less as compared to glargine U300. Therefore, some amount of reduction in the cost will come out at the end of few months of taking the drug. Again, at lower dose, you have better fasting plasma glucose control with degludec as compared to glargine U300. You can see here even in the RSSDA clinical practice guidelines, they have written that glargine U300 requires addition of 20% extra doses when you take it over a long period of time. If you compare the HbA1c action profile and also longer duration of using the molecule, you will see that at some point the glargine U300 dose is slightly more than the degludec molecule. So moving on to briefly the ultra short acting insulin. So the ideal insulin should always match with the meal. So it should not start too early, it should not start too late, and it should not continue too late into the action profile. What will happen is that either the patient will have a pre-lunch hyperglycemia or a pre-lunch hypoglycemia whenever the duration is too short or too long. Therefore, we need a molecule that will have an onset of action that is smooth, uniform, and in comparison to what we see with the meal. So the problem with human insulin that is currently available, it is a slightly slower absorption. Therefore, you have to take it 20 minutes or sometimes even half an hour before you eat. It has a slow onset of action, and it should be optimally administered. That is why it should be optimally administered 30 minutes late. And if by chance you administer just before the meal, then most of the time they end up in pre-lunch hypoglycemia or late postprandial hypoglycemia or pre-dinner hypoglycemia because of the variable action profile and the onset and duration of action. So today we have the insulin that has come from Banting and Best to the modern day insulin, which is the ultra fast acting insulin. The journey has been wonderful in terms of helping our patients achieve good glycemic control with reduction of hypoglycemia. So a normal pancreas releases insulin as soon as the glucose is detected in the blood. So that is very short, almost 5 to 10 minutes we see the action. But regular insulin takes 45 minutes to see the insulin levels rise, and it takes around 2 hours to peak. Again, the rapid acting insulin currently available is able to achieve near normal, but the ultra fast acting insulin is reaching the almost normalcy with respect to utilization. What is the advantage of this ultra fast acting insulin is that you can give the insulin just immediately after eating also. So especially in type 1 diabetes, when you don't know how much their intake is, how much they are taking, they can decide after eating whether they want to take 1 or 2 units more or less depending on their carbohydrate intake. So this will not go into details. Again, you can see here the faster acting aspart, the area under the curve is much better as compared to the aspart insulin. The aspart is much better compared to human regular insulin. So today we have improved PPG control and reduction of nocturnal hypoglycemic events and also preprandial hypoglycemic events because of the faster acting insulin, and it can be administered up to 20 minutes after the start of the meal. So you can start just 2 minutes before the meal up to 20 minutes after the meal without resulting in significant hypoglycemia. And the most utilized this drug could be will usually be during pregnancy, type 1 diabetes, and elderly patients, and also patients in the hospital where you don't know how much they will take. You can always decide to give just after they eat. Otherwise, we see sometimes you see the patient glucose level is 200 and you give say 6 or 8 units of insulin and the patient doesn't eat well, they end up in hypoglycemia. Then the next dose insulin is skipped and the patient eats well, sugar results in suddenly the fluctuating is there. So even though we are coming out of sliding scale, unfortunately coming out of sliding scale is not resulting in a major improvement in the glycemic fluctuations inside the hospital, and this drug could make life easier for those of us who are practicing in hospital, because we can decide based on what the patient has eaten. So therefore, the advantage of faster acting insulin is it can be used in the pump, subcutaneous, IV, all the special populations, pregnancy, pediatric and elderly also. So that is why the ultra fast acting, rapid acting analogs are almost mimicking the physiology, and therefore they are matching the very long acting insulin which has a stable basal profile with very short acting insulin which has the almost normal pancreas. So this basal bolus regimen that is currently available is almost near to the normal physiology that we see in a patient who doesn't have diabetes, and therefore the quality of life is much better in these patients. So finally, I will briefly end with the combination of these two molecules together. So high carbohydrate diet is a reality in India, and if you look at the STAR study, almost 60 to 70% of the energy intake of Indians is through the carbohydrates. Therefore, only basal insulin is not going to help us in achieving the glycemic control, because the studies have shown that only 30% or 20% achieve HbA1c less than 7% if they are started on a basal insulin only. So we need a prandial insulin, and therefore this molecule combination of aspart with degludec can address this problem by having a short acting insulin which is mealtime and very long acting insulin. Why is it important to have this combination is that this combination can be taken with any major meal. You can start the insulin in the morning, afternoon or night. It is not required that you have to give it at the same time, and even if the patient has flexibility, he can adjust, and if they have especially those who have shift duties, this is the ideal choice for them because they can change the insulin timing without worrying about the shifts. So we have good evidence when degludec has been, IDEGASP has been compared with basal insulin. This is a study that has looked at 267 patients with IDEGASP and oral drugs, and glargine with aspart separately and oral agents. And if you see, if it is given separately, again the 6.6% significantly lower dose with IDEGASP as compared to glargine U100 plus the aspart molecule. So the cost is also less, and the number of injections is less, and also achieved similar improvement in the fasting and plasma glucose and HbA1c compared to basal bolus therapy. So with single prick, which is flexible, you are able to achieve the same control with 2 injections given at different times, and at the same time reduction of the cost by reduction of the hypoglycemic episodes. Therefore, the current guidelines also talk about IDEGASP as one of the best insulins to initiate in those patients where you think that the PPG levels are also significantly high, because you can start with one insulin and titrate to 2 times daily and achieve the almost similar control when compared to basal bolus therapy also. So in India, where we want lower hypoglycemia, we want flexibility, we want the regimen to be simple, we want a device that is excellent in terms of utilization for young children, older adults also, and we want both fasting and PPG to come under control so that the HbA1c is under control, and we want effective glycemic control with reduction of the glycemic variability. If all these are achieved, we will see better quality of life for our patients, and if the quality of life is better, we can also say that the number of admissions to hospital and other costs will come down. Therefore, in the long term, the cost effectiveness also is seen. So today, the modern day goal of modern day insulin is to achieve quality of life that is almost equal to normal. So that is why they are called the next generation insulins, because they are not talking about HbA1c control, they are not talking about just reduction of the hypoglycemia, they are talking about something that we all feel. It is an emotional feeling that we have when we are normal and we have a disease, that I have a disease, by taking the molecules it is restricting me. So that restriction is gradually getting eliminated, and therefore the goal of modern day insulin is not just glycemic control, reduction of hypoglycemia, it is also to improve the quality of life. Thank you for a patient listening.
Thank you, Dr. Mahesh sir, for updating us with the newer insulins and the newer molecules. Thank you, sir. Thank you so much. For the next talk, I would like to invite Dr. Santosh sir onto the stage. Dr. Santosh is a senior endocrinologist from Magna Clinics, Film Nagar, Hyderabad.
So good afternoon, everyone. So I'll be talking about the clinical benefits of weight loss. One minute, there's something come up here. So this is the post-lunch session. So anybody who wants to sleep, please sleep, no problem. Just don't snore very loudly, that's all. So I am the organizing secretary of Endocrine Society of India, which is going to be held in Hyderabad this year. So we require your blessings to make sure that the conference actually gets held. Please block your dates, and if anybody is interested, please come also. We'll be ready to host you. So I'll be talking about a mechanistic link between obesity, diabetes, and CVD, and then I'll be talking about the effects of weight loss. Now, it is common knowledge for us that actually when BMI increases, the risk for type 2 diabetes increases. But when the BMI is increasing within the normal weight range, for example, BMI is moving from 21, 22, 23, the risk for diabetes is increasing very slightly. Once a person becomes overweight and becomes obese, the risk of diabetes increases very fast actually. For every unit increase in BMI, there will be a 1.5% increased chance of developing diabetes. This is better represented by this diagram actually. So if you can see, if you assume that the relative risk of developing type 2 diabetes is only 1 at a BMI of less than 22, up to 25 you see the relative risk is not increasing much. But after 25, it is suddenly exponentially increasing, so much so that a person who has a BMI of about 35 has 93 times the chance of developing diabetes as compared to a person who's having a low BMI. Obesity, pre-diabetes, and type 2 diabetes are nothing but just one disease continuum. So whenever a person is having obesity, you can see that here. So you can see that what's happening is slowly the insulin resistance is developing. Insulin resistance is causing worsening of the beta cell function. Muscle cells are becoming more and more susceptible for insulin resistance, and fatty liver is also developing. Once the person is moving from insulin resistance to pre-diabetes, it's the beta cell compensation that occurs. Beta cell hypersecretion will occur. There will be increased insulin secretion that will be occurring. And once the person moves into diabetes, the beta cell failure will occur and there will be increase in blood glucose. So obesity precedes pre-diabetes. Pre-diabetes will precede type 2 diabetes. It's just one continuum. But how can fat cells, so we are talking about deposition of fat in the subcutaneous tissue, in the visceral fat, how can it cause diabetes? Just because fat is there over there, how does the blood sugar increase? How does the cardiovascular disease risk increase? This is all because that when the adipocytes become from lean adipocytes to hypertrophic adipocytes, remember adipocytes secrete a lot of cytokines. They secrete a lot of inflammatory cytokines, and this inflammatory cytokines is going to all the areas of the body, especially the endothelium, damaging the endothelium and causing atherosclerosis. It causes altered liver metabolism, which leads to CVD and type 2 diabetes, reduces the insulin uptake at the level of muscle, and also beta cell secretion goes down. The lifestyle risk of incident CVD for different BMI categories is such that if you are in the normal BMI, you don't die. If you are high BMI, you will die faster. So that's what this entire slide shows. that the higher the BMI, the higher the risk of mortality as time passes by. Now, how does weight loss actually affect all these factors? That is what we are going to discuss. So goals and benefits of effective obesity management is number one, to achieve weight loss. So achieving weight loss might not be very difficult. You might have a very, very motivated patient who's doing some intermittent fasting or doing some keto diet or taking some medicines and losing weight. The second part is the most important one. After losing weight, to maintain that lost weight becomes the most difficult part. And if you are able to maintain that lost weight and mitigate the risk of diabetes, reduce the cardiovascular risk, reduce the functional impairment, and improvement quality of life, then only you are actually providing some clinically meaningful benefits. So for the first time, the ADA guidelines in 2023, they said now how we should approach a person who has diabetes. So initially, the ADA guidelines used to say, look at the HbA1c and treat the HbA1c. But nowadays, ADA guidelines says, don't look at HbA1c, please look at the weight of the patient also. Please look at the cardiovascular risk that the patient is having, and please find out if the patient has associated comorbidities, and then only decide what to do. And to be very frank, it is for the last 2 to 3 years that even we endocrinologists who are meeting people with diabetes for the first time in the OPD are now talking about weight loss as one target. So we used to always tell, keep your HbA1c below 7, keep your BP below 140/90, keep your LDL below 100. We used to never talk about the weight that much. We used to say, do exercise, like that we used to tell. But now we have started talking about weight as an important tool for managing diabetes, and that's what the ADA guideline also says. They also talk about giving good cardiovascular risk management. For every patient with diabetes, don't concentrate only on the blood glucose, but also concentrate on the weight, smoking, BP, lipids, everything you need to concentrate. Then only you're giving holistic care to the patient. How does weight reduction help in the management of type 2 diabetes? Weight reduction, as I said, will improve the insulin sensitivity and preserve the beta cell function. But at least 5% weight loss should occur. Then only the clinically meaningful benefits occur. And for every kg of weight that you lose, you would actually reduce the HbA1c by 0.1. These are the studies which show what are the evidence of benefits of weight loss. So diabetes prevention, so a person who has entered into pre-diabetic stage, we have studies like the Darking study. The Darking study says that if you lose weight, the prevalence of, the incidence of developing diabetes drops by up to 51%. And even after 20 years, if you have lost weight, you're actually preventing from entering into diabetes. The Finnish diabetes prevention study and the DPPOS study, they all say that only if you lose weight, the chances of moving from pre-diabetes to diabetes lessens significantly. There is one trial called as the direct trial. Direct trial is people who already have an HbA1c of above 6.5, are they able to reverse the diabetes by good weight loss? And they said by good lifestyle intervention, you can reverse the diabetes and become medicine-free also within 1 year only. So this is 1 year data of direct, okay? So if you lose a good amount of weight, you can actually go back from taking medications for diabetes to not taking medicines. But in people with diabetes, to make them lose weight, it's much more difficult. Why? Because in advanced cases of diabetes, you know, they will be made sedentary because of neuropathy, foot ulcers, heart disease. In the early cases of diabetes, patients have lost weight because they have high blood sugar. And you suddenly control the blood sugar, they'll end up gaining weight actually. Glucosuria will go down. There are medications in diabetes that cause weight gain, insulin, sulfonylureas, thiazolidinediones. And a patient who is worried about hypoglycemia will keep snacking intermittently, and therefore it becomes very difficult for them to lose weight. What are the weight loss medications and what are their effects on the HbA1c levels? So in India, remember, there are only 2 medicines that are approved for weight loss, and one of them is not even available. Okay, so one is Orlistat, and the other is semaglutide 2.4. Although it is approved in India, it is still not available in India because it has become such a popular drug in the US that US is using up all the semaglutide that's available. It's not yet reaching India actually. But it's approved, so the DCJ is approved. So once it does come to India, many more people will benefit. There are certain other drugs also which are now going to come in, that is the appetite suppressing drugs like naltrexone, bupropion, phentermine and topiramate. They all cause significant amount of weight loss. But the ones, the liraglutide and the semaglutide, As we know, they are not only weight-reducing agents, they also help in the pathophysiology of type 2 diabetes itself. And the prevalence of the reduction of HbA1c is much more with these agents as compared to orlistat and the other drugs. So this slide shows the same thing. People with diabetes, they find it much more difficult to lose weight as compared to those who don't have diabetes, irrespective of whatever agent they are using. Among all the agents, it is semaglutide, which is the most strongest molecule which is going to cause weight loss. And I said it's already approved in India, so we are going to discuss a little bit about that now. This is the step 2 trial, that is weight management in type 2 diabetes. So, I was actually selected as one of the investigators for this trial. When I went for the investigator meeting and came back, the management in the hospital of my hospital changed completely. So ethical committee was not there only when I came back. And then I said, I unfortunately could not take part in this trial after that. But this trial had a very, very nice way of doing it. So they compared placebo or semaglutide 1 mg or semaglutide 2.4 mg, and they wanted to find out, especially in patients with type 2 diabetes with age greater than 18 years and on 1 or 2 oral antidiabetics, what is happening. It was seen very clearly that with semaglutide, you are able to lose weight very nicely, and 2.4 mg of semaglutide, remember, this is a trial which went on for 68 weeks, and still the patients managed to lose and maintain weight loss of up to 10 kilograms, even after 68 weeks, which is an amazing number. HbA1c understood, as I told, semaglutide, the GLP-1 receptor analogs are one of the most potent anti-diabetics. And therefore, those patients who are on 1 mg semaglutide or 2.4 mg semaglutide, they had an HbA1c reduction almost up to minus 1.7 to minus 1.9. But semaglutide 2.4, it showed beautiful results in the composite outcomes. That means people who are able to reduce 10% of their body weight and also have an HbA1c of less than 7 was seen in 45%. And 1 in 4 patients were able to achieve a weight loss of 15% weight loss and having an HbA1c of less than 7. And most of them were actually reducing their diabetes medicines. The HOMA beta and the HOMA IR also significantly improved as the patient lost weight and were using semaglutide. With semaglutide, there was improvement not only in the sugar parameters and weight parameters, systolic BP and diastolic BP was also decreasing. And fasting lipids have also changed to the beneficial part. The HDL cholesterol is increasing and the triglycerides have started decreasing. And therefore, cardiometabolic effects of GLP-1 receptor agonists have expanded. They don't only affect the pancreas. In pancreas, as we know, they cause glucose-dependent insulin secretion and suppression of glucagon. They don't affect only the gastric emptying, but they affect in the brain to reduce the satiety. To improve the satiety, to increase the satiety. In liver, they reduce fatty liver. In the heart, they reduce the cardiometabolic risk. And in the kidneys, they increase the natriuresis and BP improves. Therefore, all the studies that have been done with GLP-1 receptor agonists, especially semaglutide, that molecule which we are talking, they are shown not only to control the blood sugar, but they are shown to be intensively protective for the heart, for the kidney, and for the liver as well. And stroke also is reduced quite a bit in those patients who use GLP-1 receptor agonists. To summarize, obesity, it's a complex multifactorial disease. It affects 2 crore adults in India, and obesity-related systemic inflammation will increase type 2 diabetes and cardiovascular disease. GLP-1 receptor agonist helps in reducing the HbA1c. It might help in diabetes remission. It reduces BP, it improves lipids, it improves quality of life, decreases sleep apnea, improves pain, renal protection, and improved NAFLD and NASH. Therefore, making this GLP-1 space a very, very interesting space. And yes, cost is definitely a concern. For most patients who afford it, they can have this myriad of benefits with these particular agents. So with that, I think I'll conclude and we'll stop it here. Thank you. Thanks a lot.
Thank you, sir. Thank you for the wonderful talk. For the next session, I would like to invite Dr. Basavaraj sir onto the stage to speak on the...
Are we having the panel discussion? I think we can close it for this matter of, to save some time.
Yeah, after.
I think we can have Dr. Basavaraj speak and then we can close it. Because time will be saved then. Give me a mic, no? Give me a mic.
Hi, I'm Dr. Shalini. Enjoyed your talk. So about the semaglutide injectable, you said it's coming. How soon is it coming? And the cost is prohibitive, 20,000 rupees per injection. Is that right?
Each semaglutide will work, as we know, for up to 1 month, each injection. Or whether it's going to work for 1 month or 15 days, I don't know. Yes, it's going to be priced around 15 to 20,000 only, that's for sure. But if you go to all these apps and you go to all these cult fitness and all, they are charging much more than 20,000 per month. So I think something which actually works might attract the patients more.
Yeah, I think this Elon Musk guy, made it like a hotcake selling. After he announced that I use it, I think it's been flying off the shelves.
Yeah. So we don't know when it will actually come out. Now with the change in the NMC guidelines, it might take even longer, I feel. I don't know. When it will actually
Oral semaglutide also gives us some little bit.
Oral semaglutide is approved for management of type 2 diabetes with obesity. Fantastic weight loss with oral semaglutide. It is the most potent weight loss agent that we have for our people with diabetes right now. But for non-diabetics, not approved for management.
But still, some off-label use has been going on.
We should not comment about that on the stage.
Thank you.
Thank you, sir. Dr. Basavaraj sir is a senior endocrinologist working in Narayana Hrudayalaya, Bangalore. Now he is going to speak on harnessing real-world experience with the oral semaglutide.
Thank you. Thank you, Magna Foundation, for giving me this opportunity. And I think we didn't hear any of the snoring, so I think everyone is alert. And thank you, Dr. Santosh, for setting up the stage about the importance of the weight, its impact on the cardiovascular diseases, and how to tackle about the weight, some of those things. So, probably now what we'll be talking about is what Madam also started the discussion was with or without diabetes. So now I'll be talking about some of the case scenarios where semaglutide has been used in the management of people with diabetes. And I've been fortunate enough by God's grace to be a part of some of these trials with semaglutide, the injectable ones, the focus trial, which is looking currently undergoing also for the efficacy of its or the safety parameters of its worsening of retinopathy, and probably a couple of more GLP, CagriSema and other things. So a couple of my experiences also I'll be sharing. So hold on to your seat and sit tight. There we go. So we'll be talking about the benefits of early multifactorial therapy in reducing the risk of complications in type 2 diabetes, the role of GLP-1 RAs in targeting multiple pathophysiological defects of type 2 diabetes, the oral sema, the new standards which it has set in the management of type 2 diabetes, and benefits beyond the glycemic control. So now, a newly diagnosed type 2 diabetes, 33-year-old lady who is obese, BMI of 29.5 kilogram per meter square with an A1C of 8.5%, comes with high cholesterol, dyslipidemia, who is on metformin 1000 milligram twice daily, mostly maximum tolerated dose, sedentary lifestyle. Mother had family history of, she has got a very strong family history of type 2 diabetes, died at the age of 65 years with CVD. Patient concerns are increasing HbA1c level with increasing weight and the associated comorbidities. So we have to understand that this has been again time and again by the follow-up data of STENO-2 trial has been told that early multifactorial therapy reduces the risk of complications in people with type 2 diabetes. So we have to target the STENO-2 targeted glycemic control, the platelet inhibition, aspirin, dyslipidemia control, the blood pressure lowering, and the lifestyle modifications, including the weight management. So the intensive and the whole of this trial period ran for 7.8 years, very small group, 160 in each group, 160 patients, they followed up. So the follow-up after 21 years of follow-up, with 7.8 years of initial intensive management led on to a decrease in the all-cause mortality of 45%, survival of more than 7.9 years in the intensive group, and time to first CVD event of 8 years, and the microvascular complications, relative risk reduction decreasing to the tune of 48% also. So we also understand that higher HbA1c predicts the higher CV risk. The fatal and the non-fatal MI, if you see that 1% reduction in the HbA1c reduces 21% relative risk reduction for any endpoint related to diabetes, 21% for death related to diabetes, 14% for myocardial infarction, and 13% relative risk reduction for microvascular complications. So, greater weight loss improves obesity-related complications. We understand that less than 5% of weight loss leads on to some improvements in the hypertension and hyperglycemia parameters. 5 to 10% of weight loss, prevention of type 2 diabetes, NAFL, PCOS, and some parameters of dyslipidemia. 10 to 15% leads on to some improvements in the cardiovascular disease outcomes, urinary stress incontinences, OSA, GERDs, NASH, what Dr. Santosh did focus upon, knee osteoarthritis, definitely. And then more than 15%, again, a direct, implication of direct trial leads on to more number of patients with type 2 diabetes remission, lesser incidences of heart failure with HFpEF, and CV mortality. So HbA1c is still reducing at more than 15% weight loss. So more the weight loss in the obese segment, or in the people with obesity, HbA1c gives a better value there. So early intensification prevents the long-term complications. So a legacy effect, which we did speak of, is a long-term benefit conferred to individuals who have been having controlled sugar in the very early stage of the diabetes. So 1% of HbA1c reduction immediately after diagnosis leads on to 20% of risk reduction for myocardial infarction. Sorry for that, 90% risk reduction for all-cause mortality. Delaying 1% A1C reduction until 10 years after the diagnosis leads on to a very dismal number of 7% risk reduction for MI and 3% relative risk reduction for all-cause mortality. So this gets on to the importance of early control of diabetes. So early initiation of newly diagnosed patients to avoid complications and mortality. So that leads on to the very important aspect of a clinical practice, which is your legacy effect or the metabolic memory, which probably we have to understand and pass on to the patients, telling that the initial phases of the diabetes journey is what really matters for the longer term control. So GLP-1 receptor agonists target multiple pathophysiological defects of type 2 diabetes. GLP-1 is an endogenous molecule. It's an incretin hormone secreted in the gut in response to the food intake. Yeah. So when you take food, there's increase in the blood glucose level, along with certain of the amino acids also are potent signals for the GLP-1 secretion that lead on to increased levels of insulin secretion, decreased glucagon secretion, decreased glucagon production, decreased gastric emptying, improving the satiety and decreasing the food intake, improving the beneficial effects on the cardiovascular system, and with a very low risk of hypoglycemia. So then coming about the pioneer trials, there have been n number of pioneer trials, the numbers ranging from 1 to 12, Pioneer Plus, Pioneer Real, and whatnot. So most of the data has been quite a good number of elaborate data in various subset of the patient population has been done. So what it talks, the Pioneer one had semaglutide versus placebo in newly diagnosed patients of diabetes who are treatment naive. So in them, so the achievement of composite target of an A1C of less than 6.5% plus a weight loss of more than 5% was better with oral semaglutide versus as compared to that of placebo. If you see, it ranges from 20% in oral sema versus placebo of 8.5%, and then over the follow-up also within less than 1 year and more than 1 year also, oral sema did achieve a good composite target there. Oral semaglutide has showed superior A1C reduction versus DPP-4 inhibitor, that is again Pioneer 2 trial design. It showed that versus sitagliptin as an active comparator had better A1C reduction with oral semaglutide 14 milligram as compared to that of sitagliptin. So oral sema also showed superior A1C reduction versus SGLT2 inhibitor. That's again Pioneer 2, which was studied in some 800 plus patients, showed better A1C reduction versus SGLT2 as an active comparator. Yeah. So then oral semaglutide showed better weight loss in the trial settings as compared to that of the SGLT2 inhibitors in that of the Pioneer 2 trial design, which we had already discussed. So if you see this bar diagram, what we understand is that higher proportion of patients achieve targets, better targets with oral semaglutide compared to other active comparators, be it in monotherapy, be it versus EMPA versus ITA, even versus liraglutide and with insulin added upon to insulin also gives you a better number of patients achieving good control of diabetes, the target A1C levels. So GLP-1 receptor agonists reduce body weight through appetite suppression. So energy intake and food consumption overall are reduced with semaglutide versus that of placebo. So if you see the energy intake during ad libitum lunch time, so in someone who is on semaglutide, they did consume roughly around 2,300 kilojoules versus placebo of almost 3,600 kilojoules of energy. So there's a 35% relative risk in the difference energy intake on sema versus not on oral sema. So sema versus placebo, they had the patients on sema did score better on the questions related to food cravings and control eating and portion sizes while still feeling meals were still pleasant. So overall, some calculated model gives us a rough estimate that people on oral semaglutide tend to lose a 4.7 centimeter of waist circumference. So the clinical attributes of concern or of importance for oral semaglutide includes a superior A1C reduction versus EMPA and sitagliptin, and clinically relevant weight loss through appetite suppression, providing the efficacy of GLP-1 RA in an oral formulation, and providing significant waist circumference reduction. So now going to the second case scenario, who is again a patient with a type 2 diabetes with multiple cardiovascular risk factors. So this is a 47-year-old male, BMI of 30 kilogram per meter square, A1C 9% with hypertension, dyslipidemia, currently on metformin, DPP-4 inhibitor and SL2 inhibitors. The patient concerns are, as usual, the worsening HbA1c levels, worsening weight, comorbidities, and family history of CVD. So GLP-1 RA in this clinical context of increased cardiovascular risk factors has beneficial effects on the multiple beneficial effects on the cardiovascular system. Potential mechanisms of the beneficial actions of GLP-1 in the cardiovascular system include your improved endothelial function, improved vasodilatation, plaque stability, better blood flow, and improving the diuresis and natriuresis, decreasing the inflammation, smooth muscle proliferation, and platelet aggregation, leading on to its supposed cardiovascular benefits. So Pioneer 6, this was the cardiovascular outcome trial, the CVOT trial done for oral sema, which showed a 21% non-significant relative risk reduction in the MACE events, and there were lesser amount events in the oral semaglutide group. But we need to understand that this was done for non-inferiority. The trial for again superiority is awaited, I think. So oral sema demonstrated a favorable CV profile, which you can see that it was non-inferior to placebo in terms of MACE, and the cardiovascular death was statistically significant to the tune of relative risk reduction of 51%, and the all-cause mortality was also better to the tune of 49% of RRR reduction with oral semaglutide. So oral semaglutide also reduces the systolic blood pressure by 5 millimeters of mercury. So hypertension does increase this cardiovascular risk in people with diabetes. So we understand that a 5 millimeter decrease in the systolic blood pressure translates to decreased relative risk reduction or of 13% in stroke, 7% for IHDs, 14% for heart failure, and 5% for deaths related to diabetes. And then it also reduces the LDL and triglycerides. So LDL cholesterol and triglycerides level are better with people on oral sema versus that of the placebos. So oral semaglutide also reduces the vascular inflammation. So CRP in couple of these trials showed that it was better control or lower in people on oral semaglutide. So choosing the right antidiabetic agent, so we understand the pros and cons of various antidiabetic agents. Now we have got an armamentarium of the oral antidiabetic agents, including insulin, the injectable ones, including the injectable GLP-1s also. But if you see, again, one of the potent molecules are these GLP-1 receptor agonists for your glycemic control, with a very good effect on the body weight, with cardiovascular risk reduction, with multiple pleiotropic benefits, with a very low risk of hypoglycemia. So probably GLP-1 receptor agonists do play a good important role in ticking on all of this. So I think with this I'll end the talk. Any questions, or we can directly wind up? whatever the organizers feel. Nausea. GI side effects are very common. The nausea is mostly the predominant one. Usually Indians tolerate to pretty good extent 3 milligram and 7 milligram. Escalating from 7 to 14 is usually an issue in Indian patients. Yes, ma'am. Except this DPP-4, because DPP-4 is also acting on the same incretin mechanisms, so it wouldn't add any of the value if you combine a GLP-1 with a DPP-4. Yes, yes, ma'am. Yes. Yeah, if you ask me lifelong, but most of the Indian patients, I don't think they'll be able to take it up that. But my discussion goes with initial starting up this therapy for 6 months, 3 months, make them see the results of that and probably then see how things go on. So a couple of my patients are 6 months through after seeing the good weight loss benefits. So I think they are wanting to continue. So probably next year also I might come back and tell if any of my patients did continue more than a year also. Thank you. So I think.
Thank you, Basaraj.
Thank you.
So thank you all the faculties. Now we'll go to the session 8. So I welcome Dr. Channaraya, Dr. Lalita, and Dr. Raghuram sir for the dais. We have the slides, introduction please. So Professor Channaraya sir is a senior consultant physician. He works at Hyderabad Hospital, Bangalore, and he has won Best Teacher Award at South Zone Epicon 2022. Dr. Lalita Madam, Associate Professor, Karnataka Institute of Endocrinology, and she has published various research articles in national and international journals. Has special interest in gestational diabetes and diabetes in young. Next slide. Dr. Raghuram, consultant diabetologist at Kanva Diagnostic Center, and he is part of many diabetic conferences as speaker, moderator, and chairperson. Over to chairperson.
Good afternoon. I welcome you to the session 8. We have 2 speakers lined up. The first speaker is Dr. Prithviraj. Yes. So he is going to speak to us on insulin paradox. Are we initiating to fail? He is a consultant endocrinologist at Magna Center in Hyderabad. He is the ex-assistant professor in the Department of Endocrinology at BYL Nagar Hospital, and he is the member of various conferences attended various as a faculty and a co-investigator of various diabetes-related research projects. Now over to Dr. Prithviraj.
Thank you, sir. Thank you for the warm introduction. Slides, please. Good afternoon. Today's my topic is insulin paradox. Are we failing to initiate the insulin? Prior to the discovery of insulin in 1921, humankind and the diabetes patients suffered a lot, and it is like a death sentence to those patients. With the discovery of this miraculous drug called insulin, diabetes treatment has drastically changed, and the longevity of the diabetes patients has been improved. And with the evolution of newer drugs, now we again go back to the stage where we are hesitating to start the insulin to the patients, even though they are ideal candidates to start the insulin. That is the paradox I am going to discuss. The agenda for today's topic is why consider an early insulin initiation in diabetes patients, and what is the right time to take control for the type 2 diabetes control. And initiation is not only enough, titration is equally important, and how to balance glycemic control with insulin versus the hypoglycemia risk. Why to consider an early insulin initiation? This is a landmark study, is the pan-Indian study, longitudinal study done over 3 years at multiple sites, found the real world outcome of diabetes treatment in Indian patients. These numbers are very scary. It shows that 4 out of 5 type 2 diabetic people are uncontrolled in India, and less than 1 in 4 Indians with established type 2 diabetes take insulin. Average HbA1c at which insulin is initiated is very high, that is 9.2%. Even this is from the another study that is got published recently. Even after insulin initiation, attainment of general HbA1c target is often inadequate in our Indian day-to-day practice. This is because of inadequate titration of the insulin. 8 out of 10, our 10 patients fail to get the glycemic control. This is the real-world data that is available. Why should we need to achieve target HbA1c? We all know this UKPDS 1998 data where it showed that HbA1c decrease of 1% decreases the deaths related to diabetes by 21%, decreases the myocardial infarction by 14%, decreases the microvascular complications by 37%. So when is the right time to take control and start insulin? These are some of the factors which are causing for the physicians and the patients to delay the initiation of insulin in the insulin requiring patients. One of the most common causes is patients' lack of knowledge of the diabetes and its side effects, and patients' poor concordance with the insulin therapy, and patients' refusal to take the insulin, and the doctor's lack of insulin titration periodically. This was in detail explained by the Basavaraj sir, legacy effect. We all know about the legacy effect. In the de novo diabetes, if in the initial 6 months to 1 year, if the glycemic control is very good, even though in the later half of their period, if the HbA1c is little bit on the higher side, the complications are observed were very less in comparison to people who had a very bad HbA1c in the initial phase of diabetes, diagnosis of diabetes. They found that when the diabetes patient, de novo type 2 diabetes patient, initial HbA1c is strictly controlled, there are less chances of having microvascular complications, myocardial infarction, and all-cause mortality. Titration. As I said, initial insulin initiation is just a part of the beginning, and we need to monitor them very periodically if necessary, initially at every 5 to 7 days to titrate the basal insulin to achieve our target HbA1c, target fasting plasma glucose, and target glycemic control. More than 80% of the maximum treatment effect occurs in the first 12 weeks. In this initial period, they required often very frequent monitoring and titration of the insulin. Early response predicts long-term glycemic control with 12 weeks HbA1c levels maintained up to 24 weeks. Early hypoglycemia has also a risk of future hypoglycemia events. Hence, we need to titrate the insulin sequentially and gradually. Early hypoglycemia increases the risk of treatment discontinuation also, and from the patient non-compliance side also fear of hypoglycemia is one factor. So we need to titrate our insulin doses on a periodical basis in a gradual manner, stepwise manner. Once initiated, optimized titration lead to effective glycemic control. Dose titration is patient specific and should be done in order to achieve target fasting plasma glucose of less than 100 mg per deciliter. Adequate titration of the insulin dose either by physicians or by patients can help patients reach their treatment goals, including HbA1c of less than 7% and fasting plasma glucose of 100 mg per deciliter. This is again the real world data, and this is recently published where they advised some best practices for insulin initiation and titration through expert opinions. In this, they mentioned that in India, the average titration dose of basal insulin remains 18 units in practice. In contrast, in clinical trials, titration of doses of up to 40 units has been reported. Indian physicians and Indian doctors procrastinate too much on starting insulin and titrating upwards very slowly. These are some of the causes for the failure to titrate the optimum insulin doses for the patient, for our type 2 diabetes patients. These are the causes found in the real world data studies. They found that the most common cause is the patient non-compliance, that is discontinuation of insulin, and few other common causes are fear of hypoglycemia, and there is a physician's or doctor's lack of titration of insulin periodically, and there are some other causes you can see here, lack of support and occurrence of episodes of hypoglycemia, lack of diabetes education, and the cost of the insulin. All these are the causes for the inadequate titration of insulin in our Indian setting. As I said, fear of hypoglycemia is a major barrier to insulin initiation and optimal insulin titration. Most of the times we see that we write one doses on paper and patient takes the doses very subnormally on their self because of the fear of hypoglycemia. This is a very common phenomenon in our OPD settings. Therefore, we need to converse with the patient and convince them the importance of the insulin intensification in order to control their fasting plasma glucose and HbA1c. Careful titration of insulin therapy can achieve a glycemic control without significant risk of hypoglycemia. In clinical practice, as I said, fear of hypoglycemia is a barrier, and this can cause the decreased desire of the patient for tight glycemic control and reduced willingness to intensify therapy and poor adherence to the diet therapy and the insulin therapy and compromised compliance of taking medication. We need to elevate their fear of hypoglycemia and gradually uptitrate the insulin to achieve the target. As I said, in the initial 3 months period after initiation of insulin is very crucial. We need to avoid the hypoglycemia. At the same time, we need to control our fasting plasma glucose to achieve our target HbA1c. Hypoglycemia during initial 3 months post-basal insulination is predictive of long-term risk of hypoglycemia over the ensuing 3 to 24 months. As you can see the odds ratio from the various countries' data, the odds ratio is very high. If the patient develops hypoglycemia in the initial 3 months of initiation of insulin, the chance of developing hypoglycemia in the future is also very high. So we need to gradually uptitrate our insulin, basal insulin doses, and achieve it needs to be patient-centric, and we need to achieve optimal dosage for the individual patients. How to balance this glycemic control and hypoglycemic risk? As I said, there is a very advantages of having effective glycemic control. It improves achievement of HbA1c targets. It prevents complications of microvascular and macrovascular complications and can lower healthcare utilization. It can restrict regimens which may improve adherence and quality of life. We need to balance this with the risk of hypoglycemia with the insulin. We need to elevate the patient's fear of hypoglycemia, and we need to we need to be in touch with the patients and may improve adherence of the patients to insulin in the initial 12 weeks. We all know that basal insulins, we have first generation basal insulins, that is Glargine 100, and we have second generation basal insulins, that is Glargine 300 and Degludec. This second generation insulins, as explained by the previous speakers, has significant advantage over the first generation basal insulins in the risk of in the having of very low episodes of nocturnal hypoglycemia or anytime all day hypoglycemia. So hence second generation basal insulins made our job a little bit easy in elevating the patient's concern of fear of hypoglycemia. The efficacy wise, both first generation insulins and the second generation insulins, Glargine 300 and Degludec, are equally efficacious, and second generation insulins are more tolerable. As we can see, the target HbA1c achieved by both Glargine 300 and Degludec 100 is similar in proportion. As I said, the efficacy both in the titration period and the maintenance period by the second generation basal insulins, that is Glargine 300 and Degludec 100, are very much similar. What about the hypoglycemia? This is the BRIGHT study, which is done head-on study, which directly compared second generation basal insulins, that is Glargine 300 and Degludec 100, and they found that the Glargine 300 has an advantage of having lower episodes of hypoglycemia. Early hypoglycemic events during titration are associated with increased rates of treatment discontinuation, as I said, and Glargine 300 has an advantage of reducing this risk of hypoglycemia. This is the study of second generation insulin Glargine 300 versus the pre-mixed insulin we have, that is insulin Degludec aspart. As there are no head-on comparison trials, they have tried to compare by indirect treatment comparisons. As we can see, there are multiple studies comparing the Glargine 300 versus Glargine 100, and there are multiple studies comparing Glargine 100 versus pre-mixed combination of insulin Degludec and aspart. So they indirectly, through this butcher method, they indirectly compared the glargine 300 with the premixed combination of insulin, degludec and aspart. And their systemic literature analysis showed that there is no significant difference efficacy-wise in between the second generation insulin, that is glargine 300, and a premixed insulin of degludec and aspart. And glargine 300 has an advantage of less weight gain with a mean difference of minus 1.3 kgs over 24 weeks duration. Glargine 300 was also associated with a lower risk of hypoglycemia overall and nocturnal hypoglycemia. Efficacy-wise, both are similar. All the new generation insulins and premixed insulins are similar, but glargine 300 has a slight advantages of low risk of hypoglycemia. And recently, from the post to 2018, we have so much of data on the second generation basal insulins in the pregnancy also. Earlier, we used to hesitate using of glargine 300 and degludec in pregnancy. Now we have so much of data, so we can start using them in the pregnancy. This study got published last year in the Diabetes Journal, where they have accumulated data from 246 patients of pregnant patients, post-marketing surveillance from 44 countries, and they have found that glargine 300 during pregnancy was not associated with specific adverse events or congenital abnormalities. The results suggest no safety issues with the use of glargine 300 during pregnancy. As I said, early initiation of insulin for the ideal candidate and adequate titration in the initial 12 weeks is very much important to get an optimal control of fasting blood sugar, HbA1c, and overall diabetes. To summarize my talk, insulin initiation in India is majorly delayed due to various patient and physician factors. Early and more appropriate interventions may improve patients' chance of reaching their target goals. Achieving early glycemic control may generate a good legacy effect. Guidelines are unanimous in recommending basal insulin at initiation. Timely intervention needs to be adopted to overcome therapeutic inertia in initiating insulin and titrating insulin. Earlier and more appropriate interventions may improve patients' chance of reaching their goal. Glargine 300 is an ideal insulin. Degludec and the second generation insulins, both are ideal insulin that can be safely used for insulin initiation and titration with a balance of efficacy and safety. Thank you. Thank you for the kind listening. I can take questions now.
Thank you, Dr. Prithviraj, for that wonderful presentation. You have highlighted the use of insulin, though we have several drugs for use today in our day-to-day diabetic patients. You have also stressed upon the importance of early use of insulin, how to initiate, how to titrate, and maintain the good glycemia so that we get good effects in the long term and reduce the complications. I think I would open the questions for the audience, if anybody would like to ask any question.
Thank you, madam. Thank you, Chairperson.
Thank you very much.
Thank you. Let me call Dr. Praveen Ramchandra. Let me introduce him. He is adult and pediatric endocrinologist. He has presented various original research publications, close to around 15. Present affiliations, Diaplus Endocrinology Clinic and Arca Hospital, Bangalore. He has been a good friend of mine also. Thank you. So he is going to talk on DPP-4 inhibitors, the vildagliptin and its fourfold advantage. As such, we all know, like throughout this today, we have heard about GLP-1 receptor agonists. So DPP-4 inhibitors little bit look pale in comparison to GLP-1 receptor agonists, but nevertheless, this has been there in use for more than a decade with various advantages like least hypoglycemia, weight neutrality, cardiovascular safety. It has been there in use across the spectrum of diabetes. With all comorbidities, we have used these drugs. So with all these host of advantages, DPP-4 inhibitors are going to be there in use for future also, even though GLP-1 receptor agonists have come. And I think he's going to justify its place with all those advantages. Thank you.
Yeah, thank you, Dr. Raghunandan. So my topic is dwelling into the recent updates of vildagliptin, why it is important, as Raghunandan told. Now this molecule has become off patent. We have been using this molecule when it was from the innovator for a long time. Recently, maybe 2 years or so, 1 or 2 years, this molecule has become off patent, and the usage of this molecule has gone maybe 100 times or 1,000 times in India, after it becoming off patent. So this is what I'm going to speak, the relevance of DDP4 inhibitors in Indians, how it is different, and vildagliptin as a pioneer gliptin, how we can place it, and update on recent US FDA guidance on CVOT. One of the drawback of this molecule, it is never got US FDA approval because they never went there. CVOT trial was not available. And with the recent update on the US FDA guidance on CVOT equivalence, how this molecule is placed, we can discuss. And update on vildagliptin 100 milligram SR, how the compliance has improved, because innovator molecule never came up with OD dosage, always it used to be BD dosage, and now we have OD dosage with Indian innovations. So how we are going to place and how it is going to improve the patient compliance and conclusions. So as we know here, the DDP4 enzyme activity increases in non-obese Indian type 2 diabetes patients. Also, it is correlated. DDP4 activity goes up when the waist hip ratio goes up, and total intra-abdominal adipose volume goes up, liver span goes up, and so on. So all these metabolic parameters, DDP4 activity goes up. Why DDP4 enzyme activity is so important? As we know that there is something known as incretin effect. Incretin effect is the one in our body, whenever there is ambient glucose, it stimulates the insulin production or release from the pancreas, and when the glucose ambient glucose level is high, this incretin effect suppresses the glucagon effect also. As we know that insulin decreases the glucose level and glucagon increases the glucose level. This incretin system is one particular segment, vertical of the anti-diabetic drugs, which acts both on beta cell as well as alpha cell, both on insulin as well as glucagon. That's very interesting here. And we know that DDP4 enzyme activity goes up in diabetes. That incretin effect, like GLP-1 and GIP, these enzymes degrades these molecules. GLP-1 and GIP are the incretins which helps the glucose to be controlled in our body, but this enzyme activity goes up and inactivates these molecules so that sugar level shoots up. And DDP4 inhibitors are the set of medicine which inhibits the DDP4 enzymes, and so thereby they prolong the GIP effect of GLP-1 or GIP effect will be prolonged, which is beneficial. How it works, and this is the pathophysiology behind that. So how Indians are different? If you see the study published by Avdesh Kumar Singh in a review article in IGM, the two studies he has quoted here, one by Park et al. And Kim et al. If you see here, in the left hand side, the Asians in the dark blue and the light blue, the non-Asians, the HbA1c reduction with incretin response is much significant in Asians compared to the non-Asians. That once again proves that as we Asians, we have predominantly intra-abdominal adiposity, and predominant intra-abdominal adiposity will increase the DDP4 enzyme activity. That's how this particular molecule is much more beneficial in Indian kind of obesity or obese patients. Then there is another study which is published in the JCM actually. So continuous oral DDP4 inhibition is documented to keep up the GLP-1, active GLP-1 much better way compared to the placebo. The orange color line is vildagliptin when it is given continuously to suppress the DDP4 enzyme activity. The active GLP-1 is much elevated compared to the placebo. And similarly, glucose tolerance when given vildagliptin, because of this elevated GLP-1, it corresponds actually. The placebo group have a poor glucose tolerance compared to the vildagliptin group. This is another demonstration how this molecule works and how it is beneficial, especially for Indians. So vildagliptin, as we know, is a durable first-line therapy for early control we can use. and there is no harmful weight gain like insulin therapy. You get or pioglitazone. Some set of patients get weight gain because of the treatment, although HbA1c comes down. There's something known as HbA1c paradox, as we know. Even if the HbA1c comes down, if the but person gains the weight, the benefit of the controlling HbA1c get offset. So weight management also very important in diabetes, not just HbA1c, but in this molecule, HbA1c get controlled, but there is no harmful weight gain which offset the whatever we achieved through HbA1c control. And there is no weight loss as well, because it's a weight neutral medication. And this molecule, as we know, works on the ambient glucose level. So there is no risk of hypoglycemia when we use this molecule, and it is cardiac and renal safety molecule. And with the SR which is come up now, vildagliptin SR, the once a daily preparation has come, and patients' complaints has improved a lot now. So these are certain study I would like to highlight here, which prompts us to use as a vildagliptin as a first line therapy. One is initial trial. This is mainly phase 2 and phase 3 study which is done with vildagliptin to establish its efficacy as well as the safety endpoints. And edge trial is the observational study which compared vildagliptin with all other anti-diabetic drugs, be it insulin or sulfonylureas and all. In that also it has shown significant HbA1c reduction compared to the other options of the diabetic molecules as well. And the verified trial is the another study which tells that, I have a next slide here. This is a verified study. It is a randomized double-blind control study in which it showed that when you start vildagliptin alone and one group, another group, if you start with vildagliptin with metformin, these two groups they compared, what they found was the monotherapy, what we usually practice, first we start to give metformin, if it fails we give another drug. That kind of arm, initial monotherapy arm, had multiple higher amount of treatment failures compared to the other arm in which metformin and vildagliptin was added as a combination. So this verified trial tells us that if you start with the dual combination vildagliptin with metformin, the treatment failure is much lesser. That's what this slide tells. So it advocates combining metformin, initiating the treatment with metformin, not just with metformin only, metformin plus vildagliptin from the initiation only, so that the treatment failure rate is much lesser. And this is the virtue study done by the innovator only, Novartis. In that they used this molecule in Muslim population who fast during Ramadan, and it showed that when compared to sulfonylurea drug, the vildagliptin had much lesser hypoglycemic events compared to the sulfonylurea. And similarly, HbA1c control also, the mean change in HbA1c which has come down also much significant in vildagliptin, and weight gain also was much less with vildagliptin in the Ramadan age group, Ramadan population. So people who are fasting in for particular certain religious practices, vildagliptin once again is the much better option compared to the others. And coming to the CVOT study, as initially I told you, this one particular molecule doesn't have US FDA approval because of CVOT was not done, but it had a European Medical Agency approval. And CVOT study meta-analysis was done to show with around 17,000 patients were gathered in that meta-analysis, where it showed that the 4-point MACE points, like MACE composite endpoint, myocardial infarction or stroke or CV death, when it compared with the comparator, it had all safety endpoints. Although it doesn't have a CVOT trial, this meta-analysis proves that vildagliptin is equally safe, is cardiac safe drug. And this particular slide shows about the various gliptin CVOT trials. The first one being PCOS for sitagliptin, and we have severtimi for saxagliptin, examine trial for allogliptin, and vildagliptin, which what I showed you the meta-analysis now. All these had a better CVOT outcome. Like TCOS, Sita did not increase MACE endpoints, whereas severtimi, which was done for saxagliptin, showed the increased hospitalization for the heart failure. And allogliptin was also found to be safe. And meta-analysis which I showed you, vildagliptin also does not associated with an increased risk of MACE endpoints. So out of all the gliptins, only the saxagliptin had a bad outcome for CVOT, but not others like Sita or allogliptin or vildagliptin. And the renal safety, if it is mild renal impairment patients between GFR between 60 to 89, so no need of changing the dosage of vildagliptin, either 50 milligram OD or BD can be given. Whereas in the moderate to end-stage renal disease, one step down we have to do 50 milligram once a day. That actually in fact reduces the burden of the cost of the to the patient. But anything below like 60 GFR, you have to make 50 milligram OD. That is the only changes you have to make. So this is renal safe. You can even use this molecule in NODAT, the new onset diabetes after transplant also. This vildagliptin 50 milligram can be used. And we have huge number of studies done before 2019. That is the vildagliptin 50 milligram BD combination. Cardio safety studies were done, hepatic safety studies were done, renal safety as well. And from 2021, including the innovator, Novartis has done vildagliptin SR studies also, and we have multiple bioavailability and bioequivalence studies published on vildagliptin SR 100 mg combination from 2021 onwards, and we have time in range study also, and we have comparative study versus 50 mg BD vildagliptin versus 100 mg SR combination also. So there is a wealth of clinical trial evidence is there for the vildagliptin. So couple of points I will tell about the update on the recent FDA guidance. As we know that after the rosiglitazone problem which has occurred, US FDA had brought in the CVOT trials to be done mandatorily from 2008 onwards. But in 2020, it has proposed a CVOT trial equivalence, like a certain condition has to be met, like for any new molecules in diabetes to be introduced, some 4,000 patients years data should be there, and 600 and patients with 65 years of age and above should be there. That data should be there, and 600 patients with established cardiovascular disease should be there. These are the few criteria has been introduced, which is deemed as CVOT trial equivalence. So following slides I will tell you whether vildagliptin has such evidences which is CVOT trial equivalent criteria as per the ESFDA 2000 guidelines. So these are the studies, like for example 4,000 patients a year exposure. The vildagliptin has almost 9,000 patients patient years exposure is there, and 1,500 patients should be exposed for the new drug for at least 1 year. And we know, as Raghuram was telling, this molecule has been using, and a randomized controlled study which was conducted for 2 years by vildagliptin is also there. So whatever the new US FDA criteria is there for CVOT equivalence, this molecule has got. So the need for new therapy in diabetes management is required, which can improve the patient compliance and better adherence, and it should be economic also at the same time. Okay. So this is the answer. Vildagliptin, as I told you, it has because of the innovation of the sustained release molecule, which is quick achievement of the drug plasma level that is remains constant at a value within the therapeutic range of the drug for a significant period of time. That is what the SR does it. And it assures day-long control, and bioequivalence to 50 mg BD has been proven, and 24 hours control with 90% DDP4 inhibition action is there. Because any DDP4 inhibitors to be effective, it should be at least it should inhibit 70% actually. This molecule has 90%. So, and it comes with once a day. So, once a day becomes economical. This is how the new technology is there. The outside there is a gel layer, which is a hydrophilic gel layer matrix. So, inside it will be the medicine. So, when patient take the tablet, it slowly get released. That's how it has the sustained release effect. Because of this slow release, it avoids peak to trough fluctuation. There won't be much fluctuation in the levels, and not significantly affected by the gastric pH also. And because of this, there is a fewer side effect because of this slow release. And these are the bioavailability studies which we have for vildagliptin 100 mg SR version. This is the reference one, the left hand side column, the 50 mg BD. If you see, this is the percentage of DDP4 enzyme inhibition actually. It is almost equivalent to 50 mg BD. Like in the first Joshi HR et al., we have 91.05% in the 50 mg BD, but in the same vildagliptin 100 SR has 90%. It's almost similar to the 50 mg BD kind of the level what we have achieved in bioavailability studies. And bioefficacy or bioequivalence study, there is a head-to-head trial was done with 50 mg BD dosage versus 100 mg SR OD dosage. And this is after 3 months you can see the HbA1c is equivalent to the 50 mg BD, 6.64 versus 6.5. Similarly, fasting and PP also similarly well controlled to when compared to the 50 mg BD. And this is a time in range study in vildagliptin 100 mg SR OD, wherein changes in primary endpoint like change in time in range of the time in range, as we know that how much percentage of the patient's glucose level maintained within expected range. That is known as time in range. So, we have the proportion of patients achieving in TR was been studied, and difference of HbA1c as calculated by CGMS was done. When you give a patient with treat with this group of patients with vildagliptin 100 mg OD, if you see in the first column this side, the bar diagram, over a period of time, people who are spent time in range have gone up actually from baseline to week 1 and week 2. Similarly, the proportion of patients in time in range after 2 weeks is much significantly higher with vildagliptin SR 100 patients. As much as 70% of the people were in time in range with this molecule. And HbA1c as calculated by CGMS, if you see the baseline and week 1 and week 2, there is a significant drop. So, this slide shows the difference between IR 100 mg versus SR. As you can see in the graph, IR peaks immediately and falls, whereas the SR has a delayed peak, and the range of this thing maintains for a longer time. To summarize, what makes the vildagliptin strand apart? As I showed you, there is a plethora of clinical evidences there to prove its efficacy and safety, and we've been using for last 10 years or so, and assurance of earlier and better glycemic control as I showed you, and benefits of durability I have showed you with low risk of hypoglycemia and no weight gain, that's very important, and offers more opportunity. This can be used in initiation treatment also in 10-year-old diabetics also, and the old age as well as the established heart patient also can be used. Even new onset diabetes after transplant also this molecule can be used, and it improves patient adherence with the introduction of the SR combination, the once a day, the patient compliance improves. With this, I thank you all for your patient hearing. Thank you.
Thank you, Dr. Praveen. That is a nice elucidation of vildapride molecule and its usage in diabetes. You have placed appropriately the molecule, where we have to use, how to use, when to use, and its advantages such as low hypoglycemia or weight neutral, And the advantage of safety you have shown us in various situations, take renal or cardiovascular benefits, and the FDA, the clearance of this molecule with the new evidences. And also you stressed on sustained release and immediate release, where you can improve the compliance of this drug as a OD dosage. Now with all those benefits you have showed and when to use this, definitely it is there for last 10 years. It will stand with the other molecules in diabetes management. With that note, if there are any questions from the audience, questions are open to Dr. Praveen.
Yeah, that can be done, sir. Because overall BD, when you compare the pricing of BD dosage and one single tablet of the 100 OD, it becomes economical actually. That's one point. And second thing is when we have evidence that it's bioequivalent, and inhibition level is as good as BD, this molecule can be shifted 50 BD to 100 OD. That can be done.
But there is no advantage over controlling HbA1c, all those things.
No, they are equipotent. The bioequivalent is not superior, but the only thing is compliance can be improved. The pill burden can be reduced, and price also can be decreased.
Hi, Dr. Rohit, good talk. Quick question. See, you were talking about the NODAT, use of vildagliptin NODAT, new onset of diabetes after transplant. My question is, vildagliptin in hepatic impairment itself, we don't use this.
What hepatic impairment?
Impairment, yeah. So liver impairment, we generally don't use vildagliptin.
Renal transplant, I'm talking about NODAT.
No, I got you.
Need renal transplant.
No, what I'm telling is, for liver impairment, we generally don't use vildagliptin.
Yeah.
But in NODAT, you are able to use this. We understand that
the liver should be fine. Yeah.
Absolutely, liver
should be fine. Yeah.
So, what is the marker? So, you are monitoring. How long can we continue it for a longer time? Because where does this evidence come from?
What is the leaflet says is, if the SGOT, SGPT is more than 3 times the normal, then that is when we should avoid this molecule. But new evidence has come that it is very beneficial in NASH, like the non-alcoholic related steatohepatitis. Vildagliptin actually in turn decreases SGOT, SGPT. So that evidence also we have, and this in these SR studies they have done with 400 milligram SR bolus they have done with the one set of patients, and they have observed SGOT, SGPT elevation is there or not. It is not found. So they have now there with the new evidence telling even when 400 milligram SR dosage in the trial they have done, they have not shown any hepatic impairment in form of elevation of SGPT. 100 milligrams should be safe enough.
The reason I asked this question is working in a transplant unit. Subtle elevation in the liver numbers, they are very, very worried, and they are using the immunosuppressants left and right. So in this situation, if I am nervous to use
anything
this because
liver impairment of significant impairment, we have other molecules. We can always use other. No need to.
No, but what is the message about for NODAT? So this is. We need to be a little bit cautious here. I think in the paper substantial.
They have done a study actually in NODAT patients. They have there's a study only I'm quoting actually in NODAT. There is a good significant number of subjects were given NODAT vildagliptin. It has worked because liver is fine only there.
Fair enough.
That's the reason. And 400 milligram, as I told you, did not cause any SGOT, SGPT elevation. Probably what I want to tell you is, if the patient has end-stage liver disease or SGOT, SGPT is 3 times the upper limit, then don't use this molecule.
Fair enough. Because sitagliptin I have used, no problem at all.
Lina also you can use.
Little bit worried. That was my question.
That's the only SGOT, SGPT. More than 3 times we will not use. Anything less than we can use this molecule. No problem.
So next we are going to have a panel discussion on imiglumin. For the panel, I welcome Dr. Srinath sir. He is a senior endocrinologist working at BGS Global Hospital. He is trained from UK. And Dr. Lakshmi Nagendra, she is endocrinologist from Mysore. She is working as assistant professor at GSS Hospital, Mysore. Go to the slide. Slide. So what we are going to do in next 10 to 15 minutes is, I will just present what is imiglimines for just 2 to 3 minutes, and we will have a discussion. What we have finalized is, we are going to have a more practical or clinically oriented questions, and we will take questions from the audience also. So we know that type 2 diabetes is a chronic metabolic disorder with metabolic dysfunction. So various factors, it's a multifactorial disease, genetic, environmental, beta cell, it leads to beta cell dysfunction, insulin resistance, and the mitochondrial dysfunction plays a major role. So we all know that mitochondria is very, very important for production of energy. So the energy is produced both from the glucose and fatty acid, depends on whether it's a fast state or fed state. So glucose is converted to pyruvate, then acetyl-CoA. Fatty acid is also acylated to acetyl-CoA, which leads to formation of ATP. But in obesity or diabetes, this is altered. This mitochondrial function is altered. So it leads to increased hepatic glucogenesis and insulin resistance and decreased insulin secretion from the pancreas. So glimine is the first, imiglimine is the first in-class molecule of glimine recognized by WHO and researched in 2007 with international approval by China and Japan, and it's there in use since 2021. So it targets 3 things mainly: impaired glucose uptake by the muscle tissue, so insulin resistance, decreases the hepatic gluconeogenesis, and increases beta cell apoptosis, decreases the beta cell apoptosis. So basically how it acts as a mitochondrial re-energizer. So it decreases the C1, so in turn it decreases the reactive oxygen species protection, and it increases the C3, via which it increases the insulin sensitivity and insulin secretion. And also it acts on the NAD plus equilibrium, via which also it increases insulin secretion. Data are coming for this prevention of sudden cardiac death also with this imiglimine. So when you compare with the metformin, its mechanism of action is almost similar. It acts on the mitochondrial electron transport chain. Metformin acts on the only complex 1, whereas imiglimine acts on C complex 1 and 3. It inhibits C1 and increases the C3. And compared to metformin, it acts on the other pathways also, NAD plus salvage pathway, potassium ATP closure, and increases the insulin secretion also. Otherwise, regard to insulin resistance and decreasing hepatic glucose output, it's almost similar to the metformin. So with this brief introduction, we'll go to the questions. So to Dr. Srinath sir, any your opinion about this time study, because time study is the phase 3 data with the imiglimine or any other meta-analysis. So what do you think about this molecule imiglimine?
See, first of all, can I ask the audience, how many of you are aware of this molecule and how many of you are actually practically using it in your clinical practice? Please raise your hands. So the numbers are very less, okay? So what this molecule, Dr. Shyamsundar has made our lives much easier. So he has clearly told 2 things. The most important, it works on the beta cell. It improves the beta cell secretions, thereby the insulin action is protected. And the second thing is it works on insulin resistance, exactly how metformin pioglitazone combination works. So the question about efficacy, and you're talking about times. What is times? Times is the trials they use the imiglimine on, especially the safety and efficacy on imiglimine. So this is a molecule initially used in Japan, very well trialed, and DGC has given a clearance for us. And probably it's only 8 months molecule if you are in the market. And we've been using it not to a great extent to other molecules. It's good that we have a molecule. The Times 1 study, which was done basically on the placebo with imiglimine studies, clearly they showed that the efficacy wise, the A1C reduction was good. So I think it was probably 0.6 to minus 1, it comes to around 0.83 or so. So that means that the HbA1c reduction was probably around 0.8. And if you are talking about times 2, where they use it with the combination therapy, that means people who are already on some molecule, they added imiglimine and saw what was the problem. What did they look at? They looked at some cardiovascular, and they also looked at the other important thing was there any efficacy improved or was there any safety concerns? So as with any other molecule, it had some amount of GI sort of intolerance, mild retinal issues, and renal impairment was noted, not to a severe extent, but like any metformin, we had a GI intolerance there. But what was noted was, interesting to the previous talk, the combination of vildagliptin, it had a very good sort of DPP-4 inhibitor, sorry. It had a good A1C efficacy, was good, best. But same thing, it didn't show any much action on the GLP-1 analogs. We do not know why, how it did, I do not know. And the most important is ×3, which is on the insulin. So what they looked at is imiglamin with the placebo, imiglamin with insulin, placebo with insulin. They found out that the A1C reduction was better with imiglamin and insulin. And the trial continued after 16 weeks where the placebo and the insulin, they added the imiglamin there and they found that the A1C improved. So with insulin also, it showed some good efficacy. Now the most important is the hypoglycemic effect, which we noted was slightly more when they used it with the sulfonylurea, especially the ripaglinide and the bigonides. And when you comparing, these were all the Japanese trials. Now what do we have for India? So for India, I think they looked at the monotherapy and they found again the A1C, the fasting blood glucose, the postprandial, and also the side effects were slightly better compared to the placebo. This is where your question to the Times study come through. And I think we are still new to this, but probably more and more use we'll see better.
Yeah, any insulin reduction data in those time 3 studies, sir?
No, insulin doses actually, to be honest, I don't know about that. So no, they didn't they reduced the dose of the insulin.
Okay. To Dr. Lakshmi, safety data from this or any other available literature so far?
So actually ×2 and ×3 were phase 3 trials, and if you look at the baseline characteristics of these studies, the EGFR was 74. So with the patients almost in the CKD stage 3, there was a lot of representation of patients in CKD stage 3, and the mean EGFR was itself low if you compare to other studies. So the HbA1c reduction in them was -0.8 in ×1 and -0.4 and 0.6 in ×2 and 3. So this is actually quite good because we are looking at patients who have CKD and we don't have, a wide variety of options with OADs. So even in these patients, the incidence of lactic acidosis was very low. There were no reported incidents of lactic acidosis, and this was in CKD patients. So when we talk of metformin, I think one good advantage of this drug is patients who have CKD and have high degrees of insulin resistance, especially patients who have acute kidney injury and are on steroids, have insulin resistance, obese. I'm using it in those patients because there is no worry of lactic acidosis. And as Sir said, the incidence of hypoglycemia with sulfonylureas was more, which is expected because the sulfonylureas itself have a high propensity to cause it.
So what about in those patients where you are using in the selected patients like patients on steroid, any GI side effects compared to the people who doesn't have this kind of?
No, one more thing is patients who are intolerant to metformin, like we know about 30% of patients are intolerant to metformin. Most of these patients are insulin resistant also. So I'm switching all my patients who are metformin intolerant to imiglamin, and they have a good response with that.
So to Dr. Srinath sir, so how do you rate this molecule? Now at present we have a lot of molecules for management of diabetes. So how do you rate this molecule compared to the available therapy, and what will be the kind of patient you will start this molecule?
See, what is the main concern in management of diabetes? It's still today, it is the compliance of the patients. So the pill burden is becoming more in our population groups. So the more, and we are not looking at their list or we are not checking whether the patients are taking. So it has come to a consensus that the less number of medications, the compliance gets better. This is where exactly imiglamin comes through as well. Because if you see the molecule, it has got both insulin resistance work and also beta cell. So if you look at starting A1C of someone with 7.2 or 7.3 or 4, whatever 5. So where the combination is probably indicated. When probably if you initiate it, there is a good way of initiation. You can use this molecule as an initiation. And as Madam said, if you have an issue with other molecules where there are side effects is there, then you can interchange. You can stop that and see whether, like metformin intolerance, whether these molecules did well. So that is also there. And also if you are talking about the intensification, I told you earlier, it can be added to any molecule. The only drawback is versus the sulfonylurea and the repaglinide. Please avoid this to use it. So of course we'll come to the renal impairment later on. But if you ask me this molecule, suppose if you are using a combination of SGLT2 inhibitors and a DPP4 inhibitors as one pill, why not use this as one pill? Because you showed in your slides that this molecule will actually address 3 pathophysiology. I mean, 3 pathological sites it works. See, physiological sites it works. So it works at the skeletal muscle, it works at your liver and also the pancreatic level. So this with using another sort of what I mentioned earlier, then 5 drugs you are trying to do with the 2 pills, then the burden of the insulin definitely will come down when we are struggling with people going on insulin. I think the earlier talks we were alluding at how the insulin is becoming a poor issue with the doctors community to start with. But it's mostly the communication becomes extremely difficult in insulin start. But a pill means the moment you write a pill, our patients are very happy. But the more and more, they're dropping it out. And the elderly populations probably, they're missing out because of the more numbers. That's where probably this molecule also will play a part.
Dr. Chin, whether you prefer this molecule after 3 OADs or 4 AADs, the patient doesn't want to be on insulin, you will try this molecule irrespective of the HbA1c what the patient does, or you will go for insulin?
Actually, in very few patients who have refused insulin, no matter what they don't want to take insulin, even if their sugars are uncontrolled and you've explained the consequences of uncontrolled diabetes, they still don't want, and most of these patients are already on glimepiride, metformin, DPP4 inhibitor and SGLT2 inhibitor. So I have put them on imiglamin as the 5th drug as a last resort, and surprisingly they have done well. Most of these patients are obese patients who have high degrees of insulin resistance. It's not that I wanted to put them, but because of lack of choice, because they didn't want, there are very few patients like that, maybe 4 or 5, and they have done well actually.
Practically, whether you will start with 500 milligram twice a day or 1000 milligram twice a day, and what is your experience, how they are doing with 500 milligram twice a day versus 1000 milligram twice a day?
So I have started only on 1 gram BD, 1000 milligram BD. Earlier only the 500 milligram was available, and because the dose suggested was 1 gram, that was amounting to 4 pills per day, but nobody was willing to take. So I don't have experiences with 500 BD actually.
So yeah, 500 milligrams twice a day is a good way to start. Once a day or twice a day, and then the best efficacy is seen at 1000 milligrams twice a day. If you're using 500 milligrams twice a day and if you're not seeing an A1C reduction, you may have to go up. So that is a message. Don't stop at 500, because the best trials have seen at 1000 milligrams.
Practically, whether any adverse effect like skin reactions, gastric intolerance seen in your patients?
Yes, so we are looking at the side effects is mainly minimal. The GI side effects is the one that we are little bit seen, literature quoted, but I have not seen any GI intolerance. But they also told some retinal sort of changes also are noted. So retinopathy, whether it's progression from diabetes or from this, we do not know. It's very difficult to say. And that subtle sort of side effects like skin rashes or allergic, 0.1, 0.2, 0.3 is the percentage, but not much. Compared to DPP4 inhibitors, this is definitely less from allergy or atopy point of view.
Dr. Lakshmi?
I have not come across any skin reactions or hypersensitivity reactions, but what I've noticed is patients still have, some patients have some amount of GI. It's much better compared to metformin, but patients who have had metformin intolerance, few patients still complain of GI, but it's very less.
Okay. Any contraindications? You look for any contraindication before starting this molecule?
See, the molecule has clearly told that if you have an EGFR less than 45, do not start, because it is a renal excretion. So if you have a mild to moderate renal impairment, you have by and large no problem. But as soon as your EGFR drops less than 45, you need to monitor less than 30, you stop. And if you're comparing that to the liver impairment, in mild to moderate liver impairment, there's no problem. But in severe, where the child pug score of more than 10, no trials are used. Of course, lactation, pregnancy, these are all contraindications. But even in elderly, as clearly told, if you're monitoring it, if you're able to give, molecule is very too early for us to comment, to be honest. So time will probably tell us. That's what I feel.
Your take on CKD, till what GFR you will use?
Yeah, still CKD states the EGFR 45, it's licensed for use. Up to 30 you can monitor and stop less than 30. But I saw a recent trial where they have used in CKD stage 5 in patients on dialysis. This was a very recently published study in only 15 patients of dialysis, and surprisingly, none of them had lactic acidosis. But it is not licensed for use as of now.
That's 500 milligram once a day they used, I think.
Yes, 100 milligram once a day.
Sure. So I think any questions from the audience? Pre-diabetes.
So pre-diabetes, again, what is the mechanism there? The insulin resistance is the most important there. So you can use this. And trials have shown with monotherapy to placebo, especially in the Indian trial, the A1C reduction there was, if you calculate it, is 0.68 plus given price, it comes to around minus 0.8 reduction. So you can use, madam, there's no problem at all.
Better than a metformin-like product. So how do you rate this in terms of cardiovascular safety? Metformin has established cardiovascular safety we have been using for such a long time with available evidences with now. Do we have any cardiovascular studies promoting or its benefits?
Preclinical models of it has been studied in mice models only, the cardiovascular and renal outcomes. As of now, we don't have studies on human subjects for cardiovascular end.
So when we don't have a cardiovascular...
No. To add to madam, in times 2 study, clearly they looked at the cardiovascular data also. 2 things they looked. One was the ECG, whether because the DPP-4 inhibitors, they looked at whether there was any variation in the ECG, changes, conduction variability, nothing was there. Echo-wise, they also looked at the left ventricle end diastolic pressures also. The safety data was achieved. So what does that mean is, when you're talking about your vildagliptin trial earlier, where they used the cardiovascular, the safety is pretty matched. So they have not, metformin, where do you go in terms of cardiovascular safety? It is a time-tested molecule, no problems. Even in heart failures, nowadays cardiologists are using it. But as I said, this is a very early, molecule is too early for us. But the data has shown that it is no contraindication for cardiovascular sort of issues.
But do we have any restriction to use in cardiovascular patients who are already having an established atherosclerotic vascular?
No, we don't have.
We don't have it.
We don't have.
If there are no more questions, I thank both the panelists for the wonderful session. Thank you very much.
Thank you.
Now moving on to next session on modern sulfonylureas and dapagliflozin, I would like to invite Dr. Prashant C.D. sir onto the stage to chair this session. He is a renowned nephrologist from Bangalore. I would also like to invite Dr. Shalini Joshi madam onto the stage. She is a senior internal medicine consultant and diabetologist practicing in Fortis, Bannerghatta. She is the head of preventive health department, Fortis, and she is a senior DNB faculty in internal medicine department. And she is an immigration panel physician for Canada, Australia, New Zealand, and United Kingdoms. She is expert in obesity management and tobacco cessation. She has been speaker and faculty for various national and international conferences. She is also corporate speaker for various health awareness campaigns, and she is a member of various associations, and she had a very numerous publications on her name. And next to chair the session, I would like to invite Dr. Vasisht Das. He's a consultant interventional cardiologist practicing at Chinmaya Hrudayalaya Mission Hospital Complex, Indira Nagar. He has multiple papers presented at annual meetings of Cardiology Society of India. I would like to hand over the mic to the chairpersons to continue the session.
So as we all know, sulfonylureas continue to be the workhorse of glycemic control in most of our patients. They are probably the second drug that is added after metformin. And they have a long track record, and renal wise also, as a nephrologist, we are comfortable with them at least up to CKD4. So I would like to invite Dr. Bhavna Sosle to tell us more about this group of drugs. She is a consultant at Diacon Hospital in Bangalore.
Good evening to everyone. Thank you to all the chairpersons, and thank you to Dr. Anantharaman and the organizing committee for inviting me here today. So what I'm going to tell you all over the next 15 minutes or so is not really going to be anything new, but it sort of helps us relook at what we need to do in practice, that is good glycemic control. And we need to again go back and remember that we still need a beta cell centric approach, not to take away any emphasis from the cardiac renal safety set of molecules that we have, but at the end of the day, all our patients need good glycemic control. And at some point of time, most of our patients, you could go back and look at your files and records, are going to be on sulfonylureas. Why are sulfonylureas still so widely used? Because they're an old class of drugs which have been available for generations, so the amount of data we have, especially on the modern SUs, is a lot of data. We know how they work, we know how effective they are, we know the safety issues, we know that it's quite easy to use because one, it's a pill, it can be given with all other therapies that the patient is already on. And we don't see any red flags over the several decades of use. So this has helped establish the whole class of modern SUs as a safe molecule for us to use. And over the years, there have been several studies, and I'm not going to look into each study and each year, but we know the modern SUs that are there today for us, which is glimepiride and gliclazide, are widely used in practice, and they are effective and safe. Now, as I mentioned earlier, we've had a lot of experience with SUs over several decades. We can use it with all other OADs that are available. We can use it with injectable molecules. So we as doctors also, and we just heard in the previous talk with emiglenin, sometimes when we use newer molecules or early molecules, there are still questions unanswered. But SUs are a class of agents where nothing per se has been unanswered at this point of time, and hopefully we'll keep learning more and more with time to come. Now, there's been a ton of evidence from India as well, a lot of studies, a lot of publications, and again, we don't really need to go into each of the studies. But what has most of these studies told us that when we use glimepiride and metformin, we know how much HbA1c reduction we expect to get, and as the dose goes up, we slightly see a greater A1c reduction. The only thing I would maybe caution about is that we don't actually go up to the full maximum dose when we use glimepiride, though the textbook would say 8 milligrams, we hardly ever use that. We stop at 4, or maybe in rare cases we go up to 6, because you put patients on a higher dose and it's not really going to do any benefit. But we could use it separately as FDCs, and we get a wide range of combinations of doses available for our patients, which makes compliance much easier. And when we reduce the pill burden, it makes diabetes control much more better because just the patients are going to be taking lesser number of pills. So we've got a ton of evidence throughout the world. Now, this particular slide tells us data from the JADE study, which is the Joint Asia Diabetic Foundation group, which was based in Hong Kong, did the study, and it was an observational study that spanned some time, and Diacon was also one of the centers in the study. So they were looking at diabetes control, what groups of agents were patients were on, and they looked at patients who were younger, patients who were older. They also had multiple components to it to see if risk scores and other things could be used to educate patients to see if patients actually get to better values. Now, one of the things highlighted in this study was that across Asia, still a large number of patients are on sulfonylureas, and there was good glycemic control and safety profiles observed in different countries. And in this particular study, the SUs used were glimepiride and gliclazide. Of course, this was not an RCT, this was just the two molecules that were being used in most of the patients. Only, I think, under 10% were on glibenclamide, the rest were all on glimepiride and gliclazide. So at this point of time, when we think of cardiovascular safety and sulfonylureas, we know that there are issues with the older molecules like glibenclamide, so we hardly ever use that today. And with glimepiride and extended release gliclazide, we've got a lot of studies, we've got a lot of data. We've got data from Advance with gliclazide, we've got data from Carolina for glimepiride, which has told us that these molecules over the years, they're also cardiovascular safe. There's no increased risk of cardiovascular event. And even before these studies came, and when we didn't have this data, there were still time-tested molecules that had been used for generations, but now the data is also there, which confirms that what we have believed over time, that SUs are safe, are actually true. Now, this was a recent study, which is why I'm going to actually highlight it here, because all of you have already heard or you've read about Carolina, so I don't need to go back into that. Now, this was a study which looked at glimepiride use in patients and its effect on cardiovascular mortality in patients with type 2 diabetes and heart failure. So this was a prospective study. So what they looked at, they compared patients who were on glimepiride and non-glimepiride therapies, and their endpoints were all-cause mortality, CV mortality, emergency visits for heart failure hospitalizations. And what was seen was that there were better survival and fewer hospitalizations with the use of glimepiride versus the other medications in this particular study. But I don't know whether these patients were actually on SGLT2 inhibitors or not, because we do know with all the data available that we would expect to see better outcomes certainly with an SGLT2 inhibitor. So I'm not trying to tell you that you use glimepiride. I'm being very clear to improve heart failure outcomes. What I'm trying to tell you is that it is safe to use in patients with cardiovascular disease, and you need not really worry about continuing a sulfonylurea or initiating a sulfonylurea. Always assess the risk, put them on a SGLT2 or plus or minus GLP-1 based on affordability, and then the SU comes there. But we need not question the cardiovascular safety and ask, is this going to worsen outcomes? And we can continue to use sulfonylureas even in patients with cardiovascular disease. Now, this is some basic science data which is available. And again, I'm not a basic scientist, so that's my disclaimer here. If you ask me how these signaling pathways work, I would tell you I can give you a link and give you the article, but I truly do not fully understand them myself. But there are a lot of lipid signaling pathways that go on in the body, and there is some basic science data, lab data, that has shown that glimepiride has an effect on some of these pathways, and perhaps this is one of the reasons why it is actually CVE safe. That is just something to remember, but irrespective of these basic lab data and animal data, we do know that sulfonylureas can be used safely in patients with cardiovascular disease. Now, this was another study that was trying to look at CV safety of sulfonylureas in comparison with DPP-4 inhibitors and TZDs. This was again a retrospective study which was done based on registry data available, and they looked at the data from point A to point B, and then they actually analyzed it. And what was actually found that the new modern SUs, so second generation SUs, did not increase the cardiovascular risk or overall mortality. Now, we've known for some time that there's also some data available of sulfonylureas having some antioxidative effects, anti-inflammatory effects, changing level of some inflammatory markers, and so on. And there is now, I said, some data also starting to emerge on how it acts on some lipid signaling pathways. So we'll see where this goes with time. But what do we know today about using a molecule like glimepiride or gliclazide, because the topic is OADs and sulfonylureas. So what we know is that we can use it in patients with newly diagnosed diabetes, we can use it in patients with long-standing diabetes, we can use it in comorbid conditions as well. Of course, when the GFR does start to fall, coming 40, 45, we want to reduce the dose, take them off, consider other therapies. We can use it in patients with cardiovascular disease. We can, though of course, there may be very minimal weight gain associated with sulfonylureas, we can use it still in patients with overweight and obesity, because often the drugs like GLP-1 RAs, which do help in a lot of weight loss, may not be affordable for a great section of our society today. Can be used in the elderly, just need to reduce the dose so that we want to minimize hypoglycemia. And of course, sulfonylureas are the mainstay therapy in monogenic diabetes. Now, this was a study which looked at combinations of sulfonylureas with other OHAs just to see what doctors are doing. It's used with TZDs, it's used with AGIs, used with SGLT2 and DPP4. So we do use sulfonylureas with all other molecules in our practice. So the other question that we commonly get asked, sometimes in Q&A sessions, and sometimes we see patients coming in, sugars are out of control, they've had diabetes for a long time, and they say my A1Cs are 10 or 9 or 11, I just don't know what to do, I've been taking my insulin. I say, okay, how long? And a few months ago or a few weeks ago. What was your control before this? What were you taking? I was taking glimepiride metformin. So where is that now in your prescription? I've stopped all the tablets because I started insulin. So this is the next thing that I would highlight, that we keep in mind that we need to remember that continuing the sulfonylurea does help our patients get to better control. There is no reason to actually take off a sulfonylurea when we initiate insulin for our patient. If we are worried about hypo, we could slightly reduce the dose. And as long as I said, we don't go up to the full maximum dose, but stay halfway there, our patients could do quite well, because it does reduce the number of injections a patient needs to take when they need to take insulin. The compliance is much better because they could perhaps be on 1 injection instead of 2, and it just makes it much easier for our patients to get to better targets better. So there is a concept which is called basal assisted oral therapy. So you continue the oral medications. We don't actually take off the sulfonylurea when we initiate insulin, but not just for basal insulin, irrespective of what insulin regimen your patient is on, because at some point you will up titrate to premixed or basal bolus at some point of time. We could continue using the sulfonylurea. We have seen patients coming with 10 years, 15 years of diabetes, 3 injections a day, clearly type 2, and they're not under control, and you put them on the SU, you don't have to put them on a 4th injection of insulin. They do marginally better. So irrespective of the duration of diabetes, though we think how much of that beta cell is really working after all this time, in practice you see that SUs do work even after quite some time. Of course, I don't know how many of you see patients with MODY. We really don't see many of them, but sulfonylureas are a mainstay that's with MODY. Now, this is just one slide looking at the effect on kidney outcomes from the GREAT study. Now, the GREAT study, what they did was they wanted to see different groups of molecules and what happened to the patient. So one arm got sulfonylurea glimepiride, one arm got liraglutide, GLP-1, another arm got sitagliptin, and the other arm got glargine. This was all with metformin. And what was seen was with the kidney outcomes, we looked at the CV data earlier, with the kidney outcomes there was really no difference at the end of the study, irrespective of which arm the patient and which group of medications the patient was on. So it is safe to use sulfonylureas. We are not worried about patients increasing their cardiovascular risk or increasing the risk of kidney events. So when you see patients, when the sugars are really high, they're catabolic, yes, think of using insulin, think of settling down the blood sugars before you actually start them on OAD. But once that happens, sulfonylureas do become an important part of therapy. It may not always be today the first line with metformin because we have better class of molecules like SGLT2 inhibitors. But subsequently, at some point of time, all our patients are, most at least, are going to go on a sulfonylurea when they're not on control with the other agents. So what do the different guidelines tell us? That we can actually use sulfonylureas. You could still use glimepiride as a first-line molecule with metformin if cost really is an issue. But today we've got SGLT2 inhibitors, DPP4s at affordable rates also for our patients. So we often put sulfonylurea. It's moved back from the first set of drugs to maybe second or third, but it's still an important part of our management. So let's not forget that they are cost-effective molecules. They're not going away anywhere. They've been available for decades. They're affordable, they're effective, acceptable. The only adverse event that we really see is hypoglycemia, but that's going to be there once you get diabetes at some point because the patient is going to go on insulin. So we have to accept, educate about hypo, ask them to monitor, readjust the dose, and teach them what they do on days when they're sick so you actually can avoid hypoglycemia. Yes, so thank you very much, and that's the end of the talk.
Thank you, Dr. Bhavna. It's always a treat to listen to you, and earlier last few years it was on the webinar, but it's good to see you in person. I think it's very important to discuss these sulfonylurea in our diabetic talks, as you rightly pointed out. And thank you for showing that slide and stressing out, at least for 2-3 minutes, that not to stop the OHAs when they start. This is a very common scenario. We see that people think that those medications don't work and they're just switched to insulin and struggling to hit the target. So very well pointed that out. And I know we've, as you rightly said, it's a low middle income country and we cannot afford the semaglutides yet. And definitely it is our tier 1, tier 2, long way from 1942 when it was discovered. And I think the newer generations are here to stay. With that, do we have any questions from the audience?
So both gliclazide and glimepiride are CV safe. You can use either of them in your practice, and extended release gliclazide and glimepiride, I would add, that are both CV safe and effective. So you could use either of them. It's really the preference of the treating doctor, and it's the preference of what is available close by for the patients. If someone's from Bangalore, it doesn't matter. They will order from an online pharmacy. Now we'll see what happens to online pharmacies. But if someone's, let's say, staying far away, if glimepiride is more easily accessible to them than extended release gliclazide, they would take that. In terms of efficacy, I would say in most of our patients, when we've used it, we don't have head-to-head data, but we see good reductions in HbA1c, so we see improvement. There is only one study, I forgot the name, I think it's GUIDE, but I'll check the study, GUIDE, which compared head-to-head extended release gliclazide and glimepiride. But again, I wouldn't infer too much from that study because it had 40 patients. Okay, so the sample size is really small. And in that study, the A1C reduction was better with extended release gliclazide. So when we use gliclazide, it's the extended release which is effective and CV safe. The immediate release formulations, I wouldn't necessarily say the same about that. But again, that particular guide study, very small number, so don't infer too much from it. In clinical practice, you can see good improvement irrespective of which of the two you choose from.
Secondary OHA failures.
Yes, so at some point our patients are going to need additional medication. I don't think the beta cells truly just die or stop. They do exist, and there is some work that's going on inside some amount of secretion, but it's not enough. So we do need to add on molecules. But when we take off a pre-existing molecule, they're not going to do well. So there's going to be some amount of still intrinsic secretion when we even continue SUs for many years as well.
So if you feel that you can continue glimepiride at the maximum dose despite having its benefits, adding on another drug and still continue to use glimepiride, is that what you mean?
Absolutely, because I've seen patients drop off the sulfonylurea thinking now I'm taking insulin anyway, so why should I take this? They don't come under control. They're again back to higher sugars and they come back to us. Or they require much higher dose of insulin because the intrinsic secretion is gone away. So yes, the dose, when you reach that 4 to 6 milligrams and is not doing well, we add another drug, or we add, oral or injectable. But if you take that off, they're going to need much higher doses of the injectable.
Then does the meaning of secondary OHA failure doesn't exist?
I don't think it exists, because even in patients with type 1, there are studies which show that the beta cell does work, but not as effectively, and there is some amount of secretion even in them. So I don't think the beta cells actually truly die off. All those slides when we see on insulin initiation that 80% or 50% of your beta cells are lost on day 1. Now there are other studies which have gone back to relook at the data, and what they've realized is that the stains that were used to recognize the beta cells were only telling them that the beta cell secretion had come down. It was not that the beta cell was dead. The beta cell was still there, it was alive, it was breathing, it was multiplying, it was all of that, but it just wasn't producing insulin, so it still existed. So there might be some amount of work that it could still do even at a period, many years later also. So I think we'll maybe know more in a couple of years as well, but we do see sulfonylureas working even at 15, 20 years of diabetes.
So thank you, Dr. Bhavna, for reminding us that sometimes old is gold, right? So what she just demonstrated to us was the meaning of a green swan, which is an innovative solution to multiple challenging problems. So that was a very nice presentation. Thank you, Dr. Bhavna. And I'd now like to call on Dr. Belinda George to educate us about dapagliflozin in CKD. So Dr. Belinda George is the Associate Professor in the Department of Endocrinology, St. John's. And you can see that she's got a very, very creditable role of honor. Dr. Belinda will now proceed with her presentation.
Thank you. At the outset, let me thank Anant Raman and the rest of the Magna Code team for inviting me here and giving me this opportunity. Today, the session will be on dapagliflozin, a definitive solution to reduce mortality in CKD patients. So when we talk about CKD, CKD is often called the silent killer because many patients, 9 out of 10 in fact, patients who have CKD may not be aware of their diagnosis and the fact that the process of chronic kidney disease has already begun. And if you look at the leading causes of CKD, it's diabetes and hypertension. And as endocrinologists and diabetologists, predominantly, we will be handling them before we hand over them to the nephrologist. So if there is something that we can do
to reduce the rate of progression, it is definitely necessary that we should take the right interventions and the right actions. And when we talk about diabetic kidney disease, as we all know, it's one of the microvascular complications, well-established microvascular complications of hyperglycemia. And the CKD that is associated with type 2 diabetes may have other factors also like dyslipidemia, hypertension, etc., contributing to the progression in kidney disease. Of course, today we are going to talk about mortality. And when we look at mortality in CKD, we used to think that it's predominantly driven by cardiovascular causes. But now we know that there are non-cardiovascular causes also, because once you develop CKD, your likelihood of mortality increases even with other causes like infections and malignancy. So let us see how we assess kidney functions. So if you look at what are the main three functions of the kidney? One, of course, is to ensure that there is excretion of waste products. Second, of course, is to have regulation of water and sodium homeostasis. And lastly, it also has some hormonal effects. It produces certain hormones. And the two main tests that we use to assess kidney function is the EGFR and the albuminuria. So how do we assess glomerular filtration rate? Basically, this is nothing but the rate at which substances are filtered through the glomerulus. And of course, we have a couple of mathematical equations. The commonly used one today is what is called the CKD EPI. It's available to be downloaded free as an app in any device, both Android and iOS. So you could be having it in your phone in your clinic. And if you open it, it'll look something like this. You just have to enter two values. One is the creatinine value, the other is age of the patient. And then you have to use the gender and the race. So if you have an example here, you can see the creatinine of this lady was 1.4. And she was 59 years of age. You can see that her EGFR comes to 41, which will basically will fall into the 3B stage of CKD. So this is something that you can do in maybe less than 30 seconds in your OPD, but it is essential that all of us start looking at GFR and not stop looking at the creatinine value alone. The next one that we use to assess kidney function is the albuminuria. So this again, the red line shows you how in patients with diabetes, the albumin excretion increases over the years with duration of diabetes. And of course, albuminuria, this is a cutoff. If you're using the ACR, the cutoff is 30. Anything more than 30 is called microalbuminuria, and more than 300 is called severe albuminuria. So this is again the index that you should be using to screen your patients with diabetes. And this is, of course, all of you are very familiar with. This is the KDIGO definition of CKD and the various stages of CKD. And this classification is based on two criteria. One is the EGFR, and the second one is the degree of albuminuria. So how do we screen our patients? We screen all of them using the CKD EPI equation to assess the EGFR, and we also do the albumin-creatinine ratio. This technically should be done once a year at least, and you can start at the time when you diagnose the patient with type 2 diabetes. So now we know how to assess renal function. So what can we do to halt progression of renal dysfunction? So till now, we only had two main things. One is, of course, manage the hyperglycemia, because we know that it's a microvascular complication of hyperglycemia, and hyperglycemia is closely linked to progression of renal disease. Second, of course, is hypertension, and the drugs that we have which are beneficial to the kidney is blockade of the RAS system. So this is what we usually use. You either use an ARB or an ACE inhibitor in patients with diabetes to ensure that there is nephroprotection. So this is all that we had earlier. And this is a picture which shows the reduction in the albuminuria and nephropathy progression in patients with improving HbA1c, going on to say that glycemic management is important in patients with diabetes in order to halt the progression. But the new kid on the block, it has been there for a couple of years now, is the SGLT2 inhibitors. Again, when SGLT2 inhibitors was introduced for the first time, it was introduced as a drug that was meant to manage diabetes. But then with time, its glycemic efficacy actually took a backseat, and now it has more of cardiorenal benefits, which the magnitude is actually much higher than its glycemic efficacy. So we found that it was beneficial for the kidney and the heart, and then we went back and postulated the mechanisms as to how it works and how it protects the kidney and the heart. So we will look at a few mechanisms here. So this is the site of action. Here you have the you have the glomerulus there through which the glucose is filtered, and the first part of the PCT is filled with SGLT2 receptors or SGLT2 transporters, which absorbs 90% of the glucose that is filtered. The remaining 10% is reabsorbed by the SGLT1 in the later half of the PCT. So in a normal individual, all of the glucose is reabsorbed in the PCT, and then in what comes out as urine, there should be no glucose that is present. So the molecular level, what goes on is that the SGLT2 transporter is here. It absorbs one glucose and one sodium from one side, and then it infuses it back into the blood. It uses a GLUT transporter for the glucose, and the sodium potassium ATPase is what actively takes the sodium outside of the cell. And then the SGLT2 continues to gather more and more sodium and glucose from the lumen. So apart from the this is how the glycemic benefit happens, because the sodium and the glucose is reabsorbed from the renal PCT. So apart from that, we know that SGLT2 has some additional renal benefits, so we will just look at briefly how exactly that happens. So what we see here is a normal, what is called the tubular glomerular feedback. So you can see that the afferent arteriole and the efferent arteriole are present in the glomerulus. Normally what happens is all the glucose that is filtered out is reabsorbed, and there is no glucose, and along with glucose, even the sodium delivery to the distal tubule is less. So what happens in patients with diabetes is that the glucose load is so high that to the distal tubule there is more glucose and more sodium. So when more sodium is delivered to the distal tubule, this activates the renin-angiotensin-aldosterone system, and the tubular glomerular feedback, that feedback is disrupted. So as a result, what you will have in the glomerulus is that the artery that is feeding into it will undergo vasodilatation, and the artery that is feeding out of it or leaving the glomerulus will undergo vasoconstriction. So this is meant as a response to, let's say, to maintain the intraglomerular pressure, thinking that the pressures are less. But however, the truth is that the pressures were not really low, so it ends up giving you the opposite effect, which means the intraglomerular pressure increases. And this increased intraglomerular pressure is what drives the glomerular damage, which we see in patients with diabetes. So if we use an SGLT2 inhibitor, in this patient or in this situation, you will see that it sort of restores the tubular glomerular feedback, and it relaxes the vasodilatation that has occurred in the afferent arteriole. So it restores the intraglomerular, the risen intraglomerular pressure is restored to normal, and this is how the SGLT2 inhibitor is postulated to protect the nephron from worsening kidney injury. So coming to today's session or today's topic, which is essentially looking at mortality in CKD patients. So a lot of trials have shown, but mortality data is only a subset of most of those trials. So I'm going to show you a trial, an analysis, basically based on the DAPA-CKD trial. So this is a pre-specified analysis from the DAPA-CKD trial, which has looked specifically at effect of dapagliflozin on mortality. So we'll just briefly look at the baseline characteristics of patients with, who are on DAPA, who were enrolled into this study. The average age was 61. They were about 30% Asian population. Their blood pressure was to the tune of 137/77. The HbA1c was 7. The EGFR on an average was around 40, 43. And the UACR was 949. So of course they had chronic kidney disease. 67% of these patients had type 2 diabetes, which means about 33% of the patients did not have type 2 diabetes, which was what was special about DAPA-CKD compared to previous DAPA trials. And if you look at the other cardiovascular factors, you can see that around 37% of them had underlying cardiovascular disease, as opposed to what we had done earlier in CVOT, where a large population had high-risk patients with ASCVD. And if you look at the other drugs that were used, here of course around 64% were on statins and a good 66% were on ARB. So these are the drugs that we commonly use. Probably all the patients who had diabetes were on statins and ARBs, and maybe other CKD patients were probably not entirely covered with this. So coming to the results with regards to mortality. So if you look at the causes of mortality overall in patients who were enrolled in DAPA-CKD, you will see that cardiovascular death and non-cardiovascular death. In cardiovascular death was roughly around in 37% of patients. So a good number of patients did not have CV death. 41% of patients, in fact, died of other causes and not really cardiovascular causes. And in a small proportion, around 20%, we really were not able to identify or pinpoint the exact cause. And if you look at the the non-cardiovascular causes, what actually drove the mortality was infections and malignancy. So like I mentioned earlier when I started, these are the newer causes in patients with CKD or drivers of mortality. It's not just cardiovascular disease, it's also other diseases. Now, if you divide the patients into those with diabetes and without diabetes, you can see that the proportion of patients with diabetes were higher, of course. The proportion of patients who died with diabetes were also higher. But then you can see that roughly they mirror each other. So the same caused mortality in both the groups. But if you look closely, you can see that cardiovascular mortality was much more prominent in patients with diabetes, whereas a non-cardiovascular death, which is infections and malignancy, the proportions were much higher in patients who did not have diabetes. So there is subtle differences in the magnitude of the etiology. However, both causes were seen in both groups. Now we will look at those who received DAPA, how they fared. So this is patients who did have diabetes, and you can see that clearly in them the graph is separating. So there was a clear protective benefit or reduction in mortality in patients who received DAPA as compared to placebo with diabetes. And if you look at the data for without diabetes, it's even more impressive. So even in patients without diabetes, there was a clear benefit with regards to mortality. Here it's close to 50% reduction, which is quite impressive. So this is a subgroup analysis of patients. So you can see that among patients, the DAPA fared better in patients who were older and in patients who had type 2 diabetes. Also in patients who had lower EGFR and higher urinary albumin excretion. So the more severe the disease or higher your risk factor, the better the effect of, and in higher blood pressure also, the better the effect of dapagliflozin. So this is looking at the different etiology of death in patients in DAPA versus placebo. Again, what is surprising here that you can see the first bar on top is the overall mortality, and that was clearly beneficial. But then when you look at the cardiovascular death, apart from the heart failure, none of the others were actually strongly in favor of DAPA, whereas the non-cardiovascular death actually showed a reduction in patients who were receiving DAPA. So this is comparison with other molecules. This is Credence and SCORED, which looked at canagliflozin and sotagliflozin. Again, you can see the data is fairly similar. With regards to all-cause mortality, both Credence and DAPA-CKD showed that there was clear benefit. And when it comes to cardiovascular death as such, if it is largely driven by heart failure, I think you will see a lot of benefit. But if it's when you're looking at atherosclerotic disease, the benefit is plus minus. Possibly, maybe none of these trials, remember, their primary outcome was something else. They were not designed to look at only mortality. So you must take this data with a pinch of salt. And if you look at non-cardiovascular death, DAPA-CKD showed a clear benefit. Again, here, the reason may be that among these trials, DAPA-CKD is the only trial which included substantial amount of patients without diabetes. So, and both SCORED and Credence had patients who had high risk for ASCVD. So again, the non-cardiovascular mortality clearly is better in patients who received dapagliflozin. So this is just a snapshot of how SGLT2 inhibitors, how their mechanism of action has expanded ever since they were introduced about a decade ago. And initially, though it was introduced to be for its glycemic benefit, now you can see it is expanding into the heart, the kidney, now it's gone to the liver. There are studies with PCOS, so it's and even with Alzheimer's. So the scope of utility of SGLT2 inhibitors is growing. We'll have to wait and watch how it progresses. So in conclusion, it was originally developed for glycemia, but now it's finding uses elsewhere and everywhere, I must say. And the mechanistic action for benefits of both cardiac and renal and even other organs are all being postulated after seeing its results. And when you talk about dapagliflozin, clearly there is a beneficial effect on mortality in patients with CKD. I think that is very clear in the data. So if we, as diabetologists and endocrinologists and physicians, are seeing patients with early CKD or with having high risk factors for developing CKD, I think it's a good practice to initiate them on DAPA or any other SGLT2 inhibitor at the earliest. Thank you.
Thank you so much, Dr. Belinda, for your dynamic presentation. Presentation was lovely, and as is your sari, which is quite monsoon-like with an umbrella on it. I was admiring that also. It was a wonderful, detailed way you had explained the mechanism of action and the glomerulus, all the pressures. It was fantastic. And we have seen, as you have shown, that it has become the favorite molecule. I mean, all the consultants are happy, made big cardiologists, nephrologists, primary care, diabetologists. And it seems like all the organs are happy too. So all the organs love it too. So I think we have more than robust evidence and everybody has been using. But with the patent gone, there is a flood of DAPA. So what are your thoughts on that, about the molecule itself, and now the newspapers showing all the generic to be used? What are your thoughts regarding that?
I think most of the effects that we see are actually class effects. So any SGLT2 inhibitor should have similar effects. But I think in India, DAPA is the most popular, like you correctly said, because it is accessible to a lot of our patients. CANA and EMPA may not be accessible and affordable to all because it's still slightly highly priced compared to dapagliflozin, which is the reason why all of us prescribe DAPA in compared to the other two.
This is one class of drugs where mortality benefit has been clearly demonstrated. And because mortality benefit is demonstrated, it becomes a very primary or an integral part of a diabetologist's prescription to have this class of drugs, SGLT2 inhibitors, in your management of diabetes. And I think that's kind of echoed by the ADA recommendations. In the DAPA-CKD study, there is a caveat. You must remember that certain classes of patients were excluded, such as adult polycystic kidney disease, ANCA-associated vasculitis, people who have received immunotherapy for CKD, lupus nephritis. So I think in this class of patients, the use of DAPA is untested. I mean, DAPA-CKD per se, you don't have data regarding that. Maybe Prashant could shed some light on it.
Patients that were excluded, but they form a very small minority of the total number of patients that we see. But it is also interesting that the type of patients that were included are the ones that are generally excluded before, like the ones with advanced CKD, the ones with albuminuria. The EMPA kidney trial went up to a GFR of 20. DAPA-CKD stopped at 25. So these are the patients, like the ones who are at really high risk for progression of both kidney disease and for cardiovascular death. So it is heartening that these type of patients were included, and a lot of Asians. 30% of the patients were Asians, again, which are generally excluded, or they form a much smaller group in the previous trial. So on the whole, DAPA-CKD was, like Dr. Vashish said, it is a first trial to show a mortality benefit in CKD patients, all-cause mortality. So I think it's a useful drug for most of the patients. But I would like to ask you anything you want to tell about the adverse effects of this group of drugs, which we should keep in mind.
Mostly, in clinical practice, the commonest adverse event that we see is genital mycotic infections. And so that, I think, with little bit of education, can reduce the risk of genital mycotic infections. To just speaking to them about genital hygiene and educating them about the effects, I think is important when you initiate the patient on therapy. Secondly, in elderly, hypovolemia could be a concern, so use it cautiously. Sometimes when you're seeing the patient for the first time, if there's a tendency to start SGLT2 inhibitor plus diuretic, particularly in an older patient, I think we should be cautious because that can cause a little bit of hypovolemia and its issues. So maybe, staggered approach. You start SGLT2 one, and the next visit you can start the diuretic, or vice versa, whichever. So those are the small things. And of course, if you're not sure of the type of diabetes, DKA can be an issue in patients with type 1 diabetes, so that is something that you should be cautious of.
So under stressful conditions where you find that the patients are in ketosis, maybe DAPA is not the right drug to start with, and once the ketosis is over, switching to DAPA is probably your best decision in the management. Am I correct, Dr. Belinda?
Correct, sir, yes.
And just pre-surgical procedure, we tend to stop it for 48 hours. And
yes, again, for the same issues, because there'll be a lot of hemodynamic variations, so you can withhold it for a while and then restart it. Having said that, I think new data shows that, during intercurrent illness, actually a patient who was on SGLT2 inhibitors fares better. with regards to even kidney disease progression. So, and eventually their prognosis is better. So maybe going forward, right now when patient is acutely ill and admitted to ICU and admitted even inpatient with maybe like a UTI, we generally tend to take it off. But maybe going forward, that practice might change as well.
Yeah, so that's a very, very interesting aspect, because the moment a diabetic gets UTI and the patient is on SGLT2 inhibitors, the tendency is to take it off. I personally think that's not the right thing to do, because you're taking off the benefits of the class of drugs for the patient. There is no cause and effect association yet. It is an observation. So thinking that just because the patient is on SGLT2 inhibitors, the patient gets UTI or a genital myocardic infection is also probably not the right approach. If it is recurrent, maybe you'd like to revisit it, but as far as possible, I would recommend try to keep the drug on so that the patient gets the maximum benefit, especially because it has mortality benefits. Whether it's empagliflozin, whether it's dapagliflozin, the class effects are huge, which is not afforded by most other classes of diabetic drugs.
All the 3 trials were stopped prematurely. Credence,
Yes.
Empakidney, Dapa-CKD. So it points towards some class effect of all these drugs. All of them showed benefit within 2 to 3 years.
It had all overwhelming benefits, which is why it was
and almost 30% of relative risk reduction in cardiovascular and renal and all. So probably it shows that it's a class effect. Most of these drugs do the work. Questions from the audience, please.
Just one more point I'd like to make before we go to the audience. Dr. Belinda pointed out a very, very important factor in the DAPA-CKD trial, which is non-diabetics with CKD. And it's very, very interesting to note that you gave the same dose, 10 milligrams of dapagliflozin, and they got the same benefits. Now here, there may be many practitioners who might think that, okay, what about hypoglycemia and so on and so forth. I don't think hypoglycemia is a concern with this class of drugs, but please understand that the benefits of SGLT2 inhibitors also extend to non-diabetics. That's a very, very important aspect to remember. I think, yeah, Prashant, you wanted to invite questions from the audience.
Questions from the audience, please.
Thank you so much. Next session, I would like to invite our chairpersons, Dr. Pradeep Kumar and Dr. Shelvaraj. Dr. Pradeep Kumar is a very eminent diabetologist who has his own hospital, Brookfield Hospital, and he concentrates on affordable care for many patients. And he has had an innovation in his name with a national patent in his name called BEAST, which is a Brookfield Emergency Accident Support Team, an app-based ICU on two-wheeler aiming at providing emergency care with a virtual ICU on site. And he has been recently awarded with the National Award for Diabetes Awareness for the year 2023. And is a very enterprising physician, and we are very happy to have him here. Our next chairperson is Dr. Shelvaraj, who is a senior physician and diabetologist and founder medical director of Kaveri Healthcare, and is a visiting consultant at Motherhood Hospital with multiple awards and publications to his claim. Thank you both of you, sir.
At the outset, I would thank Dr. Anantram and Magna Code for giving us this opportunity to chair this session, and kudos to Dr. Anantram for putting up this wonderful show for diabetes update and endocrinology update. It's with huge pleasure and honor that I would like to invite Dr. Arvind, who doesn't need any introduction to this august audience, but we refer to him as the Thyroid of diabetes in Bangalore. And he always brings about a flair of Bollywood, Tollywood, and Collywood into his presentations, and we are looking forward to hear from our Thyroid, Dr. Arvind Jagdisha. Over to you, Arvind.
So good evening, everybody. At the outset, I thank Dr. Anantraman and Magna Code team for making me a part of this conference. Today my talk is on role of DPP-4 inhibitors in special population. So first I'll take two important special conditions like CKD and CVD. First I'll be discussing about CKD. If you take CKD in type 2 diabetes, CKD affects nearly 2 million individuals worldwide, and type 2 diabetes is the leading cause. Diabetic kidney disease is a major microvascular complications of type 2 diabetes worldwide. On the right hand side you can see the prevalence of CKD exceeds 20% in patients with age more than 60 years and 30 to 40% in high risk population with diabetes. Around 30 to 50% of type 2 diabetes patients develop DKD can have rapid progression leading to kidney replacement therapy. So the bottom line is there is an increasing prevalence of DKD parallels the dramatic worldwide rise in the prevalence of diabetes. So if you take the global burden of CKD in type 2 diabetes, almost 10% of the deaths in type 2 diabetes patient is attributable to CKD. Diabetes is the most common cause of end-stage renal disease accounting for nearly 44% of new cases. On the right-hand side, you can see nearly 36% patients with DKD results in persistent albuminuria, reduced eGFR or both. Risk of diabetes-related CKD observed much higher in Asian countries than in the Western population. So CKD attributed to diabetes is a major but under-recognized contributor to the global burden of the disease. So the double-edged sword of diabetes and CKD, if we take the Indian scenario, almost 697 million cases of CKD in the world. Nearly 16% of the cases of CKDs are Indians. Prevalence of CKD in Indians with diabetes reported to be 48%. Threefold higher in renal and all-cause mortality in Indians with type 2 diabetes versus without diabetes. So this is a flow chart showing the adverse interrelationship of type 2 diabetes in CKDs. Like if you take at the top diabetes, hyperglycemia and dyslipidemia, like how it goes on, how the pathophysiological factor plays a role and leading on to intercellular signaling pathways abnormality, leading to transcription factor that is increase in NAFKB, leading on to glomerular hypertrophy, mesangial expansion, tubulointerstitial fibrosis and inflammation, glomerular sclerosis and kidney fibrosis. So the metabolic changes associated with diabetes leads to glomerular hypertrophy, glomerular sclerosis and tubulointerstitial inflammation and fibrosis. So we know that as the age advances, there will be a renal function deterioration. With the increasing duration of diabetes, it also adds on that. So the longer duration of diabetes is associated with lower eGFR in patients with type 2 diabetes patient. So you can see in this slide the structural changes in kidney morphology due to type 2 diabetes. On the left hand side you can see the normal kidney glomerulus. On the right hand side you can see the diabetes kidney glomerulus. So the bottom you can see the the DKD induced structural changes, that is the thickening of the glomerular basement membrane, fusion of the food process, loss of porocytes with the denuding of the glomerular basement membrane and mesangial matter expansion, and development of DKD associated with many alteration in structure of multiple kidney compartments. So the renal function deterioration over a period of duration of diabetes has been shown in UK PDS 74 study as well. So now coming to another aspect of today's talk is the cardiovascular disease. So in diabetes, especially in type 2 diabetes, so there's a 2 to 6-fold higher incidence of CVDs in type 2 diabetes patients than non-diabetics. Every 1% increase in HbA1c is associated with 8% increase in risk of heart failure. On the right hand side you can see about 1/5 patients with chronic heart failure have type 2 diabetes and 40% type 2 diabetic patients experience worsening heart failure. So 1.5-fold greater risk of heart failure in type 2 diabetes with HbA1c more than 10%. So CVD is a common comorbidity in type 2 diabetes. So you can see the global burden of CVD in type 2 diabetes. We know the prevalence of type 2 diabetes in cardiac patients amplifies the risk of hospitalization and heart failure than the non-diabetic patient. So there is a double epidemic of diabetes and CVDs, especially all over the world, especially in our countries as well. So this is a flow chart showing the adverse interrelationship between the type 2 diabetes with CVD. So the pathophysiology of cardiomyopathy of diabetes, how the things happens in diabetes, how the person develops an heart failure and heart-related ailments in type 2 diabetes. So the mechanism following diminished systolic and diastolic functions of the heart also increases the risk of having heart failure in diabetic patients. So this is the natural progression of type 2 diabetic patients towards CKD and CVD. So bottom line is the end-stage renal disease is most recognizable consequences of DKD, but majority of the patients actually die from CVDs and infections before needing the kidney replacement therapy. This is an important statement. So before they end up in landing in dialysis or so, they die because of the infections or because of the heart ailments. So the 4-point major adverse cardiovascular events rates is increased with the lower baseline eGFR in type 2 diabetic patients. So how do you manage these patients with renal impairment or CKD? This is the question. So the challenges of various OADs in CKD, we can see here the various drugs like metformin contraindicated if eGFR is less than 30, SGLT2 inhibitors less than 30 should not use, GLP-1RA caution with initiating or increasing due to the potential risk of acute kidney injury, glitazones not suggested in renal impairment due to potential fluid retention, sulfonylureas not recommended in CKD, especially the second generation. So the various guidelines have shown the management of type 2 diabetes with CKDs. So what they say is the optimize the glucose control to reduce the risk or slow the CKD progression. In CKD patient more than 30 years, so recommendation is to be aggressive with the appropriate medication to prevent the CKD progression. So KDIGO guidelines in type 2 diabetes with CKD, this is a flow chart showing that first is always the lifestyle modification. On the right hand side you can see lifestyle therapy first, then the first line treatment with the metformin and SGLT2 inhibitors and additional drug therapy as needed for the glycemic control. So the AAC guidelines once again recommends the usage of various drugs in the CKD, especially the role of SGLT2 inhibitors and DPP4 inhibitors plays an important, and a dosage adjustment is very important to see which stage of CKD the patient is at. Accordingly, the dose adjustment is to be done. It is not the toxicity of any medication. 100 mg means it is not strong medication or it causes toxicity. 50 milligrams is more than enough to control the renal progression in a particular patients of CKD. So durability, now I will be showing few studies regarding the sitagliptin patients. Like this study shows the durability of sitagliptin in elderly with type 2 diabetes. You can see in these studies, sitagliptin achieved durable effect and stabilized microvascular complication progression in elderly patients with type 2 diabetes. So sitagliptin achieved durable effect and a stabilized microvascular progression in elderly patients with type 2 diabetes. Next is sitagliptin in type 2 diabetes and risk of renal failure. This is a retrospective study done. What does it say is the sitagliptin, compared with diabetic controls, sitagliptin did not increase the risk of acute renal failure. So the next study is the clinical evidence of DPP4 inhibitors with versus sulfonylurea. This is always the question asked, like after metformin, which drug to use, whether to use sulfonylureas or DPP4 inhibitors. This is a clinical evidence shows, this is a real world evidence study which shows that sitagliptin provides a greater reduction in albuminuria independent of the glycemic control. So the efficacy of sitagliptin in type 2 diabetic patients with chronic renal insufficiency. This is another studies which emphasizes the benefit of sitagliptin in the management of chronic renal insufficiency. According to the stages of CKD, you can adjust the dosage so that the sufficient drug exposure is enough to manage the diabetic status. So, the sitagliptin demonstrated glycemic control in type 2 diabetic patients with moderate to severe renal insufficiency and patient with end-stage renal dialysis end-stage renal disease on dialysis as well. This is to be noted. So, moderate to severe as well as ESRDs on dialysis and even in transplant patients as well. So, sitagliptin is well tolerated and demonstrated effective glycemic control in type 2 diabetic patients with moderate to severe renal insufficiency. So, the stable EGFR with sitagliptin over 4 years. So, we know all this 4 years, 5 years back we had this landmark study PCOS which came into the publication where we came to see that treatment with sitagliptin was well tolerated in CKD patients with no evidence of adverse impact on the safety endpoints in the PCOS. Now, always there is a direct comparison study between the sitagliptin versus the glipizide in type 2 diabetic patients with CKD. This particular study once again emphasizes sitagliptin provided glycemic control non-inferior to glipizide in type 2 diabetic patients with chronic renal insufficiency who had inadequate glycemic control. So, in this particular study, you can see the dosage used was sitagliptin was 25 milligrams. That means 25 milligrams is more than enough. It doesn't mean 100 milligram causes any toxicity. In this particular group of patient, 25 milligram is more than enough to have a proper mechanism of action. So, sitagliptin provided clinically meaningful reduction in HbA1c and FPG levels similar to glipizide over 54 weeks in type 2 diabetic patient and ESRD on dialysis therapy. This is another interesting study, that is composite HAR study, which shows sitagliptin versus dapagliflozin in mild renal impairment. So, what does this study says? Sitagliptin showed greater improvement in glycemic control than dapagliflozin in type 2 diabetes patients with mild renal insufficiency and were inadequately glycemic control on metformin and sulfonylureas. So, now coming to another aspect of today's discussion is managing type diabetic patient with CVDs, that is cardiovascular disease. As we can see the recommendation, whether it is AAC or ADA, what does it say is after metformin, after lifestyle modification, after metformin, assess the overall clinical scenario of the patient, where they are at risk of ASCVD, risk of heart failure, risk of renal failure, cost is a factor, weight is an issue, then you select the medication appropriately. In all these situations, if you see, the DPP-4 inhibitors has a role to play in all these aspects. So, this is an important slide to show the placement of DPP-4 inhibitors in treatment algorithm as per ADA and ESD recommendation. You may ask me like where it is placed, where do you use the DPP-4 inhibitors? So, you can see in this slide metformin as the first line therapy. If the patient has established ASCVD or CKD, if yes, DPP-4 inhibitor can be used as a third line therapy if HbA1c above target. Next point, no ASCVD or CKD. If minimizing the risk of hypoglycemia is compelling, DPP-4 inhibitors can be used as a second line therapy or later, other than the second line agents like SGLT2 inhibitors, GLP-1 RAs and TZDs. The combination of DPP-4 inhibitors with GLP-1 RA is not recommended. Very important point. The third point you can see, if weight loss or minimizing weight gain is an important aspect, DPP-4 inhibitor once again has a role to play as the third line agent in combination with SGLT2 inhibitors when GLP-1 RA is not tolerated. The last point which plays an important role in our country country. If costs are important, DPP-4 inhibitor as the fourth line therapy after SU and TZD. So, DPP-4 inhibitor has a role to play. This slide summarizes the overall picture where you prefer to use DPP-4 inhibitors in your clinical practice. So, the role of DPP-4 inhibitors in CVD's safety in diabetes, you can see the DPP-4 inhibitor has a non-inferior risk of composite outcome compared to sulfonylureas. So, in this particular study, what does it say is DPP-4 inhibitor associated with reduced risk of hospitalization for heart failure than sulfonylureas in type 2 diabetic patients. So, coming to the safety outcomes of DPP-4 inhibitors, DPP-4 inhibitor can be subjective choice for treating type 2 diabetes as they do not seem to affect the CVD risk. So, sitagliptin in type 2 diabetic patient is showed significant reduction in the risk of CHD and in overall ischemic stroke. This particular study has shown that, published in this year's study, which has shown it can be used very comfortably in patients with CHD. So, overall, sitagliptin achieved favorable outcome on lowering CVD risk in type 2 diabetic patient. This another landmark study which showed that beneficial effects in renal patients, safety aspect in renal patient. It once again emphasizes in the cardiac patients as well that addition of sitagliptin to a usual care did not significant effect on rates of major CV events or hospitalization for heart failure. It can be used as a diverse group of type 2 diabetes patients who are at high CV risk without increasing the rate of CV complications. So to summarize my talk, the role of DPP-4 inhibitors in CKD, with the prevalence of type 2 diabetes increasing steadily, CKD will continue to rise in India. The recommendation to reduce the dosage of DPP-4 inhibitors in renal impairment are aimed for achieving drug exposure that yields maximum efficacy. Sitagliptin is well tolerated and demonstrated glycemic control in type 2 diabetic patients with moderate to severe renal insufficiency and end-stage renal disease on dialysis as dialysis patient. This is an important slide which shows the role of sitagliptin in DKD. There should not be any hesitation in using sitagliptin in this particular group of patients, because you should not think that particular dosage is heavy or anything like that. So definitely they're looking at the what stage of CKD patient is having. Accordingly, the dosage can be selected 50 milligrams or even 25 milligrams, but for the better efficacy of sitagliptin in CKD. When it comes to role of DPP-4 inhibitors in CVD, so Indians are more susceptible to diabetes and CVDs. CAD occur 2 to 3 decades earlier in Indian diabetic patients. Indian patients with type 2 diabetic have twice the CVD mortality and all-cause mortality rates. DPP-4 inhibitors have tolerable safety profile than the sulfonylureas for type 2 diabetes treatment initiation in high-risk CVD patients. Sitagliptin can be used in diverse group of type 2 diabetic patients who are at higher CV risk without increasing the rate of CV complications. Sitagliptin achieved favorable outcomes on lowering the CVD risk in type 2 diabetic patient. So when it comes to the usage of DPP-4 inhibitors in the management of type 2 diabetes, definitely it has a role to play not only in the management of regular diabetes, even with the complicated, even in the special circumstances patients, we can use this particular molecule where the role of DPP-4 inhibitors, especially the sitagliptin, has got benefit to show. Thank you for your patience hearing. If you have any questions, please, we can have a discussion.
And you have clearly demonstrated that its utility is much beyond the normal diabetes or the garden variety of diabetic patients. It could be still used in patients with DKD or CKD. To start the discussion, maybe I would just want to get a basic doubt. Maybe when we are able to get the maximum tolerable efficacy of the DPP-4 or the sitagliptin in CKD at 25 milligram, why do you need a higher milligrams for a person with a normal renal function?
Yeah, the basic thing is when the function, what happens in CKD is, I showed the clinical slide, where there is so much of changes in the glomerular structure. So that might be the thing, because when it is kidney is functioning normal, that 100 milligram is, the studies have shown that 100 milligram is beneficial. When there is a reduced clearance, insulin clearance and all those things, the 100 milligrams may not be, it may be more. So that is what the clinical study have done is, 100 milligram in a CKD may not be required, but the same mechanism of action can be expected with 25 milligrams. So that is 25 milligrams can be.
So at 25 milligrams, we are trying to say that the maximum DPP-4 inhibition
Drug
efficacy
exposures,
rate
yeah.
is obtained.
Yeah.
Okay. Wonderful.
So given a choice amongst the DPP-4 molecules in a patient who's got CKD, what would be your preferred choice of picking up a molecule and why?
See, that's a very interesting question, because it all depends upon the preference. Because the direct question is the competition between linagliptin and sitagliptin. That's the direct question. The only thing is, if you compare the linagliptin, the dosage is only fixed 5 milligram, that is comfortable, you can use in any stage. But that doesn't mean that sitagliptin is much inferior or anything like that. Because if you compare, if you see the studies, one with the Carmelina study, another with the PCOS study. If you see these two studies, PCOS is one study with larger patient population is there, and PCOS is the one study where 100% patient had the CVD, where 57% with the Carmelina, and the fasting plasma sugar reduction and the weighted glucose reduction was very much good with the sitagliptin. So even you can use linagliptin, but if at all, if you say the patient has got moderate renal insufficiency, you use 50 milligrams. 50, that's more than enough. If the patient is having severe renal insufficiency, use 25 milligram. If the patient is on dialysis, still you can use 25 milligram. If the patient post-renal transplant, the studies are there with sitagliptin where it can be used comfortably. So these are the beneficial or plus or minus point with both linagliptin and sitagliptin. But what I mean to say is, the patient with diabetes, CKD, it's not only linagliptin always. It's not only. Sitagliptin has a role to play. It may not be 100 milligram. That 100 milligram should not be seen as a very toxic dose or heavy dose for a CKD patient. It doesn't mean. It says 50 milligram is more than enough. So you can definitely use that.
But there is generally an underplay in the real scenario, because once a patient is in CKD or DKD, the number of prescriptions floating with a lower dose of sitagliptin is comparatively lower as compared to the direct lina or the 10-ligliptin which we see.
Yeah, that is the thing, the main talk, or today's talk agenda was that the dosage of sitagliptin is available in 25, 50 milligrams and 100 milligrams. Depending upon the efficacy, it can be used very, very comfortably. When it comes to cost factor, it doesn't matter much actually. So 25 milligram compared to linagliptin is almost the same. So you can definitely, if the patient has got severe renal insufficiency, you go for 25 milligrams. So very comfortably, without any hesitation, with the patient with diabetes or with moderate and severe renal insufficiency, with dialysis, post-transplant, definitely you can use sitagliptin.
Any questions from the audience? Well, if there are no questions, thanks for the wonderful talk, Dr. Arvind. It was
Thanks,
always a
Anantha.
pleasure to hear from you.
Thank you.
With this, I would like to invite Dr. Pramila Karla, who doesn't require any introduction. She is a professor of endocrinology from Ramaya, a very big name by the Endocrine Forum, and a great orator, which we are awaiting to hear her about redefining metabolicity with SGLT2 inhibitor. Over to you, Dr. Pramila Karla.
Thanks, chairpersons, for the kind introduction, and good evening, everyone. At the outset, I thank Dr. Anand Raman and the Magna team for inviting me for this talk. And I'll be talking about the the topic on redefining management of metabesity by SGLT2 inhibitors. We had a nice talk by the previous speaker on the use of DPP-4 inhibitors. We know that DPP-4 inhibitors, ever since they came into the Indian market, have been one of the good drugs for the treatment of diabetes. But over a period of time, another group of drugs which came into the Indian market are the SGLT2 inhibitors. And the benefit which we achieved over and above the previous existing drugs was definitely a weight loss benefit and a cardiorenal benefit, which has been shown in many of the studies. And we know that when we talk about diabetes, it is not just diabetes or hyperglycemia, it's more of a cardiorenal syndrome, it's more of a overweight and obesity, which we are also trying to treat along with the treatment of hyperglycemia. So we know that the burden of diabetes in India is huge, and we also know now from the studies, from the ICMR study, that the burden of pre-diabetes is huge. The burden of pre-diabetes, as per the latest data, is around 15.3%, and diabetes is also huge, and the number is increasing. And if you try to remember the last 1 week, whatever patients we have seen in our OPD, we clearly will know that most of the patients whom we see in our OPD with type 2 diabetes either are overweight or obese. So they fall into that category who are always the high risk, not only regarding to their hyperglycemia, but because of their overweight status or obesity status, they are even more prone for complications. So when we talk about the treatment of diabetes, we just don't talk about the treatment of hyperglycemia or a glucocentric approach. We talk about metabesity, that means the metabolic syndrome, and the obesity. That is the whole thing we are targeting. And we know that along with the hyperglycemia, they also have dyslipidemia, they also have hypertriglyceridemia, they have low HDL, they have higher waist circumference, and obviously over a period of time, they are predisposed to cardiovascular problems and cardiorenal problems. So when we talk about the obesity or generalized obesity in our country, we know that it is increasing, and we may have different sets of patients. You may have a patient who may look like to have a normal BMI, but when you see their visceral fat or you see their abdominal obesity, they are quite overweight or obese, and they don't fall into that actual healthy category. So so-called people who look to be normal are actually not normal. So that is the whole concept of the unhealthy normal BMI. So we call that patient as healthy, but they are not actually healthy. So when we talk about metabolic disorders, we know that patients may have multiple problems, but we know that when we are talking about the use of SGLT2 inhibitors, we are definitely talking about diabetes. Along with that, we are talking about obesity, and we are definitely talking about cardiorenal benefits. So also we know that all these translates into problems with endothelial dysfunction as well. So also that is also the part of the syndrome. Now, when we talk about this concept of metabesity, we know that obesity, diabetes, dyslipidemia, they all cause one problem, that is inflammation. So we all know that now when we talk about diabetes or we talk about the complications of diabetes, it is not just one hyperglycemia or the glucocentric thing which we are talking about. It is a vicious cycle of inflammation. So what happens, the inflammation sets in, there is hyperglycemia, there is glucotoxicity, there is lipotoxicity. This all leads to more of inflammation, more of endothelial dysfunction. As a period of time progresses, it leads to more of the vascular failure. That is what we call as the dysfunction with the endothelial dysfunction. We call that as accelerated atherosclerosis, and all these patients land up with more of cardiac problems. They land up with either a cardiomyopathy, they may land up with a cardiac event, or they may land up with a heart failure. So these are all the problems which happen over a period of time, and this inflammation is the central part of it. So it's the thing which continues. And that is why when we bring down the glucotoxicity, when we bring down the inflammation by reducing the reactive oxygen species, we are actually bringing down the burden of the problems of the metabolic syndrome which is happening in that patient, and also bringing down the endothelial dysfunction or the vascular failure which is happening in these patients. Now, we know that there is a bidirectional relationship of type 2 diabetes or obesity and metabolic syndrome. So as the diabetes progresses or as the hyperglycemia progresses, there is more of inflammation, there is more of endothelial dysfunction, cognitive decline happens, loss of beta cells happen over a period of time, and the further glucotoxicity propagates the further loss of the beta cells. Now, when we talk about this impact of this obesity on health, we know that if a person is obese, now obese may not actually mean the BMI obese. It may mean more of visceral fat, it may mean more of the abdominal obesity, it may mean more of the higher waist circumference. So these are all the people who are predisposed to more of insulin resistance. They'll have hypertriglyceridemia, and you will see when you do their blood tests, you will see that they have a low HDL, and they have a LDL which is not seemingly high as per the numerical value, but when you see they have the small dense LDL which is more atherogenic, and also these patients have more of reactive oxygen species, more of inflammatory products, and these patients are more predisposed to further problems related to their cardiovascular issues. And also many of the women may be also harboring polycystic ovarian syndrome along with that, and these are all the factors which further leads to the problem. So this is what we were talking about, is the healthy obesity, so-called what we call. We say that the patient is either metabolically healthy, non-obese, or the patient is metabolically unhealthy, non-obese, or the patient is metabolically healthy, obese, or the patient is metabolically unhealthy, obese. So we have all these categories. So it's just not the BMI we have to see. We have to see what all is existing. So is the patient looking metabolically healthy, non-obese? Fair enough. Then we have a patient who may be non-obese, but still they are unhealthy. They may have dyslipidemia, they may have impaired glucose values. Then we may have a patient who is metabolically healthy, but is obese, may be overweight, but still their parameters are within the range. But it may not stay within the range over a period of time. It may have problems over a period of time. Then we have the metabolically unhealthy obese. That's the category where everything is deranged. They are already obese. They always have the metabolic problems as such. Now, when we talk about the high-risk obesity, we know that these people are predisposed to multiple problems. So they may have insulin resistance, they may develop diabetes over a period of time, then they may have higher blood pressure, they'll have abnormal lipid values, and they will have inflammation, which I was talking about. They'll have endothelial dysfunction, and so-called what we call as a vascular failure. And then they will have these cardiovascular events. One or the other event may happen, and the first presentation may be with the event only, rather than with the hyperglycemia. So when we talk about the obesity burden, now we know that when we classify for our patients, we take a BMI more than 25 kg per meter square as obese. So we are not taking the cutoffs of 30 or 29.9 international cutoffs, for the reason that there are studies which have been done, and they have found that even the people who have a BMI beyond the 25 mark have a higher visceral fat, which predisposes them to the same amount of the metabolic syndrome which a normal Caucasian of a BMI 29.9 or 30 will have. So we are actually having a lesser BMI, but still we are more predisposed to problems even at a lower BMI. And we know that as the patient increases with the BMI levels, the risk further may increase. And if you talk about our patients, we know that we may say that some patients look lean, but when you actually calculate their BMI, they are either in the overweight category, which we call as a BMI between 23 to 25, or they'll be in the obese category as well. Now this we are all aware, the thin fat Indian concept, which we talk about, we say that the Indian looks thin, and we all are aware of the two pictures which we all have seen many times, Dr. Yudnik and Dr. Yagnik sitting together. Both had the same BMI, but Dr. Yagnik had much more visceral fat as compared to Dr. Yudnik. So this is how we say that we had the lean obese or the unhealthy lean phenotype, which the visceral fat is more, and the patients are predisposed to more of cardiovascular problems. So we know that our cutoffs are a little bit lower. We say that if a patient is within a BMI of 18.5 to 22.9, we classify them as normal. More than equal to 23 to 24.9, we classify them as overweight, and above the 25 mark, we classify them as obese. Now, today we are talking about the use of SGLT2 inhibitors. So we know that SGLT2 inhibitors are one of the group of drugs used for the treatment of diabetes, also used for the treatment of cardiovascular problems or heart failure per se. But when we are talking about diabetes and obesity, we know that whenever our patients who are overweight or obese, and we do use SGLT2 inhibitors, we do see a good amount of weight loss. And that's one of the good things, because we don't not only get a weight loss, but we also get a reduction in the inflammation or the metabolic risk parameters in these patients. So we always talk about the treatment of diabetes, and we say there are multiple pillars which help in the treatment or the management of diabetes. So we know that glycemic control, blood pressure control, dyslipidemia, this has to be done. but we also have to see that we also take care of the cardiovascular and the renal problems. Like I said, that it's not just the metabolic syndrome or diabetes or the glucocentric approach which we target, we also talk about cardiorenal benefit. So that is how the treatment of diabetes has changed over a period of years, ever since newer and newer drugs have come into the Indian market. Now we know that patients who are treated with SGLT2 inhibitors, we have to use these drugs definitely if the patient already had a cardiovascular event or is a high risk for ASCVD or is a high risk for renal disease, already has albuminuria. These are all the patients who definitely need these drugs unless there is a contraindication. But we can also use it as a drug, as an anti-diabetic drug for many of our diabetic patients, because if you have to add a drug after metformin, then we have options. We have options of DPP-4 inhibitors. We know that they are weight neutral, cardio neutral. Then we have options of SGLT2 as well, because these drugs are also going to help in weight loss. They have a cardiorenal benefit. They also are going to have a good anti-hyperglycemic efficacy. They reduce the inflammation and the oxidative stress as well. So in a way, they actually take care of multiple pathophysiology which happens in patients with diabetes and also the other comorbidities. So we know that when we talk about the cardiorenal protection with SGLT2 inhibitors, there are multiple mechanisms. So we know that the blood pressure is also reduced to some extent. We see a drop of around 3 to 4 millimeters in systolic and 2 to 3 in diastolic. We also see that there's a cardiac fuel is changed. We know that ketones are, they help the cardiac outcomes as well. And also we know that because of the weight loss and the reduction in the visceral fat, there is further reduction in the inflammation as well as the metabolic risk factors. And also the patients lose weight overall. So all this translates into cardiorenal protection. Now we know that when we talk about patients with type 2 diabetes, we know that SGLT2 are upregulated in type 2. So when we use the SGLT2 inhibitors, they help to take care of that upregulation. They block the SGLT2 and there is excretion of more glucose in the urine. This is a simple mechanism by which these SGLT2 inhibitors work. So basically there is more of glucose excretion and the patient's glucose values start coming down in the blood. And as a result of which these patients will be definitely having a hyperglycemia which is taken care of. And along with that, they will also be losing weight because there is a sort of a calorie loss which is happening. Now, we know that if there is a urine glucose excretion of approximately around 119 grams per day, it leads to around 476 calorie loss, which happens in a day. So this is how it translates into the calorie loss for the patient, which leads to further weight loss. And predominantly that weight loss is because of the loss of visceral fat as well. Now, if you see, whenever we talk about any anti-diabetic drug, we know that SGLT2 inhibitors are also approved for heart failure and other indications. But when you talk about its use in diabetes, the first and the foremost thing which we have to be very sure of, that they have to have a good anti-hyperglycemic efficacy. And we have multiple studies with the SGLT2 inhibitors being compared to metformin, being compared to SUs, used along with SUs, along with DPP-4, compared to DPP-4, and we have seen a consistent reduction of HbA1c across all. So HbA1c reduction may range from 0.7 to even more than 1 in some of the studies, because it depends on how high the HbA1c to start with is, if the patient has a shorter duration of diabetes or a longer duration, also if the other factors are also playing a role. So many factors do play a role. So along with that, we see that the patient's drop of HbA1c is at least 0.7 to 0.8% with most of the SGLT2 inhibitors which have been studied. Also, it's not just the HbA1c, we are also worried about glycemic variability. So we know also we worried about fasting glucose, we are worried about postprandial glucose. So we also have to see whether it translates into reduction of all these parameters. So we know that we have data with glycemic variability with SGLT2 inhibitors. Also, when we try to see the fasting glucose values, also we see a consistent drop across all, whether it is being compared as a monotherapy or with the DPP-4 or with SUs or with the combinations with the other drugs, like if you are trying to compare with SU-MET combinations. So wherever these drugs have been studied, everywhere it has been shown that the consistent drop of the fasting plasma glucose has happened. And also the postprandial. So we know that not only the fasting, but also the postprandial glucose values drop to the tune of around 55 milligrams per DL in most of the studies, what has been studied. Now, When we talk about weight loss, we know that the weight loss is majorly because of loss of visceral fat as well, because people are always skeptical that if the patient is losing glucose from the urine, then they may have more of muscle mass loss. We do see some amount of muscle mass loss, not that we don't see. We see that especially in our older group of patients, but we have to counsel them about regular exercises. But the major loss also happens in the visceral fat. So many a times the patients will come and tell you that I have lost my muscle mass, but actually we have to tell them that it's also the loss of the visceral fat which is happening, and that's actually the thing we want the patient to have. Because if the visceral fat is lost, then it translates into reduction in the problems or the metabolic syndrome characteristics, and it actually helps the patient to get a better glycemic control and a better predisposition to the protection from the cardiovascular problems. So that is actually the beneficial thing which is happening for these patients. So if you see with canagliflozin around 300 mg, the visceral adipose tissue loss, they have tried to study in this study, and they have found around a 8.1% loss. Also, if you see the comparison with the GLP-1, we know that if you say the best standard of care if you can offer to your patient, it has to be a metformin, SGLT2 and a GLP-1. That's the best, because we know that you give the benefit obviously of metformin, which is already there. Along with that, if you have to give 2 drugs to your patient, you give a SGLT2 inhibitor and you give a GLP-1 analog, and it actually gives a very good glycemic control with the cardiorenal benefit also there with both of them. But when you try to see the comparison also, it has been shown that the gliflozins like canagliflozin have been found to be having a very good effect on the drop of the HbA1c as compared to GLP-1 analogs as well. Also the body weight lowering. So body weight lowering is also comparable. We know that GLP-1 analogs have a body weight loss effect ranging from 2.5 to 3 to even sometimes more, and the similar thing has been seen with SGLT2 inhibitors as well. And also you might have seen that sometimes your patients lose even more weight, and the reason for that could be many. Like first could be that the patient might have been on SUs and you would have brought down the dose of SU. Patient might have been on insulin and you would have brought down the dose of insulin. So all those factors also translates into further weight loss. And that's why you would see that many of your patients, when you start SGLT2 inhibitors, may not just lose 2.5 to 3, they may lose even more, or the pioglitazone is stopped. So all these factors further helps in the reduction of the weight. So there are many other factors in a normal setting or a real world setting which may add to the weight loss which you see with the SGLT2 inhibitors. And if you see the data with the canagliflozin, they have seen a good amount of HbA1c reduction to the tune of 0.86% and the body weight reduction to the tune of 3.6 kg with canagliflozin 300 mg dose. And if you see the patients who are in the low risk to very low risk category, then we can always say that we are definitely going to use these drugs for the benefit of the cardiorenal protection as well. But the patients who are in the higher risk or the upper end of the spectrum towards the higher cardiorenal risk are definitely the candidates where you have to offer the SGLT2 inhibitors, because we know that most of the data with SGLT2 inhibitors has shown a beneficial effect on the reduction in the hospitalization with heart failure and the MACE events as well. So if you, we have already discussed this mechanism of action. So there's a urinary glucose excretion, as a result of which both the fasting and the postprandial glucose values come down, and there is reduction of the visceral fat as well. So when we talk about the selectivity of the SGLT2 inhibitors, if you see the selectivity, we know that for the canagliflozin it's around 260-fold, for DAPA it's around 1200, and empagliflozin is around 2700-fold. And we also know that the SGLT1 receptors are also to some extent blocked by canagliflozin dose of 300 mg. There are some studies where they have found that if you have a lesser selectivity, you have a more beneficial effect on the heart failure outcomes. And if there is a more selectivity, then the beneficial effect on the heart failure outcome may be a little bit lesser. But these are all the different studies. It is not head-to-head comparison of any study. So there may be some differences in that. Also, we know that there are studies where they have tried to see the GLP-1 levels and the PYY levels, and they have found that there was a 35% increase in the GLP-1 levels with canagliflozin 300 and 60% increase in the PYY levels, which slows down the gastric motility as well and obviously reduces the appetite of the patient. And most of the times, if you see the studies which have been done with canagliflozin, they have shown a beneficial effect on the MACE events as well as the renal outcome. We know about the data from the canvas as well as the credence. So this was one of the first DKD trial which was done, and there was a significant renal protective effect which was seen with the use of canagliflozin. And you can see that the patients in the primary composite endpoint, if you see the doubling of the serum creatinine or the end-stage kidney disease or the EGFR reduction to less than 15 or the dialysis initiated or kidney transplantation, most of the places there was a beneficial effect with the use of canagliflozin. And we also know that it was found to have a beneficial effect in the renal death also to some extent. And if you see this, definitely it fared much better as compared to placebo in the primary outcome of end-stage kidney disease or the patients who had a doubling of the serum creatinine or renal or CV death. The hazard ratio was 0.7. So if you see the Credence trial, also there was, we know that when we start the SGLT2 inhibitors for initial few weeks, you will see a drop of the EGFR, but over a period of time that EGFR becomes normal, and that drop mostly happens to the tune of 4 to 6 mil per minute per 1.73 meter square, and over a period of time that drop becomes better and the patients come back to their normal EGFR in few weeks. And after that, we know that the fall of the EGFR is prevented. And we know that when we see the data from the Credence also, the long-term EGFR trajectories and the overall renal safety profiles were similar among the patients, whether they had an acute drop or they did not have. So again, the question comes that if the patient has baseline albuminuria, will it be better? So again, they have tried to see the urine albumin creatinine ratio, and they have tried to see that patients who had whether albuminuria at the baseline versus those who did not have. So we know that the effects were seen in both group of patients. And also if you see the blood pressure effects, we know with the SGLT2 inhibitors, we do see a drop of the blood pressure in systolic to the tune of 3 to 4 and diastolic to the tune of 2 to 3. And we know that this also has a beneficial effect not only on the renal, but also on the cardiovascular outcomes. So the cardiovascular outcome, the cardiovascular mortality and all-cause mortality was found to be reduced, and we know that this was seen in most of the canagliflozin trials. And if you see, the all-cause mortality was reduced to the tune of 14% and the cardiovascular mortality to the tune of 16%. And we know that when we talk about the adherence, we know that if a patient has lesser side effects and if they get some beneficial effects, they mostly adhere to the medications. And this has been seen in many of the studies that metformin definitely had the best adherence when they tried to see this in this review, but they found that SGLT2 inhibitors are also one among the best adhered drugs by the patient, or the compliance was quite good with these group of drugs as well. So highest was definitely with metformin users, and second to metformin was the SGLT2 users. And obviously if the patient has to take an injectable therapy, the adherence is always lesser as compared to the oral drugs. And when we see the major guidelines, we know that when SGLT2 inhibitor trials initially came, we were all skeptical that how come such a good effect is seen in such a short duration of time. But over a period of time, when we got more data from different trials, we were very clear that the benefit is seen quite early and it continues to be seen. So this is how the guidelines also changed as per the data we got, and over a period of few years, you can say, the guidelines have become very clear. So we know that these are one of the good group of drugs which we can offer to our patients as a general anti-diabetic drug, especially in patients who are overweight or obese. And also definitely as a drug if a patient is a high-risk ASCVD, already had an event, or is a high risk for renal outcome problems. So we know that it can be definitely used as an adjunct therapy for glycemic control, no controversy on that. We know that SGLT2 inhibitors like DAPA are also approved for heart failure indications as well. And also the cardiovascular outcome data is very well there with canagliflozin. We have the data from the renal outcome as well from both the CANVAS and the Credence trial. And we know that the progression of the decline of the EGFR was consistent whether the patient had albuminuria or they did not have albuminuria. So to summarize, we know that meta-obesity is one of the things which is quite a challenge in our patients. We keep on searching, or we keep on looking out for better options for our patients so that they get the maximum benefit and the better quality of life as well. And we know that a renoprotective therapy with a good anti-diabetic efficacy would be one of the good options for most of our diabetic patients. And we have this data with the canagliflozin on the reduction of the 3-point MACE as well as the reduction of diabetic kidney disease progression, even irrespective of the patients having albuminuria or they didn't have albuminuria. So I think with this I end. We can take the questions.
Thank you very much, Dr. Pramila. This was indeed a very fantastic and intricate deliberating talk on the various nuances of obesity. You also brought out the subtle differences of the obesity. Not all obese are the same. And you also highlighted the role of inflammation in the various forms of obesity and its contributing factors, and also how this group of drugs can be effectively used in diabetic patients having this CKD and cardiovascular diseases. So one question from my side to you is, given the various evidence that we have amongst the various SGLT2 inhibitors that are available, in your clinical practice, do you have a preference of using one versus the other in specific comorbid conditions of diabetic individuals?
Actually, if you see, we have data with dapagliflozin, EMPA and canagliflozin at the moment. So until unless we have a head-to-head trial to see the comparison, we know that we have all types of patients studied with all these 3 SGLT2 inhibitors. So it will be difficult to say that we can prefer one over the other. But it's just a question that definitely we have data with canagliflozin from the Credence and the Canvas, but we also have data with the other SGLT2 inhibitors. So I can say that it is all these 3 drugs have proven evidence with the cardiovascular and the renal outcome. That's how I will put it. Until unless we have a head-to-head comparison.
But in clinical practice, I think considering the patient's affordability, the other salts which can provide similar effects, do we still score upon canagliflozin, or do you want to look at others?
Now that's a very controversial question, because affordability is one end of the spectra and the treatment is one end of the spectra. If you have the drugs available which are good for the patients, like we also use like oral GLP-1s, though they are costlier, we agree, but we know that they are effective, so we use them. We use the injectable GLP-1s also, though we know that they are costlier, but we do use them in the group of patients. So I think keeping the cost aside, I would put that we can use it. Keeping the cost in mind, then we have to go for the options, whatever is available. That we also have to see the patient's affordability. That is definitely there. But that is one end of the thing. So it is always a shared decision and an informed decision. Patient has to be informed. And if they want, whatever the patient is the king, whatever the patient says. But as a doctor, it's our duty to tell them. The rest is left to the patient.
Any questions from the audience? I think everyone is clear about SGLT2 inhibitors. We have been bombarded with the SGLT2 inhibitors over the day. Thank you, Dr. Pramila, for the wonderful presentation. It's great to hear from you again. Thank you.
For the next session, we would like to invite our 2 next chairpersons on the dais, Dr. Sharath Honnati and Dr. Shobha Naidu. Dr. Sharath Honnati is a consultant diabetologist physician practicing at HSR Bangalore, and he's also consultant at Apollo Sugar Clinic, Electronic City, and is an accomplished physician. And our next chairperson is Dr. Shobha, who's been a consultant at Saga Hospitals, Bangalore. Thank you. Thanks.
So we have our next speaker, Dr. Mani Deepti Dasari, who's a full-time visiting consultant and endocrinologist at Apollo Sheshadripuram. And at her honor, she has the best outgoing students in MBBS and the secured gold medal in MBBS, and has publications in areas of hypothyroidism and diabetes. Over to you, Dr. Mani Deepti.
Thank you, sir. Thank you for the warm introduction.
I thank Dr. Anantaraman sir and Magna for giving me this opportunity. So today our session is on targeting the role of dapagliflozin and sitagliptin in type 2 diabetes. As we all know, till the discussions which went on, everyone focusing on it's not glucocentric approach, it is an wholesome approach, cardiovascular risk factors and renal factors also we have to address. With all these risk factors in address, like if the patient has same HbA1c, there are some people who are having more cardiovascular complication. There are some people who are having less cardiovascular complications. Till now, HbA1c is the golden standard for the control of the diabetes. Nowadays, with the advent of the continuous glucose monitoring, we have another parameter that is target in range. 1 in 11 adults living with diabetes. Adults with diabetes is expected to reach by 113 million by 2030 and 151 million by 2045. Over 1 in 2 adults living with diabetes were underdiagnosed. 7,47,000 deaths are caused by diabetes in 2021. So in diabetes, India ranks second when in the list of the countries with the largest number of adults with diabetes in 2021, and it is anticipated to remain so in 2020 and 2045 as well. So 46.7% of the type 2 diabetes are under age 40 years. 40% of the type 2 diabetes are between 41 to 50 years. The most comorbidities associated with are hypertension, which is seen in 23% of the people, obesity in 26% of the people, and dyslipidemia in 27% of the people, and most common complications which are associated are heart disease and renal disease. So what are the unmet needs in the type 2 diabetes? It needs a combinational approach to address multiple pathophysiological mechanisms of hypoglycemia, the treatment that provide both glycemic and non-glycemic benefits. And most important aspect, for the quality of life to improve, there should be always a reduced occurrence of the hypoglycemia or weight gain. And there should be the improve the compliance and adherence of the patients to the therapy. So amidst the rising wave of type 2 diabetes in India, a dynamic solution that not only tackles the unmet challenges, but also embraces the intricate dance of comorbidities in the real of diabetes, a true metabolic symphony to bring the patients in range is required. So coming to our topic, glycemic variability and time in range, what is the role of this dapagliflozin and sitagliptin in keeping patients in range? This is the time in relation which compared the all-cause mortality in patients with diabetes. So in this, the time in range was measured with continuous glucose monitoring at baseline, and the participants were stratified into 4 groups by time in range, that is more than 85%, 71 to 85%, 51 to 70%, and less than 50%. As you can see, the all-cause mortality if in patients who are in time in range, it is less, and who are in whom the time in range is less than 50%, the mortality is more. In conclusion, this study found a strong and graded inverse relationship between the time in range and risk of all-cause cardiovascular mortality among patients with type 2 diabetes. These findings suggest that patients with diabetes should be encouraged to aim for an achievable higher time in range to reduce the risk of adverse clinical outcomes, and the goal should be individualized. So, the effects of sitagliptin on 24-hour glycemic changes in patients with type 2 diabetes assessed using continuous glucose monitoring. You can see the amplitude of glucose excursion with pre-treatment and after sitagliptin treatment, the period of hypoglycemia and percentage period of hypoglycemia. With sitagliptin, the patients experiencing the hypoglycemia is very less. The glucose excursions, the percentage of hypoglycemia and hypoglycemia were all significantly decreased after sitagliptin. So the effect of dapagliflozin on mean amplitude glycemic excursion, as you can see, this red line indicates the placebo group and blue line indicates the dapagliflozin group. These are the patients who are at the baseline. Once after the treatment is started, compared with the control group, patient in dapagliflozin group exhibited reduction in 24-hour mean blood glucose and lower mean blood plasma glucose concentration. The achievement ratio of time in range more than 70% in the sitagliptin and dapagliflozin group in all body mass index subgroups at 24 weeks after treatment. You can see for lower BMI group, the sitagliptin group showed a significantly higher time in range. In higher BMI group, the achievement ratio of time in range is more than 70% in dapagliflozin group. But in moderate BMI group, that is 25 to 30 kg per meter square, there is no significant difference noted between the two groups in the achievement ratio of time in range more than 70%. Shielding hearts in type 2 diabetes, till now we have seen the beneficial effect. There are twofold advantages in the management of type 2 diabetes, both cardiovascular and diabetic control. So a large proportion of patients with type 2 diabetes have cardiovascular disease. Globally, approximately 1/3 of the patients with type 2 diabetes have cardiovascular disease. Patients with type 2 diabetes and cardiovascular disease have increased risk of other complications when compared to patients without CVD, that is MI, stroke, heart failure and CKD. The cardiovascular disease occurs early and is the leading cause of mortality in patients with type 2 diabetes. So these are the past years which have been increased evidence of dapagliflozin from 2019 after the generic approval of dapagliflozin metformin approval, and in 2022 July there is a generic approval of dapagliflozin with sitagliptin, and nowadays every guideline is also suggesting. So dapagliflozin foundational therapy across the range of ejection fraction in patients with heart failure. You can see at different levels of heart failure, the glycemic control is quite good with diabetes, with dapagliflozin. Association between sitagliptin and heart failure, this is a secondary analysis from the TICOS trial. With sitagliptin, there is no increased risk of heart failure. So effects of DPP-4 inhibitors on ASCVD risk in type 2 diabetes, there is a significant mean reduction, that is minus 1.56% in ASCVD risk group was found among patients on DPP-4 combination. Significant effect on DPP-4 inhibitors on reduction of hospitalization, lipid profile and also ASCVD risk profile of type 2 diabetes regardless of other clinical comorbidities. So ADA guidelines in 2023 has approved SGLT2 inhibitors can be used in patients with pre-existing cardiovascular disease. Guardians of renal health in type 2 diabetes, this dapagliflozin and sitagliptin, as in the previous talk by Dr. Arvind sir, he also told that sitagliptin protects renal glomerular endothelial cells against high glucose dysfunction and injury. It has a protective role on the vascular cells in the renal tissue to counter the high glucose induced stress. This sitagliptin has a high beneficial effects in the prevention of diabetic nephropathy and could be used for preventing diabetes related renal complications. So does dapagliflozin compared to placebo reduce the risk of kidney failure and cardiovascular events in CKD patients with or without diabetes? The answer is the DAPA-CKD. In DAPA-CKD, dapagliflozin compared to the placebo significantly reduced the risk of kidney failure, CV death, hospitalization for heart failure, and all-cause mortality in patients with CKD with or without diabetes. Dapagliflozin is well tolerated in keeping with its established safety profile. So the KIDCO in 2002 recommends SGLT2 as a first-line therapy in diabetes with CKD. So the SGLT2 inhibitors with DPP-4 inhibitors, a double benefit in the management of type 2 diabetes. So this is a 24-week multicentral randomized double-blind placebo-controlled trial. HbA1c after the combination therapy, there is a reduction of HbA1c by 0.5 and the fasting plasma glucose level come down by 24 milligrams. So the combination achieved better glycemic control and greater weight reduction without increasing the risk of hypoglycemia and urinary tract infection in patients with inadequately controlled type 2 diabetes. So increased safety with addition of DPP-4 inhibitors to SGLT2 inhibitors. Nowadays there has been so many studies because previously SGLT2 inhibitors increases the, we have the concept of increasing the mycotic infection, but after the addition of DPP-4 inhibitors, the incidence of genitourinary tract infection also favors the use of the fixed drug combination. So overall, the rationale for the use of dapagliflozin plus sitagliptin, we have good it is weight neutral, it has better glycemic control, it is cardioprotective, and it has renal protection, and the time in range which it reduces the risk of hypoglycemia, so the time in range is also quite good. The pathophysiological approach using combination therapy with the combination known to address the established complication in type 2 diabetes. Both of these class of medication are associated with the lower risk of hypoglycemia, thereby improving the patient's quality of life. So with this I conclude. Thank you.
Thank you very much, Dr. Manidipti. You very well combined the previous two talks about the sitagliptin and the SGLT2 inhibitor, which has a very beneficial effect when it's combined and used. And you touched upon a very important concept of the glucose variability and the time in range, where not only concentrating on the HbA1c, where these two molecules are more focused, and the glucose variability is much more lesser than compared to when it is used single or monotherapy. Any questions, ma'am, you have?
Yeah, thank you for the talk and giving in-depth knowledge on that. I want to know, with this, have you kind of monitored the time in range with the CGM with your patients, and how much have you practically, seen it?
Practically, in my experience, I have not kept the CGMS for dapagliflozin and sitagliptin. This is only from the trials I could see. But insulin, obviously, we'll put CGMS in them. The time in range is quite useful, because once one patient experiences hypoglycemia, he will be obviously every time he will be worried that when he may get hypoglycemia. With this combination, we can be quite assured that the risk of hypoglycemia is very less to the patient. That assurance we can give to the patient, because most of the patient will be worried about the hypoglycemia, because most of them will be having some comorbidities and they will be elderly. So at night they may be staying singly. So in them, with this combination, obviously there is a less risk of hypoglycemia.
With SGLT2 and DPP-4 as such, hypoglycemia is not much. But I think in time in range, we are more worried about the hyperglycemic status.
Yeah,
so how are we monitoring that? And have you done that?
That can be done with
7-point GRBS or something like that.
Continuous glucose monitoring only, that we can do that thing.
Okay, thank you. Anybody else for any questions open? Okay, with this, I think we'll go to the next speaker. Thank you. I think we'll take up the next session now. I think I thank Dr. Anand Raman, for conducting this session, and also thanking him for giving me this opportunity. I think all the people who have come here, no need any introduction about him. For the few of them who have come here, consultant endocrinologist and co-founder of Magna clinics for obesity, diabetes and endocrinology at BTM second stage. Is a visiting consultant at Motherhood, Cloud9 and Chennai Mission Hospital. He's a faculty in various diabetes and endocrinology conferences, and he has more than 30 publications to his credit. And he would be actually giving us a talk on a novel vaccine to prevent zoster. Why zoster? I think in all of clinical practice we have seen that herpes zoster is there, and with the emerging increase in population in the elderly beyond 60 years, there's a recurrence or resurgence of again exhausted